at Gmail. And I'm on Twitter.
I'm saying we don't have to. That's the thing. Not your problem. We can finish Wednesday, Friday.
Yeah, man. Yeah, sure.
Hopefully it's recording.
Here, we gotta stand in front of this and get a selfie too, Ashish.
Okay.
This is proper form. We stand here. Let's see if we can get the screen to show up. And that's not YouTube. Ah, that's the struggle's real. All right. Awesome.
Okay. So it's 8 o'clock. So I think we'll start so that we can finish up all the cases. People are going to trickle in. First we should thank Jared for agreeing to that at the last moment, because he had a very, very busy schedule this week. He's been traveling from California to Little Rock to California to New York, and now back to Little Rock tomorrow. So it has been a very, very hectic week. So thank you, Jared, for agreeing to do this at a short notice. So without much ado, let's start with the 100 cases. Hopefully you guys, did you see those cases online? Yeah, so these are all digital slides, so it's very easy to see off the cloud. So we're going to start with case 1. So with case 1, I keep, whenever we're talking up to the residents, we always tell them that you should always have a format of approaching a slide, pathology slide. So just don't jump to a diagnosis. Try to always develop some type of a plan in your mind that this is how I'm going to approach a skin pathology slide. So you always start from the top and then you go to the bottom actually. So do I see any changes in the stratum corneum? Do I see any changes in the epidermis? Then you go to the dermal epidermal junction, then you go to the dermis, and then you go to the subcutis. If you follow that format every time, it will make your coming to a differential diagnosis much, much easier rather than jumping to what is the diagnosis actually. So following that format here, if we start from the top, we zoom in and start from the top, it is almost like a basket view hyperkeratosis, but the epidermis is showing all these spongiotic changes. So by spongiosis, the word spongiosis means edema of the epidermis actually. So edema is collection of fluid. So what we see is collection of fluid in between the keratinocytes. So that is, you can see these keratinocytic, they are separated out. And when the edema becomes quite intense, you'll start forming these vesicles actually. So there's quite a bit of spongiosis of the epidermis with vesiculation. If you look at the dermis, you have a superficial perivascular lymphocytic infiltrate. You might have some eosinophils, or the eosinophils are not always present, but if they are present, it's good. So basically, the reaction pattern that you're seeing here is an eczematous process or a spongiotic dermatitis. And because of the acute reaction, it is an acute spongiotic process. And the prototypical lesion for an acute spongiotic process is allergic contact dermatitis. So in allergic contact dermatitis, when the patient has been exposed to something, then they are going to develop these spongiotic changes in the epidermis with vesiculation. But you have to always remember, many times in the report, you're just going to get a spongiotic dermatitis as a report basically, and it can be related to a lot of different things. So there's a paper about spongiosis, and the way it goes is spongiosis can be caused by 800 things actually. So this pattern can be seen in dyshydrotic eczema. This pattern can be seen in nummular eczema. So a clinico-pathological correlation is very important when you're talking about any eczematous process actually. If this was an acral site, then more likely it would be dyshydrotic eczema basically. If the clinician says that these are nummular lesions, then most likely these are coin-shaped lesions, then it is most likely going to be nummular eczema. The irritant contact dermatitis is going to show more. Based on the pathophysiology, the irritant contact is because something is irritating the epidermis. So based on that, what is the changes that you're going to see in the skin are going to be some changes that will tell you that something is irritating the epidermis. On the top, you're going to see some dyskeratotic cells and also some neutrophils. So if you see those, then you think of irritant contact dermatitis actually. So you have to do a clinico-pathological correlation to come to a definitive diagnosis in an eczematous process. Otherwise, most of the times, the report that you're going to get is spongiotic dermatitis. It could be acute, it could be subacute, or it could be chronic. When it becomes chronic, the patient has been scratching a lot, and so because of the scratching, the epidermis is going to react in a certain way. So it is going to become acanthotic. The dermis is going to show you some fibrosis. So if you start seeing those changes along with mild spongiosis, then you think of a chronic eczematous process actually. So this was the prototypical type of allergic contact dermatitis. Moving on to case 2. So what do we see here? So again, follow the same pattern.
You mentioned that in delivering contact dermatitis, you have
This keratotic cells.
how would you differentiate that with IV? With the both
The most important thing, the other thing that you would see is a lot of eosinophils in the epidermis when you're thinking of IP actually. So coming on to slide 2. So again, when we start from the top, what do we see? We see a lot of confluent parakeratosis. You can see that the paraker is quite confluent. And then if you zoom in high power, you're also going to see some neutrophils, abscesses in the stratum corneum. The epidermis is slightly acanthotic and it shows this psoriasiform hyperplasia. And by psoriasiform hyperplasia, what do you mean is that you see the elongated bulbous rete-ridges actually. So you see that if you look at the parakeratosis, just below the parakeratosis, you see loss of granular layer. There is thinning of the suprapapillary plates. So suprapapillary means this is the dermal papillae, and the part of the epidermis above the dermal papilla is the suprapapillary. So the thinning of the suprapapillary plates. And when you look at the dermal papillae, you're going to see this increased capillaries actually. So all these features are pointing towards psoriasis actually. So this is a very prototypical slide for psoriasis. So if you go back and what are the changes that you want to see in psoriasis, that what is the one change that is always present in psoriasis is the presence of neutrophils in the stratum corneum. If you don't have that, then we can just call it psoriasiform dermatitis. You cannot say like this is compatible with psoriasis, because if you look at lesions of gutted psoriasis, you might not see any of the changes that we talked about: the parakeratosis, the psoriasiform hyperplasia, the thinning of the suprapapillary plates, because all that takes a little time to develop actually. So in gutted psoriasis, which is a very acute process, the only thing that you're going to see that points that this is psoriasis is the presence of the neutrophils in the stratum corneum. So that is a very important feature to look for whenever we are thinking of psoriasis or psoriasiform reaction pattern. So confluent parakeratosis. The other thing to remember is psoriasis will only be biopsied if the patient is not responding to the treatment actually. Otherwise, for a dermatologist to make the diagnosis of psoriasis is very easy actually. So he or she is not going to biopsy that lesion. So whenever you're going to get a biopsy in real life, those are patients that have already been treated with psoriasis. So you might not see all the changes that have been described in a classic lesion of psoriasis. So when we talk about classic changes, you talk about confluent parakeratosis. But that might always not be present because the patient has been treated or is not responding to the treatment, so that parakeratosis is not confluent enough actually. So you're going to see stop and go of the parakeratosis. A very important feature to look for is, where do I see the loss of the granular layer? The loss of the granular layer is always below the parakeratosis. So if you have stop and go parakeratosis, you're going to see the loss of granular layer just below wherever you see the parakeratosis. And beyond that, you're going to see again normal granular layer. So you might see normal granular layer, loss of granular layer based on if the patient has been treated prior to taking the biopsy. So in a very classic case, confluent parakeratosis, very important, the presence of neutrophils in the stratum corneum, the loss of the granular layer, the psoriasiform hyperplasia of the epidermis, thinning of the suprapapillary plates, increased capillaries in the dermal papillae, and then a superficial perivascular lymphocytic infiltrate. Those are all the features that you want to look for whenever you're thinking of psoriasis actually. You might also see some neutrophilic abscesses in the epidermis. That is not uncommon, but that is not always present. But yes, you'll always see the neutrophilic abscesses in the stratum corneum. And another thing to remember in psoriasis is the pathophysiology, that the skin is multiplying the epidermis is multiplying much faster than normal actually. So you might see increased mitosis in the epidermis. That doesn't equate to actinic keratosis, because whenever you see increased mitosis, you might think maybe I'm dealing with actinic keratosis. You're seeing the parakeratosis on the top. But again, remember the pathophysiology of psoriasis, because of increased proliferation, you might see some mitosis that might bring up the differential diagnosis of AK, but it can be present in psoriasis actually. So psoriasis, case number 3. So following the same pattern, we start from the top. So what do we see? We see some normal stratum corneum, and then you see these very nice parakeratosis that appears like a mound actually. So these are like small hills of parakeratosis that you see. A very, very important word that you're going to see in this differential, whenever you're thinking of this diagnosis, is this mounds of parakeratosis. So you see this mounds of parakeratosis, one mound here and another mound here. The epidermis shows mild spongiotic changes. So you can see there is increased spaces between the keratinocytes. So there is mild spongiosis in the epidermis. And in the dermis, you see a superficial perivascular lymphocytic infiltrate. You might see some eosinophils, but they are not always present. You don't have to have them for this diagnosis, but if you see them, it is good. It is okay, like it is, you don't need them for the diagnosis. But the other feature that most of the books are going to describe is the presence of red cell extravasation in the dermis. So mounds of parakeratosis, mild spongiotic changes in the epidermis, superficial perivascular lymphocytic infiltrate plus or minus eosinophils, and red cell extravasation. So if you see all these features, then you're going to think of PR actually. So very classic pityriasis rosea is going to show you all these features actually. If you see eosinophils, another thing to think of is a pityriaciform drug eruption. Sometimes a drug eruption can look very much like PR. In that one, you're going to see more eosinophils than you would normally want to see in PR. If you see that, at least that thought should go through your mind. Maybe this is a PR like drug eruption actually. Otherwise, very classic PR. So mild spongiosis, the parakeratotic mounds, the superficial perivascular lymphocytic infiltrate, the extravasated erythrocytes, and sometimes admixed eosinophils. Moving on to the next case. So even on low power, we know we are dealing with something that is very lichenoid actually. So you see this so what do you mean by lichenoid? Lichenoid infiltrate is, that is an infiltrate of lymphocytes that is hugging the dermal epidermal junction. You have to make sure that you don't mix up lichenoid with a superficial perivascular lymphocytic infiltrate. I've seen that happen quite often actually. Because if the infiltrate is quite dense, people then consider that as a lichenoid infiltrate. The lichenoid infiltrate, the basic definition is the infiltrate is hugging the dermal epidermal junction. So it has to almost like obscure the dermal epidermal. If you see that, then you're thinking of a lichenoid infiltrate. Now, when you think looking at a lichenoid infiltrate, your differential diagnosis narrows down quite a bit actually. Either I'm dealing with lichen planus, or I'm dealing with lichen planus like keratosis, or I'm dealing with a lichenoid drug eruption. Those are the only three things to think of. So how do you differentiate between the two? The most important thing is going to be history. But many times you're not given the history. So in the history, like if they tell you it's a single lesion, then most likely it's a lichenoid keratosis. If they say it's a rash, then it could be a lichenoid drug eruption, or it could be lichen planus. So in lichen planus, like if you listen to all the big people like Elston and all that, they say that lichen planus is like a restrictive parent actually. And what do they mean by that is that you do not have any parakeratosis in lichen planus, and you do not have any eosinophils in lichen planus. But in pathology, what we have learned is that you never say never, because the moment you say never, the next case is going to show it actually. But that is what has been described. No parakeratosis in lichen planus and no eosinophils in lichen planus. So here we don't see any parakeratosis. But if I go high power and start looking in the infiltrate, there is the eosinophil actually. I already like highlighted the eosinophil, so there is the eosinophil actually. So if I see the eosinophil, then most likely this is going to be a lichenoid drug eruption. If I didn't see that, then it would be a lesion of lichen planus. So here's one eosinophil, here's the other eosinophil actually. So I can like, if I could, so whenever you get a slide out like this to look at, the most important thing is to go high power and then scan the dermal epidermal junction very carefully to look for any eosinophil. If you see that, then you pick lichenoid drug. And if you don't see that, then you pick lichen planus. So lichenoid drug eruption, everything that looks like LP plus eosinophils. So moving on to the next case. So what do we see here? You see a big pustule that is composed of neutrophils. So you see so the pattern, if the reaction pattern that this would fall under would be a subcorneal neutrophilic pustulosis, basically. So you're going to say this. So whenever you see a subcorneal neutrophilic abscess, there should be a list of differential diagnoses that goes through your mind actually. So what am I dealing with? Am I dealing with pustular psoriasis? Am I dealing with acute generalized exanthematous pustulosis? Am I dealing with Sneddon-Wilkinson syndrome, or am I dealing with IgF empficus? Those are the four main differential diagnoses whenever you see something like this, where you see a big neutrophilic abscess in the stratum corneum. So, and many people consider pustular psoriasis and AJAP as a spectrum of the same disease actually. So like if you talk to any of the older people that have been practicing dermatopathology for quite some time, like Dr. Phelps, who's my boss, who's been practicing dermpath for 25 to 30 years, he considers AJAP and the pustular psoriasis as one disease actually, and they are just spectrums of the same part. But for the newer generation, I think they take them as separate entities actually. So that you might find people that say they are the same disease, and you might find people that. So how do you differentiate between AJAP and pustular psoriasis? So again, you have to think about what would you see in psoriasis. Normally, you're going to see loss of granular layer under the neutrophilic and under the paracrine. So do I see any loss of granular layer actually? Do I see any thinning of the suprapapillary plates? If I see all those features, so here if I go high power, I don't see any granular layer below the neutrophilic abscess. And if I go and look in the dermis, I'm going to find the eosinophils. So if I see the eosinophils and I see the neutrophilic, subcorneal neutrophilic abscess, my most likely diagnosis that I need to pick is AJAP actually. So acute generalized exanthematous pustulosis is going to be subcorneal pustular neutrophilic abscess plus eosinophils in the dermis. But remember, some people might still call that pustular psoriasis. Pustular psoriasis is the only variant of psoriasis that Whedon describes can have eosinophils actually. So if you go and read up Whedon, you'll see that in that pustular psoriasis, he says that they can have some eosinophils. So there is a lot of overlap between pustular psoriasis and AJAP. But if this was on the board exam, then the thing to pick would be AJAP actually, if you see the eosinophils. Sneddon-Wilkinson, you need more history to make the diagnosis, but again, you might not see the eosinophils. And for IgF empficus, you need immunofluorescence to make the diagnosis. Otherwise, all of them are going to show you very similar histology actually. So AJAP. Moving on to the next case. If you have any questions, please don't hesitate to stop me, and because the main thing that you should take from this 3R thing is what are my differential diagnoses whenever I see some slide, not what is the diagnosis. Because on the board exam, you're not going to, or on any exam, you're not going to get the similar slide. So the thought process is what is more important to take out of this room. That when I see this, should be my thought process of approaching a slide basically. So again, what do we see here? If we start from the top, we see a very normal looking stratum corneum. But when we look at the epidermis, what do we see here basically? You see a lot of dyskeratotic cells actually. So you see dyskeratotic cells in the epidermis, and at the dermal epidermal junction, there is some sort of vacuolar interface changes. So you are seeing again, the reaction pattern is now vacuolar interface dermatitis with dyskeratosis. So again, once you have thought of that, your differential diagnosis narrows down quite a bit actually. So now I'm dealing with something that is a vacuolar interface change, and that is dyskeratosis. So my list of differential diagnoses is either I'm dealing with erythema multiforme like reaction, I'm dealing with acute graft versus host disease, or I'm dealing with a fixed drug eruption. Those are the only three differential that you need to think of. Sometimes a photoallergic or a phototoxic might show the similar changes, but then you won't see the vacuolar interface changes. You are going to see the dyskeratosis, but you won't see the vacuolar interface changes. So if you see vacuolar interface changes with dyskeratosis in the epidermis, am I dealing with erythema multiforme, acute graft versus host disease, or a fixed drug eruption? So what would you see in erythema multiforme? Like if you start from the top, because it is an acute process, you're going to see the basket weave hyperkeratosis. I'm going to see some dyskeratosis in the epidermis. It could be in all layers of the epidermis. And then in the at the junction, I'm going to see vacuolar interface changes, and in the dermis, I'm going to see a superficial perivascular lymphocytic infiltrate. If it is related to some drug, I might see some eosinophils basically. So those are the features that I'm going to see, and if I see that, then most likely I'm either dealing with most likely erythema multiforme. If it was fixed drug eruption, what would you see actually? How would you differentiate this from fixed drug? We have a slide, I think, coming up for fixed drug, so we can talk about that when we talk about fixed drug. But In what would you see in acute graft versus host disease? How would it differ from this? Most likely, there might not be much difference actually. But whatever cases we have seen mostly don't show the amount of dyskeratosis in graft versus host disease that you would see in erythema multiforme. So one is the degree of dyskeratosis, but you can't use that in the board exam. In real life, yes, that might help because most of the times the degree of dyskeratosis that you see in erythema multiforme is not is quite high compared to what you would see in graft versus host disease. If you look at Whedon and McKee, they talk about hypergranulosis in graft versus host disease. So sometimes people use that if you see some hypergranulosis, that is more likely. And then the most important feature that Dr. Prieto, my mentor, taught me was dyskeratosis involving the follicle. So if I see dyskeratosis involving the follicle, then more likely I'm thinking of graft versus host disease rather than erythema multiforme. So if they give you a follicle that is showing you some dyskeratosis, then most likely that is graft versus host disease rather than erythema multiforme. So many times the distinction is not that easy. People struggle a lot. Then the clinical history in real life, it's very easy. Pick up the phone, talk to the clinician. How is the patient presenting? Is there any history of a transplant or anything? And then the diagnosis becomes much easier. But if this was on the board exam, yes, you have to start thinking, how would I differentiate? So look for hypergranulosis, look for any dyskeratosis involving the hair follicle. What is the degree of dyskeratosis? And hopefully that will help you differentiate between the two actually. The satellite cell necrosis is always associated with this. Like whenever you see dyskeratosis, you're going to see some lymphocytes, and that some people call that satellite cell necrosis. Any of them would have going to show that. So preserve basket weave, because it is a very acute process, you're going to see dyskeratotic keratinocytes at all levels. The vascular interface changes, the superficial perivascular lymphocytic infiltrate plus or minus eosinophil actually. So next case here. So again, what do we see here? We see a normal looking stratum corneum. And then again there's a lot of, these are, you can see this dyskeratotic keratinocytes. So this pink keratinocytes that you see, this pink cytoplasm, the pycnotic nucleus is what is called as a dyskeratotic keratinocyte. So you see those. So again, now I'm in the same differential diagnosis. But here, what is different here? What do we see in the dermis here? You see a lot of pigment incontinence. So you see a lot of pigment incontinence, and there is some sort of dermal fibrosis actually. So I've heard Dr. Elston talk about acute on acute and acute on chronic. So when you see acute changes in the stratum corneum and acute changes in the dermis, that is acute on acute, that favors erythema multiforme. When you talk about acute and chronic, means acute changes in the stratum corneum and chronic changes in the dermis. Because how does fixed drug present actually? So it is a reaction that is occurring at the same place every time the patient takes the drug actually. So the reaction will happen, the patient discontinues the drug and the reaction goes away. So the epidermis will again show, when it again happens, that the epidermis is going to show you the acute changes. But the dermis doesn't, it still has some remnants of the previous attack basically. So you are still going to see some dermal fibrosis and that pigment incontinence that is telling you that the reaction had happened before. So that is called acute on chronic. So if you see the pigment incontinence, if you see dermal fibrosis, if you see some eosinophils, you are going to favor a fixed drug eruption rather than erythema multiforme. So acute on acute and acute on chronic. By the chronic, I mean the chronic changes in the dermis, which is some mild dermal fibrosis and the pigment incontinence and some. And usually the other things that most books describe is the infiltrate in fixed drug eruption goes a little bit deeper than erythema multiforme. Sometimes that might help actually. If you see the infiltrate going a little bit deeper, that is also in favor of. So remember, like there is not one feature that, so you can use that as a cookie cutter basically. You have to look at the entire thing in like, what do I see in the stratum corneum? What do I see in the epidermis? What do I see in the dermis? And try to put the whole picture together to come up with a diagnosis actually. So this is an example of a fixed drug eruption. So acute stratum corneum, the necrotic dyskeratotic keratinocytes, the vascular changes, pigment incontinence, and then the papillary dermal fibrosis, and then you might see the eosinophils, and then that makes it easy that this is a fixed drug eruption. So here again we start from the top. The stratum corneum looks pretty normal. the epidermis looks a little bit atrophic actually. It looks a little bit atrophic epidermis, but what do you see at the dermal epidermal junction? We see a lot of vacuolar interface changes. So you are again in that same chapter or reaction pattern, vacuolar interface dermatitis. So the first question, do I see any disc keratosis? There is no disc keratosis here. So the other differential diagnosis that we talked about are gone basically. So what is the other feature that is very striking on low power? Is this dense limb infiltrate. So you see a very dense infiltrate which is around the follicles actually. So you see a vacuolar interface change with a dense infiltrate that is perivascular and perifollicular actually. So if you go high power, so whenever you see an infiltrate in the dermis, you fly in and look at the players that, like, if you have heard Rapini, that is what he says, fly in and look at the players actually. So if you look at the players, this is mostly lymphocytes. I don't see any eosinophils actually. So it's a perivascular and a perifollicular infiltrate of lymphocytes with a little bit of atrophic epidermis and vacuolar interface changes at the dermal epidermal junction. So what is your differential diagnosis here now? Lupus or connective tissue disease. So you're going to think of connective tissue. So what are the features that you want to look for? You might see other very characteristic feature that you see here is follicular plugging actually. So you see follicular plugging, you see the vacuolar interface changes, you see the perifollicular lymphocytic infiltrate and the perivascular. If I did a PAS, the PAS is going to show me thickened basement membrane at the dermal epidermal junction. And if I did a mucin stain either with Alcian blue or colloidal iron, I'm going to see increased mucin in the dermis actually. So then with all these features, this is described lupus. So lupus vacuolar interface changes, the perivascular and the periadnexal lymphocytic infiltrate, the increased dermal mucin, and then basement membrane thickening. Moving on to the next one. So again, we start from the top. So pretty normal stratum corneum. The epidermis also looks quite normal. If you look at the dermal epidermal junction, I don't see any vacuolar interface change or a lichenoid infiltrate. But in the dermis, what do I see in the dermis? We see a perivascular infiltrate actually. So we see all this perivascular infiltrate, which is quite, so whenever you see this infiltrate, now you have to again go in and look at the players basically. So what do I see actually? So it's predominantly lymphocytes, but we see a lot of eosinophils. So then your diagnosis becomes very easy. So this is a predominantly perivascular inflammation in the dermis with a lot of eosinophils. So your list of differential diagnosis narrows down quite a bit actually. So I'm either dealing with drug, I'm dealing with bug, or I'm dealing with the urticarial phase of BP. Those are the three main differential diagnoses to think of whenever you see perivascular dermatitis with eosinophils. So drug, bug, or urticarial phase of BP. Yes, Wells can show you the similar picture. Churg-Strauss might sometimes show you a similar picture, but those are not very common diagnoses that like whenever you're thinking of in dermatopathology, don't go to the zebras first actually. Always think common things first. Yes, the zebra should always be in the back of your mind, but you shouldn't be jumping to those diagnoses immediately. Like, am I dealing with Wells? Am I dealing with Churg-Strauss? Because those are not very common diagnoses, and even for an experienced dermatopathologist, many times that needs a lot of clinical pathological correlation to make the diagnosis actually. So common things would be drug, arthropod bite, which could be just even scabies, or it could be like an urticarial phase of BP. And for the urticarial phase of BP, you need immunofluorescence to make the diagnosis. But one very characteristic feature that has been described, if you're thinking of urticarial phase or prodromal phase of BP, is the presence of eosinophils going into the epidermis or lining up the dermal epidermal junction. So if you see eosinophils that are lining up at the junction or going into the epidermis, you're most likely dealing with some sort of a vesicular bullous disorder. In arthropod bite, the other thing that we have seen that has not been described in books is the infiltrate tends to go even into the subcutis. So many times I will see the eosinophils even in the subcutis. If I see that, most likely I'm dealing with an arthropod bite. But these are like features that help you come to to pick some, if there are two very close diagnoses, if one of these are present, then you might favor one. Remember, this can happen in all three of them. But just to favor one, you might use some of these features. So this is a nice prototypical example of a drug eruption. So moving on to the next case. So here the important thing at low power or when you're looking at the slide is to understand where the location is, because with that you are going to be able to make the diagnosis here. So what is the location of this biopsy? Acral site basically, because why do we see acral site? Because of the presence of this hyperkeratosis that you see on the top. So this is a acral site biopsy because of the presence of this thick hyperkeratosis on the top. And then if I look at the changes, like do I see any much changes in the epidermis? There is mild acanthosis, but not much actually, and this might be normal for an acral site. So do I see any vacuolar interface changes at the dermal epidermal junction? Not much, because it looks pretty normal, dermal epidermal. But what do I see in the dermis? You see a little bit of edema in the papillary dermis, and then you see a perivascular lymphocytic infiltrate. So you can see this is composed predominantly of lymphocytes. There are not many eosinophils here. You might sometimes see them, but usually they are not present. So there is not much of so it's predominantly a lymphocytic perivascular infiltrate. And if you look at the inflammation, it is going quite deep actually. And very characteristically, if you look at these eccrine structures in the base of the biopsy, the lymphocytes also tend to involve these eccrine structures actually. So you see this lymphocytes involving the eccrine. So it's pericrine, it's perivascular, acral site. So first of all, like if you see a perivascular and a periadnexal inflammation, you always first the common thing to think of would be lupus actually. So again, you're going to think of connective tissue disease. But now this is an acral site, and if I did a mucin stain, most likely it's going to be not increased mucin. So what would be a differential diagnosis? Perniosis. And remember that acral site is going to help you come to the diagnosis. So if you have to think of perniosis, think of acral site, papillary dermal edema, superficial and deep perivascular infiltrate, and then characteristically also involving the eccrine structures at the base actually. Sometimes even going into the subcutis. If you see all these features, then most likely you are dealing with perniosis actually. Again, there is quite an overlap with lupus. So if this was on the exam, they're not going to give you both of these, the differential diagnosis on the list, either perniosis or connectivity, because you need a little bit of history. You need to do the stains to differentiate between the two actually. But this is predominantly perivascular. It is not around the follicles. I see it more around the eccrine structures, but not around the hair follicles. So the papillary dermal edema would also raise the differential diagnosis. What is the other condition that can show you papillary dermal edema? Urticaria, polymorphous light. So it's very characteristically described with polymorphous light eruption. So perniosis and polymorphous light eruption are the two very characteristic features that are, and then sweets. So three things they always talk about papillary dermal edema: perniosis, sweet syndrome, and then polymorphous light eruption. The polymorphous light eruption is a reaction to the sun basically. So it is going to show you some changes in the epidermis more basically, some diskeratosis and all that. We don't see that here. This is an acral site, so that is you can rule that out. But you have to remember, whenever you see papillary dermal edema, three things to think of are polymorphous light eruption, sweet syndrome, and perniosis. So moderate to dense superficial infiltrate, and sometimes around the acrosyringiums, the papillary dermal edema, and then some. They have also described fibrin thrombi within vessels in some cases of perniosis actually. So moving on to the next case. Mm-hmm. That's what they describe actually. So, but remember, like vasculitis, I try to avoid that word because vasculitis has been described, and if you look at quite some of the books, they all talk about lymphocytic vasculitis in perniosis actually. But for me, like whenever I think of vasculitis, I don't want to give you that impression because vasculitis always comes with fibrinoid degeneration of the vessel wall. So that, yes, if you read in the books, they talk about lymphocytic, and what do they mean by lymphocytic vasculitis is there is some edema of the vascular wall with lymphocytes around the vessel. That is the definition of lymphocytic vasculitis. But whenever we are teaching, like we always emphasize the fibrinoid degeneration when you're talking about vasculitis. So it can get confusing actually. So better not to use the word lymphocytic vasculitis. But if you read in the books, they definitely talk about lymphocytic vasculitis in perniosis. And what do they mean by that? Is edema of the vessel wall with lymphocytes almost traversing the vessel wall. So moving on to the next case, if you look at the top, what do we see here? Some parakeratosis, hyperkeratosis. The epidermis is showing a lot of spongiosis with a lot of lymphocytic exocytosis. So whenever we're talking about lymphocytes going into the epidermis, it's called lymphocytic exocytosis. So when lymphocytes go into the epidermis, either it could be related to some sort of a inflammatory process that is attracting the lymphocytes into the epidermis, or it could be MF. So when you're talking about MF, you don't use the word exocytosis, you use the word epidermotropism. So when you're talking about an inflammatory process and lymphocytes going into the epidermis, it's called lymphocytic exocytosis. And when you were talking about mycosis fungoides or some atypical T cell infiltrate that is going into the epidermis, then you say lymphocytic epidermotropism. Actually. So in this one, it's mostly lymphocytic exocytosis because there's a lot of spongiotic changes also. What else do we see here? These are scattered. Dyskeratosis. So hyperkeratosis, parakeratosis, mild spongiotic changes in the epidermis, a lot of lymphocytic exocytosis, dyskeratotic cells within the epidermis, and then if you go low power, there is inflammation in the dermis actually, and the inflammation is also going deep. But how is what is the shape of the infiltrate? If you try to, it is almost like a wedge shaped actually. So you see a wedge shaped infiltrate in the dermis. And if I go high power and look at the infiltrate, it is only lymphocytes. There is no eosinophil in this one actually. And there are papers that have described that this diagnosis will not show any eosinophils in the dermis. So I normally would not want to see any eosinophils if I'm thinking of pleva actually. So this diagnosis is going to be pleva. So what are the features in pleva that you want to look for? Hyperkeratosis, parakeratosis on the top, sometimes some neutrophils, epidermal spongiosis, lymphocytic exocytosis in the epidermis, presence of dyskeratotic cells in the epidermis, and then this wedge-shaped lymphocytic infiltrate in the dermis with no eosinophils. Many times I always say never, you say never, but I think that this is the condition where you can say you don't want to see any. If you see eosinophils, then most likely you're dealing with some sort of a drug eruption. So pleva is the one condition that I've seen the papers that have looked at 500 cases of pleva and they haven't found eosinophils. So there is some sort of at least literature that goes and corroborates that actually. So if you see all these features, then the clinical history will also help you. It's usually young kids or teenagers which are developing this pustular reaction throughout the body actually. So pleva, compact hyperkeratosis, focal parakeratosis often with neutrophils, dyskeratotic cells in the epidermis, vacuolar interface changes, dense wedge-shaped infiltrate, erythrocyte extravasation, and neutrophils within dermal web. These are all the features. And when you go back, we'll share a copy of this presentation again with the slides and the presentation, so you can go back and again review the whole thing once over again. Actually. So moving on to the next case. So what do we see here? What is the striking feature here? Something is happening in the stratum corneum. So there is something, but and if you look at the epidermis, what is the pattern here? Regular psoriasiform. So you see a psoriasiform reaction pattern. So that is the bigger picture. This is in the psoriasis chapter actually. So you're seeing something that has a psoriasiform reaction pattern. So you see this bulbous retinoids. But now, whenever we think of psoriasis reaction pattern, first thing, do I see any neutrophils in the stratum corneum? So I go high power, but instead of neutrophils, what do we see here? We see this clearing or ballooning like degeneration of the stratum corneum actually. So you see this balloon degeneration or very clear looking stratum corneum. So if you see that with the psoriasiform hyperplasia, what is your main differential diagnosis? Acrodermatitis. So you're going to start thinking of zinc deficiency. If you see this very clear changes in the stratum corneum, where you see this very ballooning degeneration of the stratum corneum, there's another word, it's not coming to me, it's not ballooning. Ballooning degeneration is not the right word actually. It is called, sorry, but if you go and read, but there's a specific description of this change that you see here, where you see this clear, the cytoplasm looks very, very clear actually. It's not ballooning. Ballooning degeneration is more commonly described with ORF or something. Like some pox virus, and that is ballooning degeneration. This is or herpes or something. This is more like the stratum corneum looks quite clear actually. Maybe I have described it here. So psoriasis with pallor. So it is called pallor actually. Sorry. So the right word to use for that is pallor of the stratum corneum actually. So what you see here is so by pallor I mean that it is a little bit discolored. So you see a discoloration or pallor of the stratum corneum, very regular psoriasiform hyperplasia, and then in the dermis I see a superficial perivascular infiltrate actually. So if I see that the pallor is the thing that is going to push you to acrodermatitis enteropathic or zinc deficiency. But you also have to remember there are other conditions like pellagra or necrolytic acral erythema that are going to show you exactly the same histology. So when you see this histology where you see the pallor of the stratum corneum, psoriasiform hyperplasia, yes, the most common thing to think of would be zinc deficiency, which can occur in a child or it can occur in an older patient. But also the similar histology is going to be seen either in pellagra or you're going to see it in necrolytic acral erythema. So if this was on the board exam, they're not going to give you all three in the differential diet. It has to be only one of them because histologically it is impossible to make the differential diagnosis unless I get more clinical history that is this what am I dealing with actually. But very characteristic pallor should point you to acrodermatitis enteropathic. So psoriasiform dermatitis with pallor and ballooning degeneration, loss of granular layer and superficial perivascular mixed infiltrate. Moving on to the next slide. So again, if you start from the top, very normal looking stratum corneum. The epidermis also looks pretty normal. But in the dermis, what do we see in the dermis? There's some action going on in the dermis. So if you go high power, there's an infiltrate in the dermis that is composed of newts and some lymphocytes. So you see newts and lymphocytes. So whenever you see neutrophils in the dermis, the next question that should come to your mind is, do I see any vasculitis? So if you're thinking if it is a neutrophilic dermatosis or any neutrophils in the dermis, the first question always to ask yourself is, do I see any vasculitis? So you're going to go high power and then start looking around the vessels actually. So if I go to the vessels, so here is a vessel here. What do I see around the vessel here? I see the fibrinoid, pinkish. I see that pinkish, dark pinkish color, and that is what is fibrinoid degeneration of the vessel wall. So I want to see this with neutrophils traversing through the vessel wall to call it vasculitis. Just presence of neutrophils in the vessel wall doesn't equate to vasculitis. You have, like in tonsil, if you see neutrophils in the tonsil, it is tonsillitis. Or if you see anywhere else, it is like gastritis. You're going to see neutrophils in the stomach biopsy. But in the skin, just presence of neutrophils doesn't equate to vasculitis. You have to see the fibrinoid degeneration of the vessel wall to call it vasculitis. So you want to see fibrinoid degeneration plus neutrophils traversing the vessel wall. If you see that, then your diagnosis is going to be very easy. This is leukocytoclastic vasculitis. So in leukocytoclastic, as the word says, leukocyte. So leukocyte is the neutrophil, and the clastic means the breaking of the neutrophilic nuclei. So breaking of the neutrophilic nuclei will show you as dust basically. So that is what they call neutrophilic dust. So if I go high power, I'm going to see this blue dot scattered throughout the epidermis. This is the leukocytoclasia that is in the leukocytoclastic vasculitis. So when this nuclei break down, you see these blue dots and this in the dermis. So these are all scattered, broken down neutrophilic nuclei. Plus the presence of this fibrinoid degeneration, my diagnosis becomes very easy that this is leukocytoclastic vasculitis. Leukocytoclastic vasculitis can be caused by many things, so you don't have to go into the etiology. If I see some eosinophils, yes, I might say this might be related to drug, but most of the times we do not go into the etiology based on the histology. It is more of a clinical pathological correlation, like why is the patient on some drugs, does the patient have connective tissue disease, and that will tell you why is the patient developing leukocytoclastic vasculitis. But based on the histology, it is almost impossible to go to more definitive diagnosis. So you just say LCV and move on basically. So perivascular mixed infiltrate with neutrophils, nuclear dust, and the fibrinoid degeneration of the vessel wall is what you want to see for leukocytoclastic vasculitis. Moving on to the next case. So on low power, what is the striking feature here? There's a lot of hemorrhage happening. So if the hemorrhage is happening, something is happening to the vessels actually. So when you see this low power image, where you see a lot of hemorrhage in the dermis, what the first thing that should go through your mind is something is wrong with the vessels actually. So what could be wrong with the vessels? Either it is a vasculitis or it is a vasculopathy. Those are the only two things that can happen within a vessel. So if for the vasculitis, what do I need to see? I need to see the fibrinal degeneration that we talked about. And for vasculopathy, what would you see? Occlusion of the vessel. So those are the two things to think of basically. So now we are going to go high power and see what do we see here basically. So do I see any neutrophils or do I see any fibrinal degeneration of the vessel? Well, no basically. So at least that one is out. So then do we see any occlusion of the vessel? So what do we, all these are vessels actually. And you see this pink homogenized material that is filling up the vessel wall, and this can sometimes be highlighted very nicely with PAS actually. So whenever I see this, then I'm dealing with some sort of a vasculopathy actually. And this can be caused by a lot of different things. It can be caused by a lot of, but the most common thing that you're going to see on an exam is going to be cryoglobulinemia. So in cryoglobulinemia, you're going to see this pink hyalinized material within the vessel wall. So if it is type 1, I don't see any vasculitis. If I see something like this associated with neurovasculitis, then this is type 2 cryoglobulinemia. But you remember, this can also happen with some sort of coagulopathic disorders and all that. So in real life, we just can't call this like cryoglobulinemia. We have to get more history. But on the board exam, this is most likely going to be cryoglobulinemia. And this can be highlighted with a PAS 10 if you need to do that. So PAS positive glassy material in the dermal vessels, little or no inflammation in type 1, and then vasculitis in type 2 actually. So next case, what do we see here? There's some sort of a subcorneal pustule again. So you're dealing with some, and what else is happening here? So if you look at this here, acantholysis. So a split, and so acantholysis is very correct. You see this. What do I mean by acantholysis? Acantholysis is when the keratinocytes, they start breaking off basically, but they still maintain. So dyskeratosis is when I see this pink cytoplasm within the keratinocytes, and those are like necrotic or not even necrotic, but apoptotic keratinocytes. When you're talking about dyskeratotic keratinocytes, those are more single cell apoptosis that is happening of the keratinocytes. So the keratinocytes have started to die, and then the cytoplasm becomes very pink, and the nucleus becomes very pycnotic, and then slowly it will fall off. By acanthotic, when you talk about acantholysis, you're talking about the keratinocytes, the intercellular bridges, they are breaking off, and the keratinocytes become more rounded and they are separating out. But there is no necrosis or apoptosis actually. So here I see this keratinocytes, they are breaking off, and so this is acantholysis basically. So what I see is a subcorneal split with some neutrophils, and then acantholysis of the keratinocyte. So whenever you see a subcorneal split, your list of differential diagnosis is again going to narrow down quite a bit. So you have to, when you're talking of a vesicular bullous disorder, first thing to always think of is, where is the split? Is it within the epidermis or is it subepidermal? If it is within the epidermis, where is it in the epidermis? Is it subcorneal or is it suprabasal? So if you think always like this, your list of differential diagnosis is going to narrow down quite a bit actually. So this one is the intraepidermal subcorneal split. So when I'm thinking of intraepidermal subcorneal split, my list of differential diagnosis narrows down quite a bit. Am I dealing with pemphigus foliaceus? Am I dealing with staphylococcal scalded skin syndrome? Or am I dealing with bullous impetigo? Those are my three main big picture differential diagnoses. So if I see with the presence of these neutrophils, what does it point towards basically? Of the three differential diagnoses, which one would you favor if you see some neutrophils in the bulla actually? Bullous impetigo actually. So if you see that, so in staphylococcal scalded skin syndrome, the main feature would be a very clean split. So all you see in staphylococcal scalded skin syndrome is a subcorneal split between the epidermis and the stratum corneum, and nothing else. There's not going to be any neutrophils, and usually even the dermis is pretty clean. So if you don't see too much inflammation, you just see the subcorneal split, then you're going to favor staphylococcal scalded skin syndrome. If you see some neutrophils within the bulla with the acantholysis, and then even some gram-positive, sometimes you might see the gram-positive organisms within the neutrophils in the stratum corneum. So if you see all that, you're going to favor bullous impetigo. If you don't see the neutrophil, you see the split, you see acantholysis, you see a superficial perivascular infiltrate with some eosinophils, most likely that is pemphigus foliaceus actually, or pemphigus erythromatosus. But you have to at least get your the differential diagnosis narrowed down quite a bit, and then you are going to look for more subtle features to make your diagnosis. All of these are attacking desmoglein 1, and that is the reason you see the split at the why is the split happening at the stratum corneum. In bullous impetigo, the causative organism is staph, which is releasing an exotoxin that is attacking the desmoglein 1 actually. Even in Staphylococcus scalarius, that is the same thing that is happening, and in pemphigus foliaceus also, it is the desmoglein 1 that is being targeted actually. So that is the desmoglein 1 is supposed to be more at the upper layers of the epidermis, and so that is the reason you see the subcorneal split. It's mostly a split with acantholysis, and many times in the dermis you're going to see the superficial infiltrate actually, which is not seen in the Staphylococcus scalarius skin syndrome. So if you see the split with acantholysis then you see the superficial, then more likely pemphigus foliaceus. But remember, in real life, I need clinical history and I need the immunofluorescence to make the diagnosis. So I'm going to always do the immunofluorescence to see the intercellular pattern of immunofluorescence within the epidermis to make my diagnosis of pemphigus foliaceus. But yes, on the exam you have to start picking like what are the features that can help me. First, what is my differential diagnosis? That is what you should take out of this room. Like, what is my differential diagnosis for every entity? And then once you have your differential diagnosis, what are the subtle features that I want to look for to come to a specific diagnosis? That is more important than jumping to a diagnosis, or this is pemphigus foliaceus, or this is bullous impetigo. The thinking process is very, very important that you should take out of this room actually.
The subcorneal split and then seeing the
Bullous impetigo, more likely. So subcorneal bulla with few neutrophils, rare acantholytic cells, and gram-positive cocci may be seen. Thank you. Here within the bulla. So now we move on to the next case. So again, we are dealing with the, what are we dealing with here again? Okay, so we are dealing with a vesicular bullous disorder because most of the epidermis is gone basically. You can see like most of the epidermis is gone. What are we left with basically? We are left with just the lower part of the epidermis. Somewhere you see some more layers of the epidermis, and in some places only the basal layer that is still stuck to the dermis. The rest of the epidermis is sloughed off. So this is known as, so now you are again in a vesicular bullous disorder. So the split is intraepidermal, now suprabasal. So intraepidermal suprabasal split. Now what is your list of differential diagnosis? I'm either dealing with, most likely I'm dealing with pemphigus vulgaris, but also sometimes Haley can cause similar reaction pattern. But most likely I'm dealing with pemphigus vulgaris. So now how do you differentiate between the two actually? Yeah, so one, like the very characteristic feature, we have a slide of Haley. So the very characteristic feature in Haley is the dilapidated brick wall basically. So you're going to see the acantholysis completely throughout the epidermis from end to end actually. So that is one very characteristic feature of Haley. But the most important feature that everybody describes, every book describes, is the absence of follicular involvement in Haley. So here you can see the follicle here, and you see the nice involvement by the acantholysis. So once you see that, then Haley is out. So involvement of the hair follicle is very characteristically seen in pemphigus vulgaris and not in Haley. So if you see that, then so like the tombstoning is also more characteristically described in pemphigus, but there are cases of Haley that can cause the tombstoning. But on the board exam, it is usually going to be in the mid spinous layer. So if you see a split in the mid spinous layer, like a dilapidated brick wall with acantholysis, you are going to favor Haley. If you see the tombstoning and the suprabasilar split, then more likely you are going to deal with pemphigus vulgaris. And then if you see the follicle involved, everything is out. This is pemphigus vulgaris actually. And then if I do the immunofluorescence, you're going to see the intercellular IgG and C3 in the epidermis. Gerard, if there's something you need to add to it, just let me know. So pemphigus vulgaris intraepidermal split, the tombstoning is very, very characteristic. The follicular extension is very important to look for. And then the perivascular infiltrate, you might see EOs, you might not see the EOs. They are not needed for the diagnosis. If they are there, well and good. and then in the immunofluorescence you're going to see the IgG and C3. So now you're at the low power, you're going to, what do you see here? Yep. Yeah. So now this is very characteristic. You're going to look at the split, like it is more in the, it is intraepidermal, but where is the split even at low power? It's in the middle, it's in the spinous layer actually. So now you're dealing with something that is intraepidermal, but more in the spinous layer actually. So yes, there might be some areas where it is showing some tombstoning like here, but most of the split is in the spinous layer, and then you can see the acantholytic cells throughout the split actually. So a lot of acantholytic cells, a split that is almost going from end to end basically. So it is involving the entire epidermis. You see a split that is almost involving the entire epidermis from end to end, and it's more in the spinous layer, not suprabasilar. So what is your differential diagnosis now? Hailey-Hailey. So this is a biopsy of Hailey-Hailey. So in Hailey-Hailey, what we are going to see is a split that is end to end in the spinous layer called dilapidated brick wall. And what is the mutation involved here? 2C1. So remember, 2C1 is the one with Hailey-Hailey actually. Real life, the diagnosis is much easier because I'm going to pick up the phone and ask where are the lesions, how is the patient presenting. So then I get the history, interdigenous areas and all that, and my diagnosis becomes much easier. But on the board exam, you have to start thinking of what are the features that are going to help me differentiate this from pemphigus vulgaris. Actually.
Do you guys know how to remember the 2C1? I want to see Halley's Comet one day.
I want to see.
That's the way that my residents learn it. And, no one knows how to make better ways to remember things than derm residents.
I want to see Halley's Comet one. That's good actually.
2C1.
So now we are moving on to the next case. So now what is the reaction pattern here? So you are again dealing with something that is causing a split of the, and where is the split now? The split is subepidermal. So whenever you see a split at the subepidermis, so subepidermal split, now you're going to think of, so again you have to start, like I keep stressing this to my residents also, like you have to always think, now I'm in a subepidermal split. The next question I have to ask myself, do I see any inflammation or not basically? So is it cell poor or is it cell rich? If it is cell poor, a list of differential diagnosis is going to be different. If it is cell rich, then I ask myself, what is the kind of infiltrate that I see? Do I see eosinophils? Do I see neutrophils? Or do I see predominantly lymphocytes? So that based on that, then my list of differential diagnosis is again going to differ actually. So what do we see here actually? We see a lot of inflammation, and what is the kind of inflammation that we see here? Pardon? Eosinophils, but also a lot of newts actually. So for eosinophils, you want to see that orange color actually. We don't see that orange color. You see mostly multilobulated cells which are, so if you see the multilobulation, more likely these are neutrophils. Yes, on the digital slide, because these are scanned at 20x, it is not that well seen. If I scan that at 40x, it will be very well seen, but on a glass slide, it will be very easy to differentiate between neutrophils and eosinophils. So if I see a lot of neutrophils, what is your list of differential diagnosis? Linear IgA, what else? Bullous lupus. So those are the two. If I see a subepidermal split, next question, is there an infiltrate? Yes, there is an infiltrate. So what is the kind of infiltrate? I see a lot of neutrophils. So if I see a lot of neutrophils, my list of differential diagnosis, again also have to remember in real life, BP is still going to be in the differential, because 95% of cases that we see are always bullous pemphigoid. So if it's cell poor, if it is neutrophilic rich, whatever is, whenever I see a subepidermal split, in real life, BP is always going to be in my differential. On the board exam, yes, if it is a cell poor, I'm not going to think of BP, because you can't make the diagnosis without the history and the immunofluorescence in a cell poor subepidermal split. If I see a lot of neutrophils on the board exam, it is less likely going to be BP. In real life, I'm still going to think of BP. So if this was a slide on an exam, this would be either bullous lupus or it would be linear IgA vesiculobullous disorder. Yes, BP is still going to be in the differential. It is difficult, but that is all I can go to. Based on the histology, I cannot go beyond that. Yes, if there is an infiltrate in the dermis that is perivascular and periadenic cell, then yes, I might favor connective tissue disease. But acute bullous lupus doesn't show all that. It is only going to show you the subepidermal split with neutrophils.
What about DH?
DH would also be in the differential, but the characteristic feature that in real life, DHs definitely can present like this, but in the board exam, it is always going to show you the papillary microabscesses. So it is going to be very papillary based microabscesses of neutrophils. If you see that, then you're thinking of dermatitis herpetiformis. If I see a very linear split and the neutrophils lining up the dermal epidermal junction, then I'm going to think of linear IgA and bullous lupus. And then the immunofluorescence is the only way to go. If I see the linear IgA, then it is favoring linear IgA, and if I see a full house, then it's going to be bullous lupus. But without the immunofluorescence, I cannot go beyond these two diagnoses. Like there is no specific feature that is going to point me to either of them actually. Yeah, if that was there, then it would favor. It still could be either of them, but it would favor more bullous lupus actually. So subepidermal blister with a linearly aligned neutrophil along the dermal epidermal junction. DH is a very good thing to always think of, but in DH, it is always going to be in the papillary dermis. Like if it was something on the board exam to pick, then the neutrophilic abscesses are going to be limited to the papillary microabscesses. So again, are we good on time? Yeah. So what is the reaction pattern here? Subepidermal split. So when you see a subepidermal, the next question is, do I see any inflammation? So is there any inflammation here? Yes, basically there is some inflammation here. So what is the kind of inflammation here? Eosinophils. Yeah. So I see a lot of eosinophils both within the bulla and also in the dermis actually. So if I see a subepidermal split with bulla, then my list of differential diagnosis, 95% of the time it is going to be BP actually, but a bullous drug and a bullous arthropod bite can also present in a similar fashion. So those should be in your differential, but 95% of the time it's going to be BP actually. We'll have to go a little faster, I think. It's already 9. So BP, subepidermal bulla with eosinophils, and then the immunofluorescence is what is going to help you out to make the diagnosis. If I see the IgG and C3 at the dermal epidermal junction, then I'm going to say that is BP. So again, low power, there's a split here. So you can see there's a nice split at the subepidermal. So it's a subepidermal split. Next question, is there any inflammation? Yes or no? Not much of it. So it's a cell poor infiltrate. So now in the cell poor infiltrate, what is your differential diagnosis? PCT and EBAs. Again, remember in real life, BP is still going to be in the differential. But on the board exam, either this is PCT or it is epidermolysa bullosa acquisita. So those are the two ones that are cell poor actually. So now how do we make the diagnosis of PCT basically? What are the other features that you want to see to make the diagnosis of PCT? So what is this called here? Festooning actually. So you see the festooning because the dermis is very sclerotic in PCT. The patient has a very sclerotic dermis, so sclerotic skin. So similar thing is going to be seen on histology. The dermis is very sclerotic because of the sclerosis. The dermal papillae, they retain their structure basically. So they don't collapse. So when they don't collapse, you're going to see the festooning, the dermal papillae still maintaining the structure because of the sclerosis of the dermis. And that is known as festooning. You're also going to see this basement membrane material hanging from the roof of the blister, and that is known as caterpillar body. So when you see this basement membrane material hanging from the roof of the blister, those are caterpillar bodies. So the presence of caterpillar bodies, the presence of festooning, and then in the dermis, what are you going to see? If you look around the vessels, there is duplication of the basement membrane material around the vessel. So you're going to see some sort of thickening of the vessel wall actually, which can be very nicely highlighted with PS. If you do a PS, it's going to highlight the thickening of the vessel wall. So you see that all those features favor porphyria cutaneous tarda. So if you see festooning, the caterpillar bodies, you see the thickening of the vessel wall in the dermis, this is more likely to favor PCT than EBA actually. So PCT. So now, what are we dealing with here? The biopsy is telling you what you're dealing with actually. Look at the size of the biopsy. If you're going to do that biopsy, you're going to do it for what? If you do such a big punch biopsy, you're thinking of something that is happening in the fat actually. So you're dealing with something. So that biopsy should tell you, oh, I must look at the fat very carefully. So if you have a punch biopsy that is going into the subcutaneous fat, no dermatologist is going to do that unless they're thinking, oh, there's something deep there basically. So what is happening in the deep part of the dermis? So you see some sort of septal thickening basically. So these are the septa and these are lobules. So you see that the septa are quite thickened. So you see a very thickened septa of the subcutaneous lobule. So when you think of thickened septa, what is the main prototypical lesion you're thinking of? Erythema nodosum. So once you start thinking, then you are going to look for what are the other features that I want to see to call it erythema nodosum. You're going to see this granulomatous inflammation. You're going to see some eosinophils, neutrophils, lymphocytes, all kind of inflammation in the septa. And then some of this inflammation is going to go into the lobules that has been described like a lace-like infiltration into the lobule. But the central part of the lobule is preserved. There's no inflammation. So it is not a, it's a septal paniculatus. It is not a lobular paniculatus. So this is a prototypical lesion of a septal paniculatus, where you see the thickened septa and then the inflammation, which is mostly chronic in the septa, with the presence of these giant cells. And they talk about Meissner's granulomas. You don't have to go into that, but some of these granulomas, they are around cleft-like spaces, and the granuloma around the presence of these macrophages, these giant cells around cleft-like spaces is called Meissner's granulomas. But very characteristically, even at low power, you know you're dealing with something that is in the fat, the thickened septa, and the presence of the chronic inflammation should make the diagnosis very easy that you're dealing with erythema nodosum. So again, like the biopsies from here to the deep part of the fat. So again, you know you have done a very deep biopsy actually. So the deep biopsy must have been done for something in the dermis or the fat basically. And even the epidermis looks pretty normal. So we have to focus on the lower part of the biopsy. So what do we see in the lower part of the biopsy? So if you look at the fat, what is happening to this fat here? So there's a lot of necrosis actually. So there's a lot of necrosis happening. And what is this? There is all this almost like purple like degeneration of the fat walls like within the fat. So what is this purple material basically? What is all this here? This is calcium, like this is saponification basically. So calciphylaxis is going to be within this very small dots within the fat, and you can see all this purple like deposition with a lot of neutrophils. So you see a lobular paniculatus with this purple degenerated material here. You can see this very nicely here. So this is all fat saponification because of the release of the pancreatic enzyme within the fat actually. So when you see this this purple colored material within the fat with neutrophils within the lobules, you're going to, you're dealing with pancreatic paniculatus. So this saponification, this you see a material, this is because of the enzyme lipase that is being released and causing a lot of necrosis of the fat, and that is known as saponification, and that is what points to the diagnosis of pancreatic paniculatus. So again, a deep biopsy here. So look at the size of the biopsy. But here also what is happening? Like what is the other feature that is different from the other biopsies here? There are also some changes that are seen in the dermis actually. So here the dermis doesn't look pretty normal. There are something that is wrong. What is wrong in this dermis at low power? It looks very sclerotic or fibrotic actually. So if you go high power, let's go high power, and you start from the top. What is happening here? You look at these vessels. So like these vessels, this is not normal vessels actually. So what is happening here? So the vessels are proliferating. When do the vessels proliferate? Stasis dermatitis. So when you start seeing the vessels that are proliferating in the papillary dermis, you know you're dealing with some sort of a stasis dermatitis. So when the stasis dermatitis becomes very exaggerated, what happens? So like you start thinking of lipo and such a deep biopsy with the fibrosis, and then look what is happening to the fat here. So you see some of this is a big fat lobule. So normally when you look at the subcutaneous fat, it is composed of these fat cells that are very well, like they have a very regular shape actually. But what is happening to the fat lobules here? Some are small, some are big, some are coalesced, quite a bit actually. So there's a lot of destruction that has happened within the lobules of the subcutaneous fat. So a lot of destruction that has happened, and because of the destruction, this is all coalesced into one big lobule actually. You see this fibrosis, so this is known as fat necrosis. So when you see the fibrosis, the macrophages and the coalitions of the fat lobules into one big lobule, that is known as fat necrosis. So you see fat necrosis, you see the dermal fibrosis, and you see the stasis dermatitis. So your diagnosis is going to be lipodermatosclerosis actually. So in lipodermatosclerosis, you're going to see the dermal changes of stasis dermatitis, the lobular proliferation of thick-walled vessels, and then in the subcutaneous fat, you're going to see the fat necrosis with the lipomembranous changes. So when this lipomembranous or the membranes are destroying, so that is known as lipomembranous. The membrane of the fat are being destroyed, so they coalesce into one big lobule. So again, big biopsy. So you know you're dealing with something in the fat. So you go. So is it septal or lobular? Something is happening to the lobules. You see a lot of inflammation within the lobule. So you know you're dealing with some sort of a lobular paniculitis. So now if you go hyper, are there any features that can help you make the diagnosis basically? So what is the kind of inflammation that we see here? Yeah, so this is a very characteristic feature that we see here. What is this known as? Needle-shaped collapse. So if you go high power and you look for these, you can see them nicely in quite a few of the lipocytes. So this is a nice example of a needle-shaped collapse. So this is another nice example of a needle-shaped collapse that you see within the subcutaneous. So there's a lobular paniculitis with a mixed infiltrate. So there's lymphocytes, there are macrophages and everything, and then very characteristically this needle-shaped collapse within the lipocyte. So what is the differential diagnosis? Subcutaneous fat necrosis of newborn, but also can be seen in steroid paniculitis. So steroid associated paniculitis, and sometimes even in cold paniculitis, you're going to see similar changes. But so the history is important. But on the board exam, your most likely diagnosis is going to be subcutaneous fat necrosis of the newborn. That is the more common thing that is going to be seen with this needle-shaped clefts within the lipocytes. I'm trying to go a little faster because I think we are going a little bit late. Subcutaneous fat necrosis newborn. And then I think this is the final paniculitis slide. So is this septal or lobular? So it's more lobular. And then when we go high power, so when you see lobular paniculitis, the first thing that you have to ask yourself is, what is the kind of infiltrate that I see? Do I see neutrophils? If I see neutrophils, I'm dealing with either pancreatic paniculitis, or I'm dealing with alpha-1 antitrypsin deficiency, or some sort of infection or trauma. Those would be the differential diagnosis. If I see lymphocytes, then I'm going to think of something else basically. And if I see eosinophils, it's called eosinophilic paniculitis. So what is the kind of infiltrate that we see here basically? Do we see any newts? No, basically it's mostly lymphocytes actually. So it's mostly a lymphocytic paniculitis. So and what is the other characteristic feature that we see here basically? Yeah, the rimming is very, very characteristic. So you see this lymphocytes that are rimming around the fat cells actually, and that when you see this rimming around the fat cells, so you can see that very nicely in this lobule actually. All these lymphocytes, they are rimming around the adipocyte. So if you see this rimming of the adipocytes, you are going to think of subcutaneous paniculitis like T-cell lymphoma. Yes, I'm in real life, I'm not going to jump to the diagnosis. I'm going to do a lot of stains. I'm going to get a lot of history before I even put the diagnosis on paper. But on the exam, if you have to make the diagnosis, what is the characteristic feature that you want to look for is the rimming of the atypical lymphocytes around the adipose tissue. If you see that without the stains, then you can pick that this is most likely going to be subcutaneous paniculitis like T-cell lymphoma. If this was a biopsy, we would do all the CD4, 3, 4, 7, 8, CD56, granzyme, TIA, and then the alpha beta 1. So there's a lot of stains that would go, EBV, all those stains would go before we make any diagnosis of a lymphoma basically. But the subcutaneous paniculitis like T-cell lymphoma predominantly CD8 positive, CD56 positive. Those are the most two common stains that are positive in a subcutaneous paniculitis like T-cell lymphoma. CD8 and CD56. CD3, 4 are mostly negative, and many times the granzyme and the cytotoxic enzymes are positive in subcutaneous paniculitis like T-cell lymphoma. The two variants are alpha beta type and the gamma delta type. The alpha beta type tends to involve mostly the subcutaneous. It does not involve the dermis and the epidermis. In the gamma delta, which has a worse prognosis than the alpha beta type, tends to involve the dermis and the epidermis. So if I have a paniculitis like T-cell lymphoma that is involving the dermis as well as sometimes going into the epidermis, I'm going to think of gamma delta type of subcutaneous paniculitis like T-cell lymphoma, which has a very bad prognosis compared to the alpha beta type actually. So alpha beta type is mostly limited to the subcutis. But that would all be a long list of different stains before we come to any of those diagnoses. On the board exam, this rimming is the only feature you're going to get to make the diagnosis of a subcutaneous paniculatus like T-cell lymphoma. So what's happening here? So there is some sort of inflammation in the, mostly limited to the papillary dermis that is forming like a lobules basically. But what is the other feature that you see here that sometimes is described in many books actually? The presence of the Gren zone. So what is a Gren zone? The Gren zone is the uninvolved part of the papillary dermis. So where just below the dermal epidermal junction, if you have a dermis that is not involved, that is known as the Gren zone. And the Gren zone has been described in 3 or 4 conditions. One is granuloma faciale, lepromatous leprosy, and B-cell lymphomas. So B-cell lymphomas, lepromatous leprosy, and granuloma faciale are the 3 places where you are going to read about Gren zone basically. So the papillary dermis very clearly uninvolved just below the dermal epidermal junction, because if you are in most of the other inflammations, you're always going to see the inflammation also almost going up to the, if there's inflammation in the dermis, it won't spare the papillary dermis. But if it spares the papillary dermis, that is known as the Gren zone, very characteristically seen in granuloma faciale. So what are the other features? If you start thinking of granuloma faciale, what are the features that you want to see? So you're going to see a very mixed, and most of the times I've seen that this is like always this lobular pattern in the papillary dermis and around vessels. So like you always see a central vessel here and you see this big lobular inflammation in the vessel. And when I go high power, what is the kind of inflammation that I'm going to see? I'm going to see a lot of also eosinophils. So I'm going to see lymphocytes, neutrophils, but characteristically granuloma faciale tends to have a lot of eosinophils. So if I see an inflammation that is forming lobules in the papillary dermis with a mixed infiltrate and a lot of eosinophils with the Gren zone, then my diagnosis is most likely going to be granuloma faciale. So nodular dense mixed infiltrate, the lymph infiltrate is often in a perivascular pattern, the Gren zone is pattern, and sometimes you might see LCV actually. Okay, next slide. So what is happening here in the, so something is, so again the epidermis is pretty normal, but the action is mainly in the dermis actually. So what is happening in the dermis? There's some sort of an infiltrate in the dermis which is composed of, what are these cells here? So if you look at the cells, like look at the cytoplasm, is it a little cytoplasm or is it a lot of cytoplasm? It's a lot of cytoplasm. So lymphocytes tend to have very little cytoplasm. It's just a blue dot basically. But if I see a lot of cytoplasm, these are most likely histiocytes, macrophages. So if I see a lot of cytoplasm, then mostly they are histiocytes or macrophages. So this is mostly a histiocytic infiltrate. So histiocytic infiltrate in the skin is also known as a granulomatous dermatitis. So if this is a granulomatous dermatitis, what is the pattern here? It is a palisaded granuloma. So in the skin, if you think of granulomatous dermatitis, is it a palisaded granuloma? Is it a sarcoidal granuloma? Or is it like a foreign body type of granuloma? Those are the 3 things. Or is it something that is associated with a lot of neutrophils? So if it is associated with a lot of neutrophil, it is known as suppurative and granulomatous dermatitis. So, and then you are going to think of some sort of infectious process. So if I see a granulomatous inflammation with a lot of neutrophils that mixed, then I'm always going to think of maybe I'm dealing with fungal infection, maybe I'm dealing with an atypical mycobacteria, and I go in that direction. If I see palisaded granuloma, so what do I mean by a palisade? The word palisade comes from the word fence. So it is forming like a fence basically. So this is forming like a fence around something basically. So if you think of a palisaded granuloma, you're either going to deal with granuloma annulare, rheumatoid nodule, or necrobiotic xanthogranuloma. Those are the 3 main things to think of. There are other things, but the 3 common ones that you need to think of is GA, NLD, sorry, 4. So granuloma annulare, rheumatoid nodule, NLD, which is necrobiosis lipoidica, and then necrobiotic xanthogranuloma. Those are the 4 differential diagnoses for any palisaded granuloma. There are other zebras, but for you, if you can remember these 4 things, that's more than enough actually. So how do you differentiate now? So now you have your list of differential diagnosis that is narrowed down quite a bit. So what are the features that you want to see to make a diagnosis of granuloma annulare? You want to see mucin, or but if you don't on the exam, they might not give you the mucin stain. So you see the EOS, but like what is the character? You're going to see this palisaded granuloma around what basically? It is mostly a necrobiotic collagen basically. So you're not going to, in rheumatoid nodule, it is fibrinoid material within the palisade. So if I see a very pink material within the palisade, that is the fibrinoid degeneration, then I'm going to think of rheumatoid nodule. In GA, it's mostly around necrobiotic collagen. So what I see is altered collagen around the within the palisade. So if I see a palisade with altered collagen, then I'm most likely going to think of granuloma annulare. If I see in NLD, what is the pattern base? You're going to see the layers actually. So if I see a palisaded granulomas in layers, then I'm going to think of NLD. And the last one is necrobiotic xanthogranuloma. The word itself is telling you what to look for basically. Necrobiotic. So I'm going to look for a lot of necrosis basically. So if I see a lot of necrosis or necrobiosis, then I'm going to think of necrobiotic xanthogranuloma. If I see very pink material within the palisade, I'm going to think of rheumatoid nodule. If I see very altered collagen within the palisade, I'm going to think of granuloma annulare. And if I see the layer, then I'm going to think of NLD. So like this 4 differential diagnosis for any palisaded granule. So what one is this basically? GA actually, because you see the palisaded granuloma around altered collagen bundles. Yes, if I do a mucin stain, I'm going to see increased mucin within the palisade. So if I see increased mucin within the palisade, that helps me that this is a diagnosis of granuloma annulare. But remember this macrophages, when you start seeing macrophages, first thing is I'm dealing with the granulomatous dermatitis. Next is what is the kind of granulomas? Is it sarcoidal? Is it palisaded? Is it suppurative, or is it foreign body type? This is a palisaded granuloma. Now palisaded granuloma, so my list of differential diagnosis is 4. And then you just go through your list of differential diagnosis and you make your diagnosis. So perivascular lymphocytes with interstitial macrophages, palisaded granulomas are in collagen necrobiosis and admixed eosinophils. So now what are we dealing with here? So first, it's a very busy dermis actually. So if you go, so what is making the dermis very busy actually? So it's some sort of an infiltrate. Again, you can see the same such type of cell that you saw in granuloma annulare. You see these big cells with a lot of cytoplasm. So you're there, yes, there are macrophages, but what is the other cell type that you see here? You see a lot of neutrophils actually. You can see a lot of multilobulation of the nuclei that helps. So you can see all these cells there. So if it was a lymphocyte, you're going to see a very nice round cell, round nucleus. But if you start seeing this multilobulation, then you know you're dealing with a lot of neutrophils. If I see this lobulation with a lot of orangish background, then I'm dealing with eosinophils. So here I'm seeing, I don't see the orange background, but I'm seeing this multilobulation. So I'm dealing with a lot of neutrophils actually. So it is some sort of a neutrophilic dermatosis. So now if I'm dealing with neutrophilic dermatosis, your list of differential diagnosis again narrows down quite a bit actually. So what is your list of differential diagnosis about neutrophilic dermatosis? Sweets is one, EED. Yeah, so like all those things that can look like sweets basically. So erythema elevatum diutinum that can look like sweets. The dorsal pustulosis of the neutrophilic dermatosis of the dorsal hands can also look very much like sweets. And then the one that is associated with inflammatory bowel disease can also look like sweets actually. So those are your list of differential diagnosis now narrows down quite a bit actually. So if it was sweets, what are the other features that you want to look for basically? You want to look for papillary dermal edema, and then what else basically? So whenever, like I said, whenever you see neutrophils, first question to ask yourself is, do I see any vasculitis? So you're going to go and look for the vessels, and I try to see if I see any vasculitis. If I don't see any vasculitis, at least that part is out. Now, how do you differentiate between sweets and erythema elevatum diutinum? Pardon? There might be vasculitis, but again, I've talked about this before. Think clinically. How does EED present? Nodules basically. So it is going, if it's something that is presenting as nodules, how would that, what is forming that nodule actually? What is causing, what would cause a nodule to form in the skin? Fibrosis actually. So like you have to think clinically and then go to the histology. So if it was a nodule, it is going to show a lot of fibrosis. So now this is showing a lot of we can see this thickened fibrous septa. So when you start seeing this fibrosis, think clinically, because this is going to present as a nodule around the elbows, around the joints. That is how EED presents. So because how is this nodule going to form? Because it is as neutrophilic dermatosis, but with a lot of fibrosis, and that is what is going to cause the nodule to form. And if I see the fibrosis, then I'm going to favor EED rather than Sweet syndrome. Because Sweets and EED can look very similar, but the clinical presentation helps you differentiate between the two actually. So if I see the, yes, books describe presence of vasculitis sometimes seen in EED, but it is not always present. So if you see, yes, vasculitis, yes, it could be EED in a neutrophilic dermatosis, but the fibrosis is very, very characteristic when you go back and look at the clinical picture actually. So the presence of a neutrophilic dermatosis with fibrosis favors EED rather than Sweets. And then the other thing that they describe in Sweets is the presence of the papillary dermal edema, which is normally not seen in EED. The other condition that we talked about, the pustulosis of the dorsal hands or the inflammatory bowel disease associated neutrophilic dermatosis will show exactly the same picture as Sweets. You cannot differentiate just based on the histology. You need some more clinical history to differentiate between those. So EED. So now what are we dealing with here? Something that is happening in the deep part of the dermis. So what are these cells here? Hopefully now you can, what are these cells here that you see here? These are histiocytes again. So what are these histiocytes forming? They're forming a palisade. So and what is the palisade around? Very pink homogenized material. So what is your diagnosis? Very easy. Like you have to follow this pattern every time in your brain. You keep doing that, you're going to come to a very narrow differential diagnosis and then very quickly to the diagnosis. But don't jump to diagnosis. So if you follow that pattern, this is rheumatoid nodule. So a deep part in the dermis, you see this palisaded granuloma, very pink material. What is your main differential diagnosis here? Deep GA actually. So a deep GA can also present with a deep kind of palisaded granuloma, but you're not going to see this pink hyalinized material. You're going to see that around necrobiotic collagen bundles. The books also describe presence of eosinophils in deep GA compared to rheumatoid nodule. The other thing is, if this was real life, I would pick up the phone and talk basically. That is usually a young child, less than around 8 to 10 years old, presenting with deep GA, not somebody who has rheumatoid disease basically. So the rheumatoid, the history would make it very easy, but yes, on the exam, you might not get the history. So this following that algorithm in your brain is very, very important. So if that is what you take out of this room, how do I start building that algorithm in my brain whenever I'm approaching a skin biopsy? I think my job is done basically. So now again we are dealing with the so let's take this one. So what is the kind of what is happening here in the dermis? So now these cells should be very easy to. What are these cells here? Histiocytes. There's a lot of histiocytes. There's a lot of lymphocytes. There are some. What are these here? Giant cells. So there's an infiltrate of giant cells, macrophages. So again, you're dealing with the granulomatous dermatitis. So what is the kind of granuloma here? It's a little bit of palisading because you can see it's forming like a line here basically. And like if you go low power, what is the other characteristic feature now that can help you very quickly come to a diagnosis is the layering basically. So same pattern follows in your brain every time. You look at the cells, oh, it's macrophages, lymphocyte, giant cells. So it is a granulomatous, it is formed. So what kind of granuloma? This is most likely a palisaded. But this layering makes it very easy. So if I see this layering, so what is the layer composed of? The layer is composed of this palisaded cells of lymphocytes, histiocytes, and macrophages, and some sort of giant cells. Then you have the sclerotic dermis. Again, you have the layer of inflammation. Then you have the sclerotic dermis. Again, you have the layer of inflammation. So that layering is very characteristically seen in NLD actually. And then if you go into much more detail, you are going to see some plasma cells. If you go around and look for some plasma cells, you will see some plasma cells in NLD. So Morphia, NLD, they always show, if you go high power and look for some of the plasma cells, you're always going to see some plasma cells in them. But you don't have to go into that much detail. The low power view and that algorithm in your brain should make the diagnosis much more simpler to come to the diagnosis of necrobiosis lipoidica. So what is happening here? So what are these cells here? Very similar pattern. So you see a lot of histiocytes, lymphocytes, and giant cells. But and what are they forming? They're forming this palisades actually. But what is the now what is the other feature that was not present in the other biopsies? The palisade is forming around what basically? There's a lot of necrosis actually. So I see a lot of necrosis of the skin here of the dermis. So look at the college. The detail is gone basically. So in necrosis, the detail is quite lost actually. So when I see a lot of necrosis, I see the palisades, I see the granulomas. Your diagnosis is much easier. What is your diagnosis basically? NXG. So what are the features that you want to look for in NXG? What are the other things that the books describe? Cholesterol clefts within the necrosis and the presence of two-tone giant cell actually. So this is the cholesterol cleft. So you can see the if I go high power and look for these cholesterol clefts, I'm going to see this cleft-like material. These are the nice cholesterol clefts that I see within the area. So if I want to look for the cholesterol clefts, I go to these areas of necrosis and I find the cholesterol clefts. And if I want to look for a two-tone giant cell, I go high power and just look around and I'm going to find the two-tone. So if I see all these features, my diagnosis is I'm pretty sure that I'm dealing with necrobiotic xanthogranuloma. So again, this is what are these cells here? Histiocytes. So again, you are dealing with the granulomatous dermatitis. Now, what is the pattern here basically? It's not the palisade. So what is this pattern called? Sarcoidal granulomatosis. So now you are dealing with, so what is a sarcoidal granuloma? So sarcoidal granuloma is the granuloma that is composed of these macrophages. They are also called naked granulomas because the word naked comes from the presence or absence of lymphocytes. If I see normally granulomas are always associated with a lot of lymphocytes. So if the lymphocytes are not present, they're called naked granulomas. So the lymphocytes are supposed to be the clothes of the granuloma. So if you don't see any lymphocytes, these are known as, so it is never any lymphocyte. If you see a very scant lymphocytes, then that is a naked granuloma. So if you see a naked granuloma, that is most likely going to be a sarcoidal granuloma. And sarcoidal granuloma is, diagnosis is going to be sarcoidosis. But again, you have to first, real life, you have to first do all the stains. I do an AFB, I would do a fight, I would do a GMS, make sure I'm not dealing with an infectious process. Once I've ruled all that out, then I'm going to call this sarcoidal granulomatosis compatible with sarcoidosis. The other thing you have to always remember, sarcoidal granulomas can also occur with foreign body things basically. So zirconium and beryllium are the two foreign body material that can look exactly like this actually. So the two foreign material that can cause sarcoidal granulomatosis is zirconium and beryllium. So if there's a worker that is working in any of the industries that is dealing with zirconium or beryllium, they can develop very similar reaction pattern, naked granulomas, and those are sarcoidal granulomas. But most of the time, this is sarcoidosis after I've ruled out any infectious etiology basically. So again, so deep punch biopsy. So what is happening here? So there's a big punch biopsy, but not like, is there any inflammation here? No. So like if you look at the epidermis, pretty normal. Dermis also looks pretty normal, but the size of the biopsy is telling you what basically, where is the biopsy from? Back basically, because nobody's going to take that big of a biopsy from the face or anywhere else. So if you see that big punch biopsy, it is usually from the back. So like this is a biopsy from the back, and what is the epidermis looks pretty normal. Even the dermis looks pretty normal most of the time. So you have normal collagen bundles. There is not much of inflammation. But when you go low power, there's something not right about the lower part of the dermis. And what is happening here? You see a lot of mucin here. So there's a lot of mucin that is collected. So this bluish material that you see here is all mucin actually, which is very easily seen even with the HNE. I don't need a stain. I don't need an Alcian blue or a colloidal iron to look for this mucin. So if I see a lot of mucin, back biopsy, what is my diagnosis here? Sclerodema. So what sclerodema clinically it presents with some in the humps on the just below the neck or thickening of the back or the skin at the back. So this is thickened epidermis that is telling you that the skin is thickened. But what is causing the thickness is the presence of all this mucin that is causing separation of the collagen bundles and causing the thickening of the skin. So the only thing to think of then is scleroedema basically. How is this different from scleroderma? This could also be scleroderma actually. Like it's a big punch biopsy and it has that rectangular shape. So why is this not scleroderma basically? Pardon? There's not much of sclerosis actually. So scleroderma, you will see a lot of pink appearing sclerotic material. And then all this, what is all these here? You see the adnexa basically. So in morphia and scleroderma, mostly the adnexa are mostly gone basically. And then do I see any eccrine structures? I don't see any. So if I had the eccrine structures here, there are some eccrine structures here. In scleroedema, I'm not going to see the loss of the pericrine fat. So the loss of the pericrine fat is very characteristically described in morphia and scleroderma. So you have to start, what is my main differential here? My main differential is because of the thickened skin on the back, big punch biopsy, is scleroderma or morphia actually. So what are the features that help me rule that out? Is the presence of the adnexa and then no loss of pericrine fat actually. So scleroedema. I'll have to go a little bit faster. So now again, like you see the same, very similar changes, but what is different about this one? Look at the color basically. How is it different from the previous one basically? Very pink and sclerotic. So you know this is different from the scleroedema. And there is no adnexa here. So the adnexa are gone. It is very, very sclerotic. It has that again, that same square rectangular pattern. So even on low power, I know I'm most likely dealing with morphia or scleroderma basically. So like this is most likely morphia or scleroderma. So what are the changes that you would see in morphia or scleroderma? Very sclerotic looking dermis, loss of adnexa. If I have the eccrine ducts, I'm going to show here is the eccrine ducts. You can see the eccrine ducts here. All the fat around the eccrine ducts is gone basically. Now in normal skin, there's always some fat around the pericrine ducts actually. If you look at any normal biopsy, when you go back, look at any skin normal biopsy, there's always going to be some fat around the eccrine ducts. So in morphia, you lose that pericrine fat. So rectangular biopsy, loss of adnexa, very sclerotic looking dermis, loss of pericrine fat, your diagnosis is either scleroderma or morphia. If I go high power and look at the scanned infiltrate, I'm going to find 1 or 2 plasma cells. If you really want to go into the and look at the biopsy, you're always going to see some plasma cells actually. Not in morphia. So again, similar looking biopsy, but what is different here now? There's some pallor in the superficial part of the epidermis, in the papillodermis. So now if I go high power, what is causing that pallor actually? It's mostly edema, but what is the other thing that you see here that is different? What are these here? Stellate fibroblasts. So whenever I see the stellate fibroblasts, so this is like, if you look at these fibroblasts, they have this very atypical, look at these fibroblasts here. All these fibroblasts have a very hyperchromatic nucleus and variation in the size and the shape. So I'm seeing some fibroblasts that are pleomorphic looking basically. So if I see something that looks like morphia, very sclerotic dermis, but then I go high power and I see this fibroblast, what do I need to think of? Radiation, that the patient has had some sort of radiation, and very characteristically, I'm always going to find these atypical looking fibroblasts scattered throughout the papillary dermis. So if I go high power anywhere, I'm going to see this very atypical looking stellate nuclei fibroblast. If I see that, then my diagnosis is going to be radiation dermatitis. Okay, so next one, what is happening here? There's something in the dermis. So what is here happening in the dermis? What do we see here in the dermis? A very feathery degeneration material that is deposited in the dermis actually. So when I see this, what do I think of basically? Gout. And what is the other differential diagnosis? Pardon? Triamcinolone. So any pinkish material deposition in the dermis that has this feathery degeneration like material, I'm going to think either this is gout or this is triamcinolone. How do you differentiate between the two? Triamcinolone doesn't cause a foreign body reaction. Remember, gout causes a foreign body reaction. Triamcinolone doesn't cause a foreign body reaction. So by what do I mean by that? When I go to the periphery of this pinkish material, I'm going to see this macrophages and lymphocytes lining up the lining and trying to form a foreign body. trying to like enclose that thing basically. So if I see that foreign body reaction around this feathery material like these are like a deposition in the dermis, then this is most likely gout. And if I don't see that, if I see that pink globules within, then it is triamcinolone. I'm trying to go a little bit fast because we are going a little bit over time actually. So what is happening here? Yeah, so like the stratum corneum looks normal, the epidermis looks normal, the dermal epidermal junction looks normal, and even the dermis doesn't have much to talk about basically. So it is like a normal looking skin biopsy. So whenever we think of normal looking skin biopsy, you have to start thinking what are the features that I am missing that can help me now make a diagnosis basically. So you look at the stratum corneum very carefully. Do I see any fungal infection? Do I see any bacteria? Do I see any changes that might make me think of some sort of a xerotic disorder basically? And then do I see any deposition in the papillary dermis? If I go high power, do I see any deposition in the papillary dermis here? Yes, we see the pink globules within the papillary dermis. So these pink globules with the pigment incontinence should point you towards amyloidosis. So whenever I see pigment incontinence, I see the pink globules, I'm going to think of amyloidosis basically. I could do the Congo red stain, I could do a keratin marker, I could do a PS to highlight it. But whenever I see this pigment incontinence and I go high power and look at the papillary dermis, so in normal skin, you have to go to the stratum corneum, go to the epidermis, go through the dermal epidermal junction, and then the dermis to look carefully. But again, like what the mind doesn't know, the eyes are not going to see actually. So if you don't think about it, you're not going to see it basically. So you have to start thinking, what do I need to see in the stratum corneum? So do I see any fungal infection? Do I see any erythema organisms? What do I need to see in the dermal epidermis? Do I see any deposition basically? So if you think about it, then you are going to look for it basically. If you look for it, then you're going to find it. So if I look for this deposition in the dermal at the papillary dermis, I see this deposition, then I know that my diagnosis is amyloidosis. So again, what is happening here? This one is a very classic. Again, I see a lot of material that is deposited in the papillary dermis. So you see this pinkish homogeneous material that is deposited in the papillary dermis. So your list of differential diagnosis is what? Whenever you see pink homogeneous deposition in the papillary dermis, what are the things to think of basically? Colloid milium, amyloidosis, what else? Erythropoietic protoporphyria and lipoid proteinosis. 4 things to think of. Any pink deposition in the papillary dermis, amyloidosis. So for amyloidosis, I need to look for pigment incontinence. If I see pigment incontinence, most likely I'm dealing with amyloid. Colloid milium, what is the feature that I'm going to look for? Is this fracturing. If I see this fractures within the pinkish homogeneous material, and colloid is coming from where? Colloid milium is coming from degenerated elastic fibers. So this is mostly a sun exposed area of the skin where I'm going to see a lot of elastic degeneration. So if I go low power, I'm going to see some solar damage along. So if I see solar damage, I see this pink deposition, I see the clefting, then I know I'm dealing with colloid milium. For erythropoietic protoporphyria, the deposition are where? They are mostly around the vessels. So if I see the deposition mostly around the vessels, then I'm dealing with erythropoietic protoporphyria. And then lipoid proteinosis, where are the depositions? So again, go back to the clinical. How does lipoid proteinosis present actually? So it presents with very tight skin basically. So the tight skin is being caused by the sclerosis of the dermis. So I'm going to see this deposition in the dermis that is very pericrine basically. So I'm going to see it around the adnexal structure. So if I see pink amorphous deposition around the adnexal structures and in the papillary dermis, think lipoid proteinosis. Around the vessels, erythropoietic protoporphyria with elastic degeneration or solar damage, colloid milium, and with pigment incontinence, amyloidosis. So what's happening here? Yeah, so you see some sort of some neutrophilic infiltrate here, but that is almost forming like a, it's trying to find a path through the epidermis. So this is some sort of a perforating disorder. So when you're dealing with a perforating disorder, there are 3 or 4 things to think of basically. Either I'm dealing with EPS, I'm dealing with reactive perforatic collagenoses, I'm dealing with some sort of Krayle's disease where the folliculitis is happening, or I'm dealing with a patient who has renal disease and has acquired perforating disorder. There are only 3 or 4 things to think of basically. So am I dealing with EPS? So for EPS, what do I need to see? So I go high power, I'm going to see this pink elastic fibers through the forming a path through the epidermis. So if I see the pink elastic fibers, then I'm going to think of EPS, elastosis perforans. So if I see a lot of degenerated collagen bundles, then I'm going to think of reactive perforating collagenoses. If it is associated with the follicle, then it is Cryles. And if the patient has renal disease, then I'm dealing with acquired perforating disorder of renal disease actually. The board might ask you a question of the drug that is associated with the EPS. What is the drug that you need to know of? Penicillamine. So if you're the penicillamine can cause EPS, in which they talk about the bramble brush type of so bramble, say the brush that you wash the bottle with, that has those bramble brushes, and that is the pattern of the elastic fibers that you would see in penicillamine. So penicillamine bramble brush pattern of the elastic fibers, remember that might come on your exam. So what is happening here? So you see some like, so there's a Gren zone, but like what is the main action happening here? So there's something in the dermis, and what is in the dermis? What are these cells? You see a lot of fibroblastic proliferation actually, and what is the background? There's mucin actually. So there's some sort of a mucinous background with a fibroblastic proliferation that is limited to the papillary dermis. So you see a mucinous background, fibroblastic proliferation. So what are the things that you need to think of basically? Scleromyxedema or lichen myxedematosus. Sorry, I'm going a little bit faster because I'm already like. So if you see a fibroblastic proliferation in the papillary dermis with a lot of mucin in the background, you have to think of lichen myxedematosus or scleromyxedema, which are both essentially the same thing. One is localized and one is more generalized. So both of them present with this mucinous background, mucin in the papillary dermis with a lot of fibrosis in the papillary dermis, and that is the fibrosis is what is causing the tight skin and scleromyxedema. So that is the reason it looks histologically like very fibrotic actually. So this is lichen myxedematosus, that is a localized lesion of scleromyxedema. So where is the action here? In the fat. So what is happening in the fat actually? So there's a vessel here that is being altered. So what is happening to this vessel here? There's a lot of what is happening? So the vessel is being destroyed basically, and what is destroying the vessel? There's a lot of inflammation in the vessel wall. So something that is involving the larger vessel. So this is a inflammation that is involving the larger vessels in the deep part of the dermis. Very few things to think of. What is the only thing to think of for you basically? PN actually. So if you see a vessel, medium vessel vasculitis that is involving the deep part of the dermis, you are going to think of polyarteritis nodosa actually. Very characteristically, polyarteritis nodosa will show you vessels in different forms basically. So if you look at this vessel, this is already now starting to fibrose actually. So you are going to see in different stages. So some will be early lesion of vasculitis, and some are going to be late lesions of vasculitis. So the fibrosis has already started form. So if you see a vessel vasculitis, medium vessel vasculitis in different phases, think of polyarteritis nodosa. Yes, there are other things that can cause medium vessel vasculitis like tachyosis, but nobody's going to take a biopsy and give it to you basically. They're going to always take a biopsy from the lower leg. So it's always going to be polyarteritis nodosa actually. So what is happening here? So again, yeah, this is a big punch biopsy. Something stuck. Just a second. I think this is stuck, so I'll have to go back to presentation slides. Launch presentation. Okay. So what do we see in this biopsy? So this is a biopsy of alopecia, because I think otherwise the diagnosis is going to be very difficult. This is a biopsy for alopecia, so rule out some sort of alopecia. So whenever you see alopecia, you're either going to either dealing with scarring or non-scarring alopecia. So what is the type of alopecia that you are dealing with here? Do we see any much scarring of the dermis? No, basically. So dealing with the non-scarring alopecia. So non-scarring alopecia, main two differential diagnoses are either I'm dealing with alopecia areata or I'm dealing with androgenetic alopecia. So what are the features that you want to see to call it alopecia areata basically? So you're going to look for the inflammation around the follicles. So do we see any inflammation around the follicles here basically? There is some sort of a lymphocytic infiltrate at the dermal papillae. So that is a very nice feature. What is the kind of hair that you see here? Is this anagen or this is a catagen hair basically? So this is more of a catagen hair basically. So you are seeing increased catagen hairs, catagen early telogen hairs with a swarm of bee-like pattern at the dermal papillae. So your diagnosis is going to be alopecia areata. What would I see in androgenetic alopecia? You are going to see miniaturization of the hair follicles, more hairs so you're going to see by miniaturization. You see, what do you mean by miniature? You're going to see smaller hair follicles actually. You're going to see hair more in anagen phase, and then you're going to see those fibrous streamers. So if I see the fibrous streamers, I see the miniaturized hairs, I see increased sebaceous glands, then I think of androgenetic alopecia. If I see more hair in catagen telogen phase and this swarm of bees, then I'm going to more dealing with alopecia areata actually. Like the catagen hairs, you start seeing this. Let me go. See, this hair is now shrinking basically. So this hair is shrinking, and this is a new hair that is going to come up basically. And the swarm of bees is very, you can see it here also basically. See, there's nice swarm of bees here actually. Okay. Keep moving. So what's happening here now? The action is mainly in the, where is the action here mainly? In the epidermis actually. And so what is happening in the epidermis? Vacuolar interface. And what is like, what else do you, what are all these cells here basically? I see a lot of lymphocytes, and like if you look at these lymphocytes, like is there something wrong about these lymphocytes actually? They are much bigger than normal. If you look at the hyperchromasia, and they are much bigger than normal. So I see a lot of lymphocytic exocytosis or epidermotropism in the epidermis, and some of these lymphocytes are quite big and hyperchromatic. So look at this. If you look at this lymphocyte, what is happening here basically? It's like a lump of coal basically, if you want to describe it. Like Dr. Elston's book he describes a lump of coal. You see a lot of lymphocytes that appear a little bit bigger, hyperchromatic, going into the epidermis. So what is the main differential diagnosis here now? MF basically. So when I see a lot of lymphocytic exocytosis into the epidermis, so this is called lymphocytic exocytosis that is out of sync basically. So normally in spongiosis also you're going to see lymphocytic exocytosis, but that is in sync with the amount of spongiosis. So there's a lot of spongiosis and there's lymphocytes, but here there's not much of spongiosis, but there's a lot of lymphocytes that are going into the epidermis. So I see a lot of lymphocytes that are going into the epidermis. If I look at high power, these lymphocytes are quite hyperchromatic. Some of them have this convolution, and then very characteristically, they are lining up the dermal epidermal junction. And then if you look at the dermis, this is known as wiry collagen bundles basically. You see these collagen bundles, they have this wiry pattern actually. So it is a wiry collagen bundle. So these are all features in favor of mycosis fungoides actually. On real life, we are not going to make the diagram. I'm going to do the CD3, 4, 7, 8, 20, even a CD30 before I even go in that direction. So I want to see increased CD4 compared to the CD8. I want to see some loss of CD7. If I see all those features, then yes, and if the clinical history is asking for mycosis fungoides, then I would say compatible with the clinical impression of mycosis fungoides. But on the board exam, they are not going to give you the CD4, 7, and 8 basically. So what you want to look for is hyperchromatic lymphocytes going into the epidermis out of proportion of the spongiosis, some lining up the dermal epidermal junction, and sometimes you're going to see those Portary microabscesses, which are a collection of atypical lymphocytes within the epidermis. If you see all those features with the wiry collagen, then you are going to think of mycosis fungoides. So again, this is very normal looking skin. So very normal looking stratum corneum, nothing in the epidermis, nothing in the dermal epidermal junction, and the dermis also looks pretty bland actually. So again, you have to start thinking, what are the features that I need to look for to make a diagnosis? So I go high power and I look at the stratum corneum. Do I see any fungal elements or bacteria? I don't see them. Do I see any changes in the dermal epidermal junction? No. Do I see any deposition in the papillary dermis? No, basically. Do I see any urticaria like reaction in the dermis? So for even urticaria can look pretty normal skin. So do I see the neutrophils and the eosinophils very mild around the dermis? If I can rule that out, so not urticaria. So now what is left basically? So this one, the history is the patient has presented with slate colored lesions on the skin basically. So the patient has some discoloration and slate like discoloration of the skin. So if I give you that history, what is the other thing that you need to think of basically? So like a slate colored discoloration of the skin, you start thinking of some deposition. So for argyria, what do you want to see basically? So you can see this black deposition around the eccrine vessel walls basically, and that is very characteristically seen. And see this black deposition. So that is characteristic, but the history is needed. Otherwise, I would not, even like after 20 years of derm path, I would not have thought about the diagnosis, even thought about let alone making the diagnosis. I would not even think of argyria. But if I get that history, slate like discoloration, the patient is on some sort of silver drugs or something, then yes, I would think of the diagnosis. But if you see something that looks pretty normal, you have to think of argyria, especially on the board exam. So just go around the eccrine ducts and look for the deposition around the eccrine ducts, and if you see that, then you know you're dealing with argyria. So what is happening here? Scabies basically. You can see the nice organisms within the stratum corneum, and they're all over basically. Look at the like this is very classic scabies. So all these organisms. So if you see something that looks like an arthropod bite on the board exam, so that you see a superficial and deep perivascular with a lot of eosinophils, you have to think of scabies and look at the stat. Again, like if you don't think about it, you're going to miss the diagnosis. So just make sure that you look at the stratum corneum very carefully to look for this organ. If you see them, then that is scabies. The diagnosis becomes much easier. But the pattern is always going to be that superficial and deep with eosinophils. If you see that, you have to think of scabies. This one is much easier because you can see the organisms all over. But on the exam, you might get just a single organism on the slide. So the next slide, you want something that is affecting the hair follicle. So what is affecting the hair follicle? What is happening to the follicle? It is causing some sort of degeneration actually. So what is causing the degeneration now? Herpes. So what are the features that you want to see for herpes? Is multinucleation. So see the multinucleation. So multinucleation, molding, and margination. Three things. So by multinucleation, I mean by the nucleus start becoming like a giant cell, like a multinucleated giant cell. By molding means that the nucleus are molding on top of each other. So you start seeing the nucleus like molding on top of each other. And then by margination, you see the clearing of the nucleus with the chromatin going at the periphery. So there's a dark rim at the periphery of the nucleus, that is the margination of the chromatin. So that is going to the periphery. So the nucleus becomes clear and then the chromatin becomes marginated at the periphery. So multinucleation, margination, and molding are the three features that you want to see for herpes reaction. So I think this is the second last slide. So what is happening? So what is the site here? Acral site actually. And then you see this organism. So these normally present as rule out of melanoma. These mostly come because these present as pigmented lesions. But the history is the patient has gone to South America, walked on the beach, and then got this infectious process on the acral site. So what is this organism? Tungiasis. So once you see this, you won't forget, because acral site, this very classic looking structure that you see. So this is a female that has a lot of gravid. So it's a gravid female actually. So you see all these eggs within the So it's a gravid female. It's always a female. It's a gravid female, and you see this in the stratum corneum, and it usually presents as a pigmented lesion. Hopefully, once you see this, you'll always remember acral site, tungiasis. Organism is Tunga penetrans. I think this is the last 50th slide. So what is happening here? So there's a lot of inflammation in the dermis. There's pseudoepitheliomatous hyperplasia. So and what is causing the inflammation here? So there's some sort of an organism here. So you see all these round organisms here. So whenever you see these organisms, you have to start thinking of either Cryptococcus, lobomycosis, or blastomycosis or coccidiomycosis. I think Gerard will go over all those. So I'll let you take over, Gerard, because I think.
Thank you, Raj. And the recording's still running? Hopefully. I'd be sad otherwise. All right. Well, we're going to go through the next 50 cases in 1 hour, right? No problem. I talk really fast. It'll be fine. So there's crypto. One thing I think that's helpful about crypto is that you have the so-called pleomorphic yeast, right? You have small ones, medium, big ones. They all look different size and shape, and I think that's really helpful, plus the capsule around them. Here is a piece of tissue that's kind of fragmented. And if you look here, you can see there's a lot of scale and keratin debris on top and ulceration. The dermis is completely filled with infiltrate, all right? And if we look closer at that, it's a whole mixture of cells, neutrophils, histiocytes, all sorts. And I can't go in any closer on this one, but you can see, I think, oh wait, there we go. These round structures here, these are large, round, uniform yeast. Here's some more. See the little circles? You can see them because they have thick cell walls. I think there's another place over here that is a little bit better. You can see them kind of floating in the background. And what you'll see is a large yeast here, and here's another large yeast right here. They're budding, so you have these broad-based budding. They're big, round balls of yeast. They look relatively uniform in size, and then they'll have buds coming off. So instead of a tiny little narrow-based bud, they have these big buds. So that's classic for what? Yeah, blastomycosis. And they, again, they're much larger than a lot of the other yeast, and they're very uniform in size. And you do tend to get a mixture of neutrophils and histiocytes. So anytime you see granulomatous dermatitis with neutrophils, always think of infection until proven otherwise. Or if you see granulomatous dermatitis with plasma cells, you often have infectious etiology. And again, until you've ruled that out, always keep that in mind. Plasma cells are a nice clue. And oh, this piece is upside down now. I've moved over here. But the presence of epidermal hyperplasia, that pseudoepitheliomatous hyperplasia pattern with neutrophils, with granulomas, also really strongly makes you think of deep fungal infections, among other types of infectious things. So that's blastomycosis. And obviously, to be sure about any fungal infection, cultures are important, or other modalities. Yeast, a lot of times, can be classified pretty precisely, in most cases, from the H&E or the PAS and GMS by their morphology. Hyphal fungal infections are totally different, though. All of the rules that we use to diagnose Aspergillus or Fusarium or Mucor are not reliable on tissue sections, and I've been taught that rule, and I tried to break that rule before and was proven wrong. So by culture. So anyway, I always have to talk the clinicians down from that and say, well, we can't tell you for sure. We can say whether it's septate or not, but sometimes treatment alters the way those hyphae look. We'll talk about that in a second. And here's a nice shave, and again, you can see a dermal infiltrate. When you look at an infiltrate from low power, if it's really blue and diffuse, it's probably lymphocytes, right? If it's really pink or gray, it's probably histiocytes. It's not always true, but that's a useful thing because histiocytes have a lot of cytoplasm. That's why they look more pale, because the nuclei are spread out from each other by extra pale cytoplasm. So that's a kind of useful low power way to start thinking about histiocytes. And when I was wrong. Look, this is not actually histiocytes, it's collagen. So see, I told you, it doesn't always work. But these areas are histiocyte aggregates. And so aggregates of histiocytes are granulomas. You don't have to look around very long on this case to find the organisms. These big, round, cystic structures are classic for cocci. And they're filled with, they're too small to see, but they're tiny little endospores, or sporangia, that are inside the cyst. So sometimes the cysts are filled and you have lots of little tiny dots in them, Sometimes the cysts break open and spill their sporangia out into the dermis and then leave open, empty cystic structures. So sometimes they won't always look perfect like that. Sometimes they're broken down. And of course, with a lot of these fungal infections, where you are geographically matters a great deal, right? If you're in the American Southwest, cocci is really common. We never see cocci where I live in Arkansas. We see histo all the time. You can see blasto sometimes. So there's certain things that are very different geographically depending on your kind of environment and whether or not the fungus likes to live there. So that's coccidioides, coccidiomycosis. And there's some information about that. Right. Oh, maybe we'll go that way. Again, a biopsy, you got a little bit of reactive epidermal hyperplasia, not real dramatic. And then the dermis is completely filled with an infiltrate, some kind of cystic breakdown even. Looking closer, we can start to see multinucleated giant cells even from this power. And then I think hopefully you can pick them up in here. See these little guys here? Little round structures. And what color are they? They're brown, a kind of a golden brown color. And even without stain, this is H&E, and you can see they're numerous little round. Oh, they actually are showing up really nice on the screen. I didn't realize that. Heck, I'll just move my podium a little bit so I can see the big screen. All right, now we're in style. Okay, so what are these called? What do people, there are lots of names, because we can never have one name for anything in Dermpath, right? We have to have like 5 names. So what are some of the names for these? Sclerotic bodies, medlar bodies, copper pennies, all the things. You guys can go publish papers and make up new names, and then we can teach them to people and just make it more complicated. But they're round, pigmented, fungal structures, okay? And I think there's actually some debate over whether they're actually yeast form or spore forms. I'm not a mycologist. I think fungus is cool, but I'm certainly not an expert on the mycology aspect. But what they do is they're round, pigmented fungal structures. You don't even really need to do any stains here, but obviously they'll stain with PAS and GMS. They'll also stain with Fontana Masson, because what this is basically a form of melanin that's being produced by the fungi. And so when you have these round structures only in the dermis, and look at all the giant cells and histiocytes, we call this what? What is the diagnosis here? Yeah, chromoblastomycosis. And it's important to know that that is a descriptive term. That's not actually the name of a fungus. Most other fungal diseases, coccidiomycosis, we name after coccidioides, but this is not named after chromoblastomycosis. That's not actually a fungal genus name. There's a bunch of different geni and species like Exophiala and a handful of different fungal species that are pigmented or dematiaceous fungi. They're soil-dwelling saprophytic fungi that make pigment. They're basically mildew. They're similar fungi to what we see in black molds and mildew. So they often are from traumatic implantation. People will like step on a stick or cut their hand when they're gardening and get a little piece of wood or something implanted. And where I live in Arkansas, almost every time I see a wood splinter, which is not usually really a splinter, it's usually a stick or a thorn from a garden, almost always you can see some pigmented fungi as like little passengers on the wood, because it's a relatively humid climate where we live and it's warm. So like all the time, they often just stay on the wood and the host immune response keeps them from overgrowing. But in people that maybe don't have as good of immunity or get a real high load of fungus, I'm not sure they can develop these, and they can be kind of ulcerated nodules or kind of draining plaques or nodules, often on the lower extremity. And if you see pigmented hyphal structures here, we use a different name. Again, this is purely just descriptive, but what's that called? Yeah, phaeohyphomycosis. So chromoblasto and phaeohypho to me are on a spectrum. It's just a matter of terminology that we use. And again, the actual species you can culture out and find out. And some of the species do behave a little bit more aggressively than others. And so it is actually sometimes helpful. The clinicians, the infectious disease docs sometimes want to know that information. So chromoblasto, always a delight to see it, because it's kind of cool to be able to see the fungi so darkly colored. All right. Yeah, I found, because you got it highlighted, yes. From low power, it doesn't look like much. And actually, I think that, can I use the up arrow to go back, or will it not do that? Okay, just zoom out, okay. Look, from low power, it might not look very exciting here. Here's the epidermis down here. There's not much inflammation or anything. The only thing you really can see is these really dilated vessels here that are filled with either blood or fibrin thrombus. Hard to tell at low power. When you go closer, look what's happening. There is blood, there is fibrin, there's clot here. But look at all of these things. What are those? Yeah, bad news is what those are. Those are fungal hyphae growing out of the blood vessel, the dilated, congested vessel that's filled with thrombus mixed with fungal hyphae, and the hyphae are growing through the vessel wall. So this is angio-invasive fungus. This is basically metastatic fungus, if you like to think of it that way. Probably they have a nodule in the lung or somewhere else. One of my early autopsies I did was a transplant patient that had just tons of aspergillus, which is what this is in this case, in the lung, and then had some of it go into the vessel in the lung, spread to the GI tract, and then erode its way in, and then the patient died from bleeding out into the GI tract. But it was a really terrible case for that poor patient, but a really good example of exactly how these fungi operate. Once your immune system is broken down and you get a nidus of this growing inside your body, it gets into the bloodstream, and then it can spread all over the place. So this will show up as purple or black areas of ischemic necrosis in the skin that eventually ulcerate and turn into eschars. And then when you biopsy, what you're going to look for is the vessels. So anytime you have one of those things where the vessels are blocked off by clot, by thrombus, always think about, could it be angioinvasive fungus that's causing the clot, okay? It's important to learn to recognize ischemic changes in the skin, like you showed earlier, I think with one of your cases, recognizing ischemic change and then looking what's wrong with the vessels. Is it because there's cryoglobulin? Is it because there's thrombi from DIC or HUS? Is it because there's fungal hyphae invading the vessels? Is it because there's calciphylaxis? Those are always important things. Once you recognize ischemic change in the skin, you have to figure out why that's there, because a lot of those things are really urgent, acute things that need to be, they're basically derm emergencies. All right. So a lot of times, if you're lucky, you'll see the hyphae staining on the H&E, even without doing the stain. But if I have any suspicion, I'll do the stain. And these tend to be in immunocompromised patients. So it's not surprising that if this were in any of us, we would have a load of inflammatory response here. But in these patients, they're wiped out and they have no immune response. So it's often very pink or red appearance from low power, because you'll see blood and hemorrhage and fibrin and no inflammatory response. And also, once the skin gets ischemic, it looks even more pink, even less purple. So it often has a very pink, wiped out kind of appearance to me, and very little inflammatory response in the setting of, and there are multiple other vessels in here with that same finding. So again, you don't call this aspergillosis unless there's a culture. You can say angioinvasive fungus and that there's septate and acute angle branching, but we actually have, there's a paper from American Journal of Clinical Pathology, I think 2010, that has a real nice evidence showing that you cannot reliably speciate fungi. Sometimes you're going to be right, but you're going to be wrong sometimes too. So we actually cite that in our reports so that our clinical team, when they call, and they're like, but just tell us, what do you think it is? Come on. And so I did one time and I said, well, it looks like it's probably mucor actually. No, it was Aspergillus niger once they cultured it. The patient had been treated with amphotericin, which can cause the fungal morphology to change. So all those classic descriptions are based on cultured microbiology dishes and not on tissue, basically. So you have to be real careful with that, and don't get bullied into trying to be a culture dish. Just tell them to do PCR. We do that sometimes too. Okay, so in this case it was aspergillosis, but remember that Fusarium and other species can have identical morphologic appearance. All right, it's a great case. Geronimo may have seen this before. I've never seen a case in the United States, but I'm always looking for it. This is a bit of an older slide. It's a little washed out. You can see we've got muscle and fat down here, a really thick epidermis up here, and then a nodule here of histiocytes and foreign body giant cells. And if we look closely, look at those. You see those little white circles? And they're all perfectly uniform in size, much like blasto, right? But in some areas, if I can find some good areas, they're kind of making chains. Instead of blasto kind of is haphazard, but these guys, see how they're like kind of linked to their neighbor, and they kind of often line up and make rows or chains. So they look like a string of pearls, or some people say they're like pot beads, like those little toys that babies have that you can snap together. I don't know. I didn't know that's what they were called until I saw that on Twitter like a year or two ago, and I was like, oh, those are pot beads? We had them when I was a little kid. But anyway, I didn't know what they were called. So, or brass knuckles, if you're from like a tough inner city place, I guess you can call them that. I don't know, or a gang or something. But we try to be a little bit more pacifistic, so we'll say pearls around here. But this is what? Lobomycosis, right? Or one of my friends from the Amazon region of Brazil likes to call it lacasiosis because it's Lacasia loboi, and he said that normally we name fungi by their genus. And I was like, oh, okay. And it's actually named after the guy, his name is Lobo, who discovered this fungi. And if you want to impress your friends at cocktail parties, there's a cool bit of trivia. What kind of animal gets lobomycosis? Dolphins, the pink Amazon River dolphins. Whoa, drop that at your next party and your friends will be super impressed. This might actually explain a lot about my social life. So I think it's cool though. I like how lobomycosis looks, and of course never see it in real life because I live in the United States. And it tends to make a real keloidal nodule. So a lot of times you'll have keloidal, dense fibrosis and scar in the background, in addition to the fungal organisms and the granulomatous infiltrates. So that can be a useful clue as well. It's like we're on a theme here, right? Again, a dense dermal infiltrate. And look at that. Look at all these little tiny white circles. So we got to go way in and see what's in the circles. Circles usually mean something. Something's making the circle. It's either an artifact, it's lipid, it's mucus capsule around, it's something. But when you see little white holes in tissue, you got to stop and wonder why they're there. Can you see what's there? It's hard to see because we can't go any higher power on this, but I think it's still enough. See the little dots? Yeah. Well, that's the buzzword, right? I think kinetoplasts are imaginary things that are not real. I'm just joking. They're real, but they're so tiny that unless you have like oil immersion, I don't feel I can reliably see them. Look, I'm a board certified dermatopathologist and I'm confessing I cannot see the kineto. It's like the emperor's clothes, right? Everyone's like, oh yeah, they're great clothes. Look at those kinetoplasts. It's fake news, man. There's no kinetoplasts. I'm just joking. They do. They're protozoa. They have kinetoplasts. Diagnosis is leishmania. But in real life, they look, to me, almost identical to histoplasmosis. They're the same size. They're uniform, super tiny. They are intracellular, usually within histiocytes. They tend to make these vacuoles. The one thing that's supposed to be helpful, though, is that in leash, they tend to line up around the outside of the vessels, like a Ferris wheel or a marquee sign, whatever that is. I don't know, but that's what people say. And but like a Ferris wheel, right? They've got all the little cars around the outside of the circle. In the middle of the circle, there's no people in the middle. So people say that's really good for leishmania, whereas histo doesn't do that. I think things that actually help me in real life, I live in Arkansas. The diagnosis is histoplasmosis, okay? Because everyone in Arkansas has been exposed to histo. I've been there 6 years. I probably have it now too. It's really common. It's everywhere in our environment. So if someone's never been outside of our state, I'm sure they don't have leishmania, okay? Unless they happen to like keep pet sandflies at home or something, which probably not. If, on the other hand, they're in the military and they've been to the Middle East, then you have to really think about that. So travel history is super important. They can also do histoplasmosis urine antigen. You can do PCR. You can send, oh, by the way, for infectious stains, the CDC in Atlanta offers free consultation, and they have like every immunostain and molecular test known to man. It takes a few weeks, but it's free. And I feel like in difficult infectious cases or cases where there's a real concern for infection, but we can't find organisms, I'll often send stuff to the CDC. No conflict of interest, obviously. It's a free service. It's one of the few things that I'm like, man, I'm glad I pay my taxes and it goes to that, because it's really awesome to be able to provide such a high level of care to patients with complex infectious disease. So anyway, histo, I think, is the real differential here with leash, and both leash and sometimes histo can cause really dramatic epidermal hyperplasia that can mimic squamous cell carcinoma, right? Like pretty much it's true of any angioinvasive fungus, also true of leash, where it can really make the epidermis get revved up and look like invasive squame, but it's just benign and reactive, okay? So, you know, telling reactive squamous stuff apart from neoplastic can, even with experience, I think is still challenging, and I struggle with it on an almost daily basis. So anyway, that's leash. And yeah, supposedly you can see little kinetoplasts. And also if you do GMS, I feel, or PAS to highlight the fungi in histo, I feel like a lot of times when they look the same until you do the stain. And then on GMS, you can really see like little tiny budding yeast forms in histo. And obviously leash won't look like that. I think leash sometimes will pick up some of those fungal stains. I don't know if it's supposed to, but I feel like it does. And Giemsa is supposed to be positive in these, but I don't have a great deal of experience with using that stain here. And also, I think recently, didn't someone describe CD1A? There's like one clone of CD1A, the Langerhans marker, for some wild reason has like cross-reactivity with leash. I've not tried that yet, but it's a thing. You can look it up. I'm sure it's a thing. But I think it's only some clones, some weird cross-reactivity. Like I think of the marquee sign as similar to the Ferris wheel, right? The round circle. And I feel like this is actually about as even though it's a little hard to see here on this big screen because they're pale. I think this is actually about as good as I've seen it, because every single circle has organisms just around, like, let me find a good one, just around the outside. See, they're like all around the outside. There's a few that have them in the middle, but most of them are empty circles with little dots around the periphery. Like right there, look at that. See, little dots around the periphery. Dot, 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 and in the middle is nothing. The same over here, dots around the outside. That's leash. That's the buzzword, the classic. All right, so there's leishmania. Is there a door to close there? Thanks. Okay, here's a solid cellular sort of thing. Now I like infections, but I like tumors too. So we can't tell for sure we are. We might be on acral skin, right? Or we could be on skin that's been picked or scratched. Sometimes it's hard to tell, right? We got a dense dermal kind of multinodular proliferation. We go closer. What shape are these cells? Yeah, some of them are spindled. You could argue that maybe those are epithelioid. They're kind of rounded. That's the thing about spindle cells, especially when they grow together in fascicles. If you cut the fascicle a long way, it looks like they're spindled. But if they're plump spindle cells in a fascicle, when you cut it cross section, it's going to look round. Like think about like hot dogs. If you cut it long way versus cross section, looks totally different, right? So I think that that's a nice way to think of it. So here, depending on which way you section through the fascicle, you're going to get a different appearance. Here are spindle cells, and see other fascicles. I know they're not as perfectly well formed, maybe as like a smooth muscle neoplasm, although that could cross your mind here. You could think of a leiomyoma or leiomyosarcoma, but they're all kind of in fascicles together. And what else do we have? What's all the red stuff? Blood, right? So we've got little dots of scattered red cells that are outside of vessels in between all these spindle cells. So what is this probably? Yeah, Kaposi sarcoma. I'm sorry, you guys already said it. Kaposi sarcoma, right. So this is described as like slit-like spaces with blood. And you might say, well, where are the slit-like spaces? That's the problem. The vessels are not well formed in Kaposi. What you have, all of these are endothelial cells, but instead of making well-formed vascular channels like endothelial cells are supposed to do, they start spindling and growing out into the dermis. In the early phases of Kaposi, it can be very subtle, and you just have these trickling of spindled endothelial cells and some little dilated channels in the dermis, and those can be quite challenging to diagnose. The late tumor stage of Kaposi can also be challenging when the blood's not present. When the blood's here, everyone's like, it's easy, no problem. Take that blood away, and all of a sudden you're like, what the heck is this? And I've definitely had cases before that didn't have much blood, and I really scratched my head for a little bit. So on your test, you probably have the blood. And if the slit-like spaces with extravasated red cells are good, and the fascicular pattern is really good, again, in tumor stage Kaposi. And the other thing, one of my mentors, Mark Edgar, who taught me, and he taught me so many little pearls that are visual clues. Look, here we're not getting the spindle cells. They look round, right? Because we're cutting the fascicle in cross section. Doesn't look like slit-like space anymore. It looks like a bunch of little holes filled with blood, like a colander or a sieve, a spaghetti strainer. So you'll never think of pasta the same way again, but it's not truly a food analogy, right? It's a kitchen utensil analogy. So I think it's legit. Food analogies are out, but kitchen utensils are in. So anyway, little holes. It's a tough crowd today. Okay. Thank you. I'll be back every night this week. So anyway, the little holes filled with blood when you cut the fascicles in cross section, I think it's a helpful clue also. And what kind of inflammatory cell is almost always present in Kaposi? Plasma cells, such a useful clue. If you think it's Kaposi, go look for plasma cells. They're almost always there. And obviously, the traditional setting is older Mediterranean men or Ashkenazi Jewish men, but actually any old person can get Kaposi, usually on the feet or the lower extremity. It's your immune paresis of old age. Immune system goes down, HHV8 levels start growing and drive the proliferation of these endothelial cells and cause the tumor. And you can't cure Kaposi, but you can treat it palliatively. And a lot of times it usually does not kill people. They die with it, not of it. With the exception of uncontrolled HIV, when they have AIDS, Kaposi can be more aggressive. One thing that can help you telling Kaposi from angiosarc is that Kaposi, the cells are kind of atypical. They usually have mites, but they're not wildly pleomorphic, okay? And telling Kaposi from angiosarc, you might say, well, they're both vascular and they're both sarcomas, but it's as different as nevus versus melanoma. It's that much different. You can't cure this. You don't need to go do huge surgical excision. There's no point to try because it'll pop back up because the virus is everywhere, right? These people get multifocal disease not because it's metastasis, but because the virus is all over their body running amok. Angiosarc, on the other hand, gets aggressively treated, has a very poor prognosis in many patients. So it's a totally different disease. And we now know you can use the HHV8 or LANA1, is that the name, immunostain, to prove that it's Kaposi sarcoma, almost always positive. I would never make a definitive diagnosis of Kaposi without, I make it on H&E sometimes if it's real classic, but usually we have the stain. It just doesn't hurt to do the stain. Angiosarc, though, arises in different settings, right? The most times I see angiosarcoma is the head and neck of old sun-damaged folks, okay? And also in radiation sites. So if it's an old person on the head and neck, do not call it Kaposi sarcoma unless they have like AIDS or it's positive for HHV8. I don't care how much it looks like Kaposi sarcoma. It's probably angiosarcoma. And I've definitely seen a few examples of angiosarc that were very spindled and look very much like Kaposi. And also if there's dramatic wild atypia, much more likely to be angiosarc than Kaposi sarcoma. Okay, sorry, I get a little excited about these sarcomas. All right, there's all of the stuff I just told you. Ah, that's nice too. I get excited about this also. I just like DermPath. Okay, look at this. So like Raj was saying earlier, or Dr. Singh, excuse me, there's a Gren zone here. I personally don't find the Gren zone to be a very useful concept for most things. It does work pretty nice for granuloma faciale, and it does, I guess, work for this, but I feel like in general, I feel like the rule gets violated so much that I just have given up on it. But look at this. We got some sort of infiltrate all in the dermis and the subcutis. It's very striking how it's organized into structures, kind of, right? How would you describe these? Yeah, there's nodules, and some of the nodules are kind of elongated. Look at this one. It's kind of like almost serpiginous, like kind of a snake or an S shape or an elongated linear kind of shape, okay? So let's go closer and see what this infiltrate is. Well, it's kind of hard to tell. It's cells with a bunch of cytoplasm. Usually that should be a thought of histiocytes. Whenever you see cells, or whenever I see cells and I'm like, I don't know what kind of cell that is, the answer is histiocyte. That's how I learned it. Honestly, I asked my mentor who had like little triads for how to remember everything. Dr. Rowe would always teach them. And I said, Dr. Rowe, what's a triad for a histiocyte? And he's like, well, you'll have to make that one up yourself, Jared. So what I learned was that once I learned all the cells and there was something left over, it's histiocyte. Because they kind of are vague and they just blend into their surroundings. And so anyway, that's the way I do things. And you can see there's bluish kind of fuzzy, frothy, bubbly stuff. I mean, honestly, you could, if you look at this at high power, you could think about metastatic signet ring carcinoma. A real subtle example of that could certainly look that way. Pathologists are really paranoid about that always. But also when you see histiocytes with little bluish stuff in them, always think of organisms, okay? In particular here, when you have histiocytes that are aggregated in these linear, this isn't like a well-formed sarcoidal granuloma, it's kind of a loose granulomatous process. It's sheets of histiocytes. I guarantee there'll be plasma cells in there if we hunt around for a while, and they're kind of growing around the dermal structures. They're around the eccrine coils, they're around the nerves, they're around vessels. Once I tell you nerves, then you're like, oh yeah, but they grow around all the other structures too in the dermis, because nerves and vessels tend to track together, and they often get near eccrine coils. So I feel like in this disease, often I see eccrine coils surrounded like this and vessels. See, look, here's a nerve right here though. Boom, that's a nerve right there. So what stain do we do, and what is the diagnosis? Yeah, this is leprosy. This is lepromatous leprosy, and you can do the fight stain, which is a different form of acid-fast stain, and there will be like a bajillion, maybe 2 bajillion even, a lot of organisms in this. Each of these places, these little holes, are called globi, and they're filled with like thousands and thousands of organisms. So you usually on H&E can actually see them. It's hard on scan because they're so small, but you can see this fuzzy little material in the spaces, and you can learn to pick up leprosy. And obviously leprosy is endemic in many parts of the world still, like India and the Middle East. But also we see it in Arkansas a few times a year. We diagnose this usually from people who have had something to do with armadillos, the 9-banded armadillo. The vast majority of them in wild populations in the southern and southeastern United States carry leprosy, and they have a huge load. They have like 200 times the amount of organisms that humans have. I don't know why. They're cool with it. They're just like, it's fine. Like, you know, so I keep, every time I drive past the dead armadillo on the road, which I know you guys are like, oh my gosh, where do you live? I live in Arkansas. We have armadillos. I'm always like, I gotta stop and get some tissue, and we're gonna make some controls. So in my mind, I keep thinking about getting armadillo roadkill to make controls. Control tissue is hard to come by for fight. Unless you live in India or somewhere where you got leprosy all the time, it's hard to find good fight controls, right? I mean, that's good news. That means that we're wiping out mycobacteria, but it's actually hard to find control tissue. We do this stain all the time, and rarely, we only find organisms in a small subset, but we stain on it because you don't want to miss it, right? So lepromatous leprosy, and there's all these borderline forms, and all that stuff to me is clinical. The more important thing about classifying leprosy is on the lepromatous end, you have sheets of these frothy histiocytes, and you have numerous organisms, okay? And then on the other end, you have these sarcoidal, tight granulomas with big epithelioid cells, and they will also track along nerves, and they will have very few organisms. And sometimes you'll stain and look, and you're like, I'm sure it's got to be leprosy, but I don't see any organisms. So in those cases, usually we'll send it off for PCR to make sure, because usually the differential there is sarcoidosis, which also can sometimes track along nerves and can cause anesthesia and nerve tingling and stuff like that, the same kinds of thing leprosy does. And if the PCR fails, then what we usually tell our clinical team is treat it with steroids and watch the patient closely. If it gets better, it's sarcoid. If it gets worse, biopsy again, it's probably leprosy. And that's what actually the Hansen Disease Center, Hansen's disease is a pseudonym for leprosy. There's a Hansen's Disease Research Center in Baton Rouge, Louisiana. They used to have a leper colony in rural Louisiana, and then they don't have that anymore. They've moved to Baton Rouge, and they actually are excellent experts. They know all about leprosy. They'll coordinate with local doctors and send drugs, I think for free actually, because patients have to stay on meds for like a year. So really good to know about that. If you ever get a patient with leprosy, either the CDC or the Hanson's Research Center are great resources that can help your patients. So this is Lepromatous leprosy. We're actually writing a paper about leprosy in Arkansas because we think people don't know that it's there, but it's out there. Those armadillos are dangerous, man. They're kind of cute though. Just don't pet them. All right. Well, there's something pink or red there, huh? What are the players, like Dr. Rapini says? What's wrong with this skin? It's dead skin, right? The epidermis is pink, not purple, right? All the nuclei die with ischemia. The first thing to go are the nucleic acids, the part that stains purple. So whenever the nuclei, they dissolve quickly, but the proteins that make the cytoplasm are like, they're structural. They're big linked chains of amino acids. It takes a long time for your body to break that down after coagulum necrosis occurs. So when you see pink stuff with no nuclei left, ischemic necrosis is a good thing to think about. And once the tissue dies, it bleeds into itself, right? So we got an ulcer that's ischemic. I bet this looked like a purple, black, ulcerated lesion on the patient. And this is something that I don't think I've ever seen actually in real life. And it's a little hard to show here, but around some of these dead vessels are little smudgy, bluish, purpley, hazy areas, okay? And these will have little tiny gram-negative organisms in them. And culture would show Pseudomonas aeruginosa usually. So what's this disease? Yeah, ecthyma gangrenosum. Again, I don't think I've ever seen this in real life. The important thing though is whenever you see these wiped out ischemic zones in that clinical setting, rule out calciphylaxis, rule out invasive fungus, rule out coagulopathy, phone call to the clinician right away. This is not something to leave from a Friday to a Monday. The patient may be dead by then. For any of those ischemic things, it's really urgent. It says it's more urgent than a diagnosis of melanoma. That can wait a week or something. This can't. So anytime you have that setting, recognizing ischemia is such an important thing. And I've actually seen a general pathologist that just didn't recognize the signs, and a patient had a calciphylaxis going on the whole time because it doesn't look like cancer. So it's important to know those non-cancerous things that are still really important for those of you in the room that are pathologists. That's an important thing to remember for patient care. It doesn't always have to be malignancy to be deadly to the patient. So ecthyma gangrenosum. All right. And here we've got an infiltrate in the dermis. The epidermis looks normal. Ignore the orange, that's just ink. For those of you who are new in the new residents here. And we've got these big frothy looking cells here. They got round nuclei and a bunch of foamy cytoplasm. Sometimes it can be hard to tell foamy and granular apart. When you look closely, you can see tiny little bubbles that are clear because they're made of lipid. And they oftentimes will kind of gently scallop the nucleus, kind of like you'd see in a cebocyte. And that's a good sign that you have a foamy cell, a foamy histiocyte probably. And if this is a little yellowish flat lesion near the eye, what would that be called? Yeah, xanthelasma. And other forms of xanthoma will have a very similar appearance. And I feel like we don't see xanthoma or xanthelasma biopsied very often. So I actually don't have as good of a handle on the differences histologically between the different forms of xanthoma. Okay, so xanthelasma are usually near the eye. If you see free-floating gooey lipid material, you can think of eruptive xanthomas, which do have correlations with different lipid abnormalities. And obviously, looking at the histology, once you think it's a xanthomatous type process, finding out what the clinical scenario is often really helpful in deciding if they need to go and do more workup for the patient to rule out a lipid abnormality. All right. Ooh, so cool. If you don't get excited about this, man, I don't know what will make you happy in life. What's that? Yeah, right. We don't even have to go closer, but we will because it's awesome. It's the mother of all hair follicles, is what Dr. Rapini would say, the hen and chicks, right? It's a big dilated central follicle, and it's got little tiny baby immature follicles around the outside that are draining into or emptying into the big cystic follicle. Classically, these are described as a big crater opening up to the skin surface. But like anything that is a crateriform lesion, if you cut it right down the middle, you have to think in 3D, cut it down the middle, it'll look like it opens the surface. I guarantee you this will open the surface, we have to section deeper into the block, or else we've already sectioned too far. And so what happens is, and this is true in molluscum or any of these kind of crater-shaped things, in some of the keratoacanthoma type squames, if you cut just a little away from the center, they can look like a cyst in the dermis. So it's real important to recognize that cyst in the dermis and umbilicated crater-shaped lesion, same thing, just sectioned differently, okay? And the central cyst will look very similar to like a follicular infundibular cyst, or what some pathologists call an epidermal inclusion cyst. and it'll have a granular layer and flaky loose keratin. And then looking around the outside, you can see little follicles, and you've got matrical basaloid cells. You've got the inner root sheaths with those beautiful bright red trichohyalin granules, and they empty into the center. And you can even see there's little hair follicle, I'm sorry, hair shafts in there too. See, there's making hair shafts. So it's actually a relatively well-functioning follicle. Here's more of the follicle here. You'll see little papillary mesenchymal bodies or little mesenchymal stuff around the roots. And a lot of times if you look from lower power, you can see that the whole lesion tends to be, it's a little harder to appreciate here, but it tends to be wrapped in a fibrous stroma, which is analogous to the adventitia that lines around normal follicles. Many follicular tumors have that fibrous kind of cellular stroma, as opposed to basal cells, which get that more myxoid, mucinous, loose stroma, right? So I think that's a nice clue for follicular neoplasia when you see this kind of pink stroma that's separating the tumor from, like, see, here's the rest of the dermis out here and over here. And if you go way back, you can kind of almost imagine this is like the border of the lesion. Out here is like where the stroma goes. It's like a circle around the whole thing. And I feel like it's a little harder to appreciate unless you've seen it up close, but I think that's actually a really useful clue that helps me with follicular neoplasms. So trichofolliculoma. All right. And here is skin from where? How do you know? That's a good, yeah, hair follicles. And what else? What's down there? Skeletal muscle is usually down below the fascia, which is below the subcutis, which is below the dermis. So anywhere else in the body, you're going to have to go a mile deep to get down to skeletal muscle. If you see skeletal muscle getting up into the dermis, you're almost always on or near the face, the platysma of the neck, scalp, somewhere in that region. So it's a good way, it's good to learn those little clues that help you. What if you see a bunch of smooth muscle in the dermis? Like more than usual for the amount of erector pilot. Like you normally see a couple strands of smooth muscle, but what if you see a bunch of smooth muscle in the dermis? Where are you? Genital skin, right? Or nipple areola, labia majora, scrotum, okay? Those are the areas that you are. So it can be really helpful, especially on an exam. If they're not giving you history, you can kind of cheat in a way by saying, oh, look, I know this got to be from the nipple. Or if you see squamous mucosa with a bunch of skeletal muscle, you're on the tongue. So you can really narrow down your differential by knowing, oh, well, I know that this, and this won't occur in this site. So it's a nice way. And in real life, too, it can help you when something gets swapped and you accidentally get something cut and they said it's from the forearm and you're like, I don't think so. Don't ignore that. I've sometimes been like, and blew it off, and then later found out, it was a swapped slide and I had to go back and amend my report and, trust your gut. Okay, so anyway, after that, a little walk down memory lane. Here we have something, right? This is an abnormal something. And how would you kind of describe these? Tadpoles. Oh, that's the best, right? Little cords or strands of epithelial cells in the dermis in tadpole shape or sperm shape, if you like that analogy better. You got to find the visual analogy that works for you, no judgment. That's what my derm residents would say, sperm in the derm. Sperm in the dermis is the way that they remembered tadpole pattern, or if you're a little more classy, I guess you could say paisley tie pattern if you're old school. I don't know what a paisley is. I know what it looks like, but I don't know why it's called that. But anyway, these little cords in the dermis. So what's the main differential for this pattern? There's like 4 things people usually talk about. And what are they? Yeah, MAC, microcystic adnexal carcinoma, desmoplastic trichoepithelioma, morpheoform or infiltrative pattern basal cell, and syringoma. Very good. So it's really useful to recognize this pattern and know those things are on your radar, okay? The problem is that we don't usually have this nice huge excision going all the way down to fascia. We usually get like this, a little shave, and I get like 3 of these guys, okay? And that's really challenging, all right? So the way that helps me is if I see obvious ducts up here and they look tadpole shaped, it's almost always gonna be a syringoma, okay? MAC has ducts also, microcystic adnexal carcinoma, and it's a locally aggressive form of carcinoma. It's important not to miss. It's rare, but it's important not to miss. And it does not look atypical. It looks bland, okay? So it's really hard to diagnose. It has ducts too, but the ducts are usually down deep. There are some exceptions. So the main thing I want to rule out is MAC. And then basal cell, I find most of the time you're going to see some islands of traditional classic basal cell. If you get a big enough biopsy, usually it's there, or there'll be a little mucin or a little cleft, something that'll tell. I feel like that's the one that's usually the easiest to rule out. Okay, so what I usually get down to is I'm between desmoplastic trichoep and MAC. And on a shave, I have a very difficult time reliably telling them apart. So usually if I have a transected desmoplastic trichoepithelioma, I'll tell them I'll say basaloid neoplasm of the dermis. I favor DTE, but I can't totally exclude MAC. I'd recommend an excision. And this happens like once or twice a year. It's not a common thing. And I would rather have a few patients get maybe more surgery than they need for a desmoplastic trichoep, but not miss a MAC. That's what I want if it were my face or my wife or my kid's face. So that's the way I handle those cases. But what you see here, both in MAC and desmoplastic trichoep, you see the tadpole-shaped cords. The stroma tends to be kind of fibrotic in the background, and you see these cysts. These cysts are keratinaceous cysts. They're little tiny keratin or follicular microcysts, okay? Again, MAC, you will eventually usually see tubules. In real life, I think it's quite hard to appreciate. It's also hard because sweat ducts can get entrapped in the middle, and they do have ducts, and then they look like tubules. So I think it's hard. People have described all sorts of different stains to try to sort these out, like cytokeratin 20, which I've occasionally found useful. It will stain scattered passenger Merkel cells in the background of desmoplastic trichoep and other follicular tumors. And those cells are usually not present in the background of MAC or basal cells. So I found that useful occasionally, but most of the time on a small biopsy, no matter how many stains I do, I'm still gonna hedge and still gonna tell them to re-excise. So I usually just don't mess with it, and I just say, here's the differential, re-excise. I feel like a big enough sample and H&E is what I need more than a bunch of extra stains. So that's my personal practical approach, but you can read the literature. There's lots of, the fact that there are so many stains described to sort this out tells you that none of them work perfectly well and that it's hard. That's what Dr. Rapini said. You got a bunch of different treatments for something, it's because none of them work very well. And I think the same is true for stains. When we have to keep investigating new stains, it's because they're all suboptimal in some way or another. This is a good example of desmoplastic trichoep because we can see the tumor's limited to the dermis. If I see perineural invasion, even though that has been described in desmoplastic trichoep by very good dermpaths who I like and trust, it still doesn't sit well with me in my soul. I just don't like that idea of seeing perineural invasion of desmoplastic trichoep. Usually that's a feature that makes me strongly favor MAC, okay? So here's desmoplastic trichoep. Challenging diagnosis. And what's that one? Another beauty. Trichoadenoma, yeah. And they're basically a bunch of tiny little keratinaceous cysts that are all relatively even-ish in size, and they're all packed together in the dermis. And look from here again. Look at that stroma. See how it's got, you can see that's where the lesion ends. Out around the outside of the whole thing, it's encased in this fibrotic stroma. Again, that's analogous to the adventitia, that outer fibrous layer around normal hair follicles. Go look at a hair follicle sometime. If you've never seen that before, there's a little band of fibrous stuff around normal follicles, and that's what's getting recapitulated here. Follicular tumors, I think, are the hardest subset of adnexal tumors because there's so many of them, and I think Dr. Rapini had a huge influence on my career also. I got to spend a couple months with him in residency in Houston. And I love what he says. He said they're like snowflakes. Each one is a little bit different. It's so true. There's no two that are quite exactly alike. They all have slight differences to them each time, which makes them more challenging to classify. Fortunately, most of them are benign. One thing you can see in anything with keratin microcyst is this granulomatous reaction to keratin debris. You can see that in any keratinaceous, keratin-producing thing. If that keratin breaks out, gets into the dermis, keratin's fine as long as it's outside the body. Once it gets down past the basement membrane and into the dermis, the body is really unhappy about it. And so some people compare these to donuts. My program director, Doug Parker, like to say if you go to like Home Depot and you look at the aisle where they have like PVC pipe, you know, those plastic pipes, you look at a stack of PVC and it looks like a bunch of PVC pipes stacked up. And I thought that was actually a pretty cool analogy. So if you're into like building and stuff, maybe you like that better. I like donuts too, so. You know. Trichoadenoma. And sometimes you can get cysts like this in trichoepitheliomas. The difference there to me is if I start seeing basaloid aggregates, either little strands of them or more nodular forms that look almost like a basal cell, then I start thinking more towards it being a trichoepithelioma. Guess what? It matters 0% for clinical care, okay? If a person has a solitary trichoep or a solitary trichoadenoma, it doesn't matter what you call it. Splitting is fun, but you know, don't lose sleep over splitting benign things that are treated the same way and have the same prognosis. Save your hedging and your worry for times where it's like spitzoid melanoma versus Spitz nevus. That's the time to hedge, okay? Don't waste it on, well, it could be a verruca, but it could be a seb, and there's overlap. No, it's the best seb I've ever seen. Definitely, there's no doubt at all. And then you can save up those hedging points for when you really need it for patient care. So I think that's a good take-home point. Practical pearls. Because in the real world, after your tests are done, that's the stuff you think, gosh, what do I say? I think it's this, but how sure am I? How do I word my report? And man, you'll wish you would have asked your attending a lot more questions. I sure do. I'm like, gosh, why didn't I think about that and ask more and beg to look at every slide in their recut set? So look at this. Okay. Got a kind of a funky, weird looking lesion here. It's papillomatous on the surface. It's ulcerated a little bit. And it's got these kind of clefting spaces pushing down that have little islands floating in them. So what's this? Yeah, this is SCAP, syringocystadenoma papilliferum. That's why we call it SCAP, because it's too long to say all the time. And so the low power is you've got papillomatous and or ulcerated surface, these kind of branching dilated duct spaces that push down into the dermis, and then papillae in the duct spaces. And for those of you who are more junior residents, papillae mean finger-shaped structures, okay? Like this thing is kind of finger-shaped. See, it goes up and down, but these are also finger-shaped, just cut in cross-section. You can't see where they connect. So floating islands that are lined on the outside by epithelium sitting in a space, that's papillary, okay? And I mean, if you're a senior resident, you already know this, but junior people, that's, I think, an important take home. And if you look at the lining is made of a double layer of cuboidal to columnar lining. The inner apical cell layer tends to be more columnar. It may have little apical snouts on the top, those little nubs of pink cytoplasm. The basal layer tends to be like a myoepithelial layer and more small and round and cuboidal. But this is analogous to sweat ducts. The only place you really see double cuboidal to columnar epithelium is salivary ducts and sweat ducts, okay? So when you see this, it's a strong indication you're dealing with some sort of a sweat gland tumor. And look at all of this inflammation packed in the middle here. What are these cells mostly? Plasma cells. Oh yeah, it's loads of plasma cells in this lesion. And if you find this on the scalp, what's a good chance that you'll find if you look around in the periphery? Nevus sebaceous of Yodison, that's right. So nevus sebaceous is like a fertile ground to give rise to all these weird adnexal tumors, SCAP being one of the most common ones. I've got a YouTube video about this entity. If you're real bored, you can check that out. So I put videos of pathology stuff on YouTube for any of you guys who don't know. So eventually I'll cover all the entities and then I'll retire. But until then, I probably better keep working. All right. And occasionally they can occur off the scalp, but the vast majority of them are on the scalp, okay? And here's a lesion that's a nodule down in the deep dermis, relatively circumscribed, and it's got cystic spaces and lots of papillary structures folding into the middle of the cystic spaces. And if you look closer at the lining cells, you'll again see that kind of same thing that we saw in SCAP. I think there's a lot of overlapping between this lesion and syringocystadenoma. And you'll have the inner columnar layer with little apical tufts or snouts. You'll have an outer basaloid layer that's usually got myoepithelial differentiation. So what's this lesion probably? Yeah, hydradenoma papilliferum, the happy pappy, as again, my derm residents teach me all of the most awesome and sometimes inappropriate ways to remember things. So anyway, so I give them credit and blame for all of the things I'm teaching you. I'm just kidding. And not only future, so no one's incriminated, future and or past derm residents have taught me these things. All right. Hydradenoid papilliferum is almost always in the vulva. A couple other things that can look kind of like this. If you're on the nipple and you see papillomatous stuff that's growing in cystic, think about nipple adenoma, okay? And depending on whether that's small and localized to the skin or deeper and involving the ductal structures of the breast, intraductal papillomas can have very similar features too. If you see something on the hands or fingers or toes that looks like this or looks like SCAP, what is it until proven otherwise? Yeah, digital papillary adenocarcinoma, which used to be called aggressive digital. People have suggested we drop the aggressive name because it's carcinoma, it metastasizes in like 20 or 30%, but it's not like it kills 90% of people. So it's not much more aggressive than other regular carcinomas, I guess. Anyway, so if you see papillary structures in an epithelial lesion on the hands or feet, you've got to exclude digital papillary adenocarcinoma. They don't always have cytologic atypia. In fact, I feel they more often don't have it than do. And they really otherwise would look benign, and yet they can still metastasize. Real important not to miss that. I was giving a talk a couple years ago, and right the day before I gave a talk, some lawyer called me and wanted me to testify on a lawsuit on a patient got a misdiagnosis, and they got a met. And I was like, no, I'm not real into that, but thank you for the offer. But it was great to scare the crap out of the people I was about to give my lecture to. So yeah, just yesterday, someone called me about a misdiagnosis of this, and they're suing someone. So it's just real important to know, because it doesn't necessarily look malignant. Just keep that in mind. Any adnexal tumor on the hands and feet, always think about that, especially if you see papillae. Real important. Okay, but this is okay. This is hydradenoid papilliferum. We're fine. All right. So what kind of a little nubbing are we dealing with here? It's like a little bump on the face. You can tell anytime there's a little dome with a flat, it's almost always a bump on the nose, and they thought it was a basal cell, like every time, right? Yeah, it's something sebaceous. So then we got to decide where. There's not very many options in the sebaceous family. Unfortunately, sometimes sorting out which option can be challenging, even though there's not a lot of options. The main options are sebaceous hyperplasia, right? Which is basically big, huge, very mature looking sebaceous glands, very white appearance, okay? And then there's sebaceous adenoma and sebaceoma, which to me are on a spectrum and is just splitting of, not splitting of hairs, splitting of sebaceous glands, I guess. If you have more than 50% blue basaloid cells and less than 50% of the white mature bubbly cells, you can call it sebaceoma. If you have a predominance of the bubbly cells and fewer of the basaloid cells, you can say sebaceous adenoma. It doesn't matter, okay? And then there's sebaceous carcinoma, of course. This is a small lesion. It looks like they got most of it with the shave. I think arguably there's more than 50% bubbly cells here. And you can't really see the bubbles real well, but there are little vacuoles and they're clear because they're filled with lipid and they dent into the nucleus. It's the same kind of rule I use for cebocytes as I use for lipoblasts, okay? In the soft tissue, an atypical cell that's in a mesenchymal tumor that has clear bubbles and indents the nucleus, those are lipid droplets and it's probably a lipoblast. In an epithelial tumor, bubbles that indent the nucleus usually are gonna be sebaceous. I do see squames that are vacuolated that seem to just be squame and not sebaceous that do actually have true bubbles though. So I've come to doubt myself over time with that. But anyway, this I think is a sebaceous adenoma. And we usually in our practice include a comment in the report that sebaceous adenomas are sometimes associated with Muratori syndrome, okay? What's Muratori syndrome? Yeah, it's a mismatch repair. It's basically hereditary non-polyposis colorectal cancer syndrome with the addition of sebaceous tumors of the skin, okay? So sebaceous adenoma, sebaceoma, and some sebaceous carcinomas, when they're off the head and neck usually, can be associated with that. Sebaceous hyperplasia has no association. We don't routinely perform the stains for the mismatch repair genes, but we will do it upon request. Different people have different ways they handle that. So we just usually put that comment in the report and let the treating physician decide how they want to address it depending on the patient's clinical situation. I find that you should not have marked atypia, you should not have atypical mitosis, and you should not have infiltrative growth. Those are worrisome signs for sebaceous carcinoma. The problem is that mitoses are often found. And I was giving a lecture one time and I couldn't find a single sebaceous adenoma in my entire collection, which is pretty extensive, that didn't have a mitosis. And that, to me, that either means I misdiagnosed a ton of sebaceous carcinomas, which I think is probably not the case because no one yet has come and say that, or it's just that mitoses are there. So don't get freaked out by a few mitoses in these. And the basaloid cells, they look blue and basaloid. That's normal, right? That's what normal sebaceous glands have. So it can be a little hard to tell like how much is atypia enough. And if I have one that's a little funny looking and it's shaved across the bottom and transected, sometimes I'll say, I think it's a sebaceous adenoma, but it's got some atypia. Please do an excision just so I can see the whole thing. Because I did have one once that I thought was sebaceous adenoma and it recurred and it was actually a carcinoma, but on a superficial shave didn't look atypical at all. So I don't routinely recommend these be re-excised, but if I have something concerning and it's broadly transected, again, it's one of those things that doesn't happen that often and I would rather just have them go and make sure that we're seeing the whole thing than miss something serious. All right. Here's a tumor that's bulging down off of the epidermis. It's very blue and basaloid. I would argue those are quite atypical, very large hyperchromatic cells, and look at all the bubbles indenting the nuclei. Not nearly as well-formed bubbles as a normal mature cebocyte, but this is probably sebaceous differentiation here, and I would say this is probably sebaceous carcinoma. Telling sebaceous carcinomas apart from squames and other adnexal carcinomas can be challenging sometimes, and there's a bunch of different stains. We use factor 13A sometimes, the AC1A1 clone, for some weird reason, stains the nuclei of cebocytes very strongly in most cases. It's not perfect because it will stain some squamous cells and other things, and it only works with that clone. But I published that, and it's like my one contribution to medicine, so I'm waiting for the Nobel Prize Committee to call me up one of these days. But in any case, it's not true factor 13A expression. It's just some weird cross-reactivity, but it seems to be relatively sensitive and specific. EMA will also stain them, but EMA stains a lot of things, okay? The key is the EMA is it should highlight the individual vacuoles. Some people use a dipafillin to do the same thing. Again, the fact that we have so many stains, none of them are perfect, all right? The clinical is important. Anytime you've got a weird-looking carcinoma anywhere near the eye or the eyebrow region, always think of sebaceous carcinoma, particularly if it's not like a straightforward squamous. It's a real ugly looking squamous or basaloid thing. You have to exclude sebaceous carcinoma, and they're going to treat that differently because sebaceous carcinoma tends to grow up into the epidermis, particularly when it's near the eye, and it can grow way back in the conjunctiva in a pagetoid fashion. So the ophthalmologists or surgeons will go and do like scouting biopsies to decide they'll treat it differently than a squame. So again, off the head and neck, well, they're just going to do a wide excision, but they can be a little more aggressive than other tumors. But near the eye is where it's a particular issue to be aware of, okay? And the ones near the eye are not usually associated with Muratori syndrome. The ones away from the eye, particularly if they're on the trunk or the extremities, many of those are Muratori associated. Okay, sebaceous carcinoma. You guys hanging in there? We surviving? It's hardcore. All right. This is very busy. Let's see if we can find out where we are. We got some smooth muscle here, and somewhere on here. But now I won't find it, of course. Well, there's apocrine glands somewhere. Okay, I promise. Okay, maybe there's not. I don't know. I thought there were. Anyway, we're in the groin. I don't know. I don't know which gender the groin we're talking about, but the epidermis is acanthotic. It's expanded here, and it's very busy because it's got all these large cells with vacuolated pale cytoplasm. So what is this? Well, that's your differential, right? We've got big cells that are atypical trickling up and spreading up into the epidermis. So it's something with pagetoid growth. So the differential is Paget's disease, either Paget's the nipple or extramammary Paget's, they look the same. Bowen's or squamous cell carcinoma in situ, which is in fact the most common pagetoid thing I see just because squames are so common. And then also melanoma. The site is a big thing. If you were in the vulva or anywhere in the anogenital area, it's Paget's until you prove to me with a good immunostain that it's not, okay? And in other sun-exposed sites, I've seen Paget's or Paget-like things like 1 or 2 times in like the extremity of an old sun-damaged arm. Really rare, okay? Certainly not common. And near the nipple, you've got to rule out internal malignancy in Paget's. In the anogenital area, many of the times they're primary extramammary Paget's, meaning they're arising in the skin, but not involving the internal organs. The biggest thing that I think is important is if you have Paget's around one of the openings, either right around going all the way up to the anal opening, or the urinary meatus, or the urethral meatus, or the vagina, you've got to make sure that there's nothing internally. If it's on the scrotum but doesn't come anywhere near one of the orifices, then the chance that it's spread from an internal thing out is really unlikely, okay? But it is important to know. And these will usually stain with what? What kind of markers will stain Paget's disease? Yeah, I like CK7. It's my favorite. What else? CK20 will sometimes stain only usually near the anus, okay? And that's probably because embryologically the glands around the anus are derived from that same endoderm, the posterior cloaca or something like that. It's the same area that gives rise to the rectum. And so just like rectal mucosa stains with CK20, sometimes extramammary Paget's can be CK20 positive, but not be actually from a rectal carcinoma. So don't make that mistake of say, oh, 20 is positive, it's gotta be spread from the inside. You probably, if there's any doubt, have them scoped. But CK7 is the best, CAM 5.2, a low molecular weight keratin, some people like CEA, all those things, okay? And usually, I think you can, well, it's not a real good example of eyeliner sign. Usually there's a little layer of normal keratinocytes underneath, and the epidermis is getting filled up with pagetoid cells above. Sometimes you can see little mucin droplets in them, so you can do mucicarmine or mucin stain to see the mucin. Sometimes they actually form little glands, and occasionally they can invade out of the epidermis down into the dermis. And when there's a focal invasion, it seems like the behavior long-term is probably the same. It's probably not like a high risk of getting Mets or anything. We've seen that a handful of times in those patients who are still alive and well 20 years later, still struggling with their disease. Local control is a big problem for Paget's. They either radiate or do a huge surgery. It's not an ideal thing to have in the anogenital area, but it doesn't usually kill you. What's that? It's that low power silhouette. What's that? Yeah, that's a poroma, right? We've got a nodule. This one's even got like the little gutter, or what's the word that you guys use? Yeah, it's got a collarette, and it's got like a little channel, a furrow around the outside, a little groove that's dipped down in, and the lesion is bulging up. It's often ulcerated or inflamed or crusted on the top. Okay, and you have this really marked acanthosis, proliferation of the epidermis of these small little round keratinocytes that are pushing way down, and sometimes it'll be thick like this. Sometimes they're actual finger-like extensions that are pushing down from the epidermis into the dermis. And when you look closer, these cells are, yes, they'll be ducts. These cells are very round nuclei. They have a little bit of cytoplasm, and they can have some clear cell change. The bits of stroma in between, the bits of papillary dermis that are entrapped tend to be very edematous. See how white and clear that is? very edematous, and also very sclerotic. They'll have dilated vessels, they'll have sclerotic collagen or basement membrane material, real dense pink stuff, and they'll have edema. That dense pink stuff goes along well with many different sweat gland tumors and even other adnexal tumors. Here's some right here. This is like basement membrane material laid down in here, big dilated vessels, edema, inflammation. Those are common findings. And then finding the ducts can sometimes be hard, but like in this case, it's worth looking around. So you look for tiny little holes. The big spaces end up usually being vessels, actually. So don't say, oh, look at the duct. That's actually a vessel because it's surrounded by dermis, see? It's a little space, and then it's got dermis or collagen around it, say there too. It's a vessel. It's got serum, blood cells, and then it's got its own little bit of collagen around it. A duct is not going to have collagen around it because it's being formed by the epithelial cells. That's probably a duct, a little tiny hole, and sometimes you can see a little pink layer we call cuticle that lines the inside of that. If you really want to prove it, you can do like a CEA or an EMA to highlight those little duct spaces. Some people have shown that c-KIT expression is seen in poromas and porocarcinomas. A lot of times I just diagnose it on H&E. And again, the differential would be like, is this a funny seb? Inflamed sebs or inverted follicular keratosis, those can look quite a bit like poroma, and the difference is they're all benign things, right? Because poromas are cooler, and so we like to diagnose those when we can. Poroma. And I believe poromas are etiologically on a spectrum with hydradenomas. I think they're like in the same family because you can see areas that look very much like hydradenoma in poroma. You can see hydradenomas that connect up to the surface and on the top look like a poroma and on the bottom look like a hydradenoma. So I believe they kind of all belong to the acrospiroma family. And again, derm paths love to split and resplit and then argue and fight with each other about who's splitting is right. But it doesn't matter. If it's a benign sweat gland tumor, it's okay. Just breathe and let it go. It'll be fine. Okay. Poroma. Here we've got nodule and big cystic spaces. So what's that make you think of? Yeah, hydradenoma tends to have nodules, cyst spaces. The cells tend to be either pink and squamoid in appearance or clear. Clear cell change is common. Hydradenomas have a wide range of appearance. If you see something that you think is a sweat gland tumor and you're not sure what to classify it as, your best guess should be hydradenoma or mixed tumor because they have a wide range of features. And when you're like, I'm pretty sure this is a sweat gland tumor, then those are the two things you should go towards because they really can have a wide range. So here's that dense sclerotic stuff. This is basement membrane. Here the cells have a little bit more of a squamous appearance with a pink cytoplasm. Sometimes the pink can be real abundant. And then here you're getting more of that clear cell change, okay? And in the middle, you could say, ooh, that looks kind of infiltrative. In the middle of sweat gland and follicular tumors, sometimes you can get real busy areas that look infiltrative. And so if you get a fragmented partial biopsy, that can be challenging. So looking at low power on a full excision, you can see actually this is quite well, even though it's big, it's pretty well circumscribed. So that's reassuring. All right, and here's the cystic area. And the cysts are actually ducts. This is actually whereas you get tiny little ducts in poromas and spiradenomas and cylindromas, the duct spaces in hydradenoma tend to get massively dilated and turn into these cysts. So cysts are there. You'll often have this double layer of kind of cuboidal or columnar epithelium on the outside. Again, oh, look at that basement membrane. So good. Whoa. Collagen type 4. Okay. So that is a hydradenoma or acrospiroma, if you like that name better. And again, I feel like no one teaches this, but I'd say 10 or 15% of cases I see, maybe more, probably a little bit more because we referral bias people, send them in consultation when they connect to the surface. They connect to the surface sometimes. Hydradenomatous papilliferum also does. I know people say it doesn't, but I see it do that on occasion. Maybe I should be calling those hydradenomatous papilliferum like SCAP and then write a paper about it, but I'm not going to do that to you guys because that's cruel. No laughs, okay. Too real. Maybe in a couple years you'll think it's funny. All right, hydradenomatous. Tough crowd. All right, here we've got blue balls in the dermis, right? So the answer you already know is big blue nodules down in the dermis. Spiradenoma, yeah. And spiradenoma is like blood brothers with what other tumor? Cylindroma. They're like twinsies. They can occur right next door to each other and merge into one. They're like the same two expressions of the same thing, okay? And they're both, even though the name spiradenoma can sound kind of like hydradenoma or acrospiroma, they look totally different. They're much more blue usually, whereas hydradenomas are usually pink or clear, pale looking. Spiradenomas cylindroma are very blue because they have round nuclei and very little cytoplasm, right? And people like to say that there's two cell types. And I think it's true, but I feel like it's kind of subtle. And actually, even though we teach it, I feel like it actually causes maybe a little more confusion for trainees. But since everyone else teaches that, I probably better too. You can kind of see vague nests in here. See how that's kind of a nest? And then this is one, they're like these nests or trabeculae that are all packed together. And around the outside of the nest, you have these little round, dark nuclei. And in the inside, the nuclei get a little bigger and more pale. I think it sometimes is obvious. Most of the time it's subtle. And I feel like it's probably something that you can appreciate after doing this for a while. But people getting ready to take the boards, it's not nearly as helpful as, is it blue? It's a spiroadenoma. Does it look blue in puzzle pieces? It's a cylindroma. Okay. Does it have cyst and clear cell change? It's a hydroadenoma. In real life, it's a benign oma, and it doesn't matter, okay? I'm not trying to be like diagnostically nihilistic. I'm just saying that when they're all benign, it's fun to like talk about all the things, but in the end, don't lose sleep over that or concern your clinicians over that with, you know, saying, well, there's really overlapping features here between, it's gonna be okay. Just let it go. Spiroadenoma, I got a video about that too, I think. If you're bored, all right. Okay, we can do it. This is like my 6th lecture this week, I think, or something. I lost count. All right, here we got a nodule down at the subcutis, probably on the face, right? Big, huge sweat, sebaceous glands and follicles. And this tumor has a very unusual appearance, right? It's got cystic spaces, kind of some nests or islands here, this bluish, weird looking color, some purple stuff. Very unusual. Look closer. Those cystic spaces really are true cysts lined by a layer of epithelial cells, right? If you see a white space in tissue, it's got to be one of 3 things. It's either got to be an epithelial lined space, which means it's a gland or a cyst, or it's got to be a lymphovascular space, meaning it's lined by endothelium. So it's either lymphatic or a vessel, or it's an artifact, whether because there was lipid there that washed out, the tissue ripped or tore during processing, there was foreign body there that fell out. So that's something Dr. Rowe, again, one of my great mentors that made me decide to go into academics, and he's a general surge path, but he taught so many great pearls, and that's what he said, there's 3 things. If there's clear white space, it's one of those 3 things. And so far, I've found that to be pretty true. So anyway, here we've got spaces lined by columnar epithelial cells, so true epithelial differentiation. So again, you see spaces like that, and the dermis, you're probably dealing with a sweat gland tumor. Always do keep metastases in mind, especially if you start seeing atypia. Metastatic adenocarcinomas of the skin can mimic sweat gland tumors. What if you have only one stain to use to tell apart a primary sweat gland tumor from a metastatic adenocarcinoma from one of your internal organs? What would you choose? CK will stain all of them. CEA will, I don't even know because I don't use CEA that much. It will stain many things. The answer is P63 or P40. Okay? P63 is what's been published in our experience. P40, which is a variant isoform of P63. The vast majority of primary adnexal tumors, both benign and malignant, will stain strongly in the nucleus with P63 or P40, just like basal cells and squames do. Adenocarcinomas from visceral organs tend to be negative. A small subset of lung adenos can stain with P63, and even P40 rarely, but it has been reported. But so it's real helpful. You got strong diffuse staining for one of those. That strongly argues against the MET from someone's colon or stomach or anywhere else internally. Because again, a primary tumor of the skin, even if you think it's malignant, they're going to do an excision with a negative margin. A MET from the lung, the patient has stage 4 cancer. Huge difference in prognosis, huge difference in everything for the patient. Okay, cystic spaces, lined by epithelial cells, nests of epithelial cells. And then what the heck's going on here? What's that? Yeah, it's cartilage, right? You can see little chondrocytes in lacunae. There's actual true cartilage right there. But the rest of it, and what I tend to see more often is this chondromyxoid. It's kind of myxoid, mucin, cartilage-y mixture. It's kind of a melange of all those things together, okay? So when you see obvious cartilage or even bone formation, that's awesome. But I feel like that's only in a minority of cases. More often I see myxoid stroma or myxoid kind of chondroid stroma or adipocytes scattered in the background of a myxoid stroma. And then you tend to see these cells here, these kind of funny looking polygonal or epithelioid cells that are sitting there in the spaces out here in the chondromyxoid stuff. Sometimes they get clear, sometimes they get spindled, sometimes they make little clusters or nests, like you can see kind of right here. So there's kind of an ill-defined cluster. It's not making a gland. So what kind of cells are these? Very good. What would they stain with? They do tend to stain with P63, and they classically in myoepithelial tumors and mixed tumors, which is what this is a mixed tumor, or also known as chondroid syringoma, a name I don't like because this does not look like syringoma at all, okay? So that name should be right out, but people still use it. It doesn't look like tadpoles to me, but it's chondroid only part of the time. So anyway, mixed tumor chondroid syringoma, which is basically like the cutaneous analog to pleomorphic adenoma of the salivary gland. is an epithelial and myoepithelial tumor. The myoepithelial part tends to differentiate into soft tissue stuff like bone and cartilage and myxoid gooey backgrounds, okay? If you see marked atypia, be careful for malignancy. You can have malignant myoepitheliomas or myoepithelial carcinoma arise out of these. And so if you see a lot of atypia, beware of that. And also do know that myoepithelial cells stain with S100 strongly, and they can stain with SOX10 also. And I've seen something got misdiagnosed as a melanoma that was actually a myoepithelioma, soft tissue. And they just did an S100 and said, and the guy got a sentinel node. It was a long time ago, but it can happen. So keratin and S100 co-expression is seen in almost always in myoepithelial cells and myoepithelial tumors. In the tumors, the actin and the other myoepithelial markers are less likely to be positive. So if actin's negative, doesn't matter. Those are still myoeps, okay? So just know that myoepithelial tumors are kind of a hot topic because they can occur in soft tissue. They can be malignant. Chris Fletcher, Jason Hornick have published a lot about the soft tissue ones, and Christina Antonescu also. And some of them have Ewing's gene rearrangements, actually. If you're ever in doubt about a gene rearrangement and anything soft tissue-y, EWS is the answer, okay? It's promiscuous. It partners with everything. It translocates with all sorts of different genes. All right, so there you go. Mixed tumor. So here's a big nodule and inflammation underneath. Let's look at the top first. We got keratin cysts, and then we've got tadpoles. So we're back in that same differential. DTE, desmoplastic trichoep, microcystic adnexal carcinoma, basal cell, or syringoma. Well, probably too big to be syringoma. And also the keratin cysts don't go with that. Doesn't really look like basal cell anywhere else here, so probably not that. And again, like I said, that one I feel is like kind of they just added him to the list because they felt bad. Like it doesn't really look as much like the other tumors usually. And here, they're cords. You can't tell if they have ducts or not, right? I don't know. Is there a duct in there? Maybe. So as you go down, those are ducts, but guess what? That's an eccrine quill. It's entrapped. Usually when you go way down deep, the tubules will start to open up and show some duct spaces. But you have to hunt around sometimes for a while, and it can be quite challenging to see. And this is why it's really hard to diagnose these on superficial biopsy. See, those are like the little duct spaces here probably. Very hard. Sometimes immunostains can help highlight it. But here, you're invading way down into the fat. No way, desmoplastic trichoep. This is microcystic adnexal carcinoma. This one's almost like too good to be true. Like it's almost never this robust. It's usually much more subtle and much more trickly like that desmoplastic trichoep, only it'll be that trickly all the way down to like the nasal septum. It'll be all the way down in muscle and around nerves and to cartilage. It's out of control, but usually not this cellular. So don't expect them to all look like this. So that's microcystic adnexal carcinoma, locally aggressive, usually occur on the face, middle-aged women oftentimes, and they don't usually have atypia. If it looks infiltrative like that and marked will be atypical cells, it's almost certainly not a microcystic adnexal. It's probably an infiltrative squame, okay? Or maybe a basal, but a squame would be my best bet. Okay. Pink thing looks kind of busy, lots of stuff going on. So the key here is this. So what's this? Pilar cyst or tricholemal cyst or follicular cyst of the isthmus catagen type. There can never be one name, never. So how do we know that? We've got what looks like stratified squamous, right? It looks like kind of like the epidermis, but there's no granular layer and it transitions immediately into a dense sheet of packed, dense pink keratin, okay? Unlike the flaky keratin and the nice granular layer you get in the follicular infundibular cysts or EICs, in pilar cysts or tricholemal cysts, you don't usually have much granular layer and you get the dense pink stuff in the middle, okay? So once you've identified that, then let's look over here and whoa, what's going on? We got all sorts of squamoid looking islands, looks almost like a squamous carcinoma. If you see something that looks kind of like a squamous carcinoma and then find areas that look like pilar cysts, you're probably dealing with a what? Proliferating pilar tumor, proliferating tricholemal tumor. And even though this looks invasive, usually on a complete excision, you'll see all this busy stuff is in the midst of the cystic space. It's not actually invading out into the soft tissue, but again, on a fragmented partial biopsy, because these clinically look like cysts, so they often get just kind of chunked out, and then you can't see the edge. So I do think it's probably good to excise these. I believe Ackerman, at least at one point, thought that these should all be regarded as carcinomas, but I've seen ones that are really big and in young people and no connection to the epidermis, and to me, it doesn't make sense for them to be squames in the traditional sense. So I think they're benign and indolent, but probably good to have them excise the whole thing. In any case, though, all the busy stuff that was usually in the middle of the cystic areas. But finding those areas like this with that nice tricholemal pattern of keratinization is really the key. Proliferating tricholemal tumor, proliferating pilar tumor, whichever name like. Do we have to?
Yeah.
Yes, we do. All right. Look, nests. So melanocytic, right? I'm writing a basic derm path survival guidebook, and I foolishly decided to write the melanocytic chapter first, and I about gave up because it's just so much and so much controversy, and OMG, how can you simplify all that? So but I did it. I got it done. It's 45 pages long, so it's like half the book. So anyway, there's the nests, okay? The nests are down the tips of elongated reedy. There's bridging between reedy to reedy. There's pink fibrosis wrapping around the nest. Some people call that concentric fibrosis or lamellar fibroplasia because it's lamellar. It's like little layer after layer, like phyllodoe, right? Okay, maybe it got more interesting now. And then lymphocytes and pigment, oftentimes underneath. This is kind of the body's way of responding against the melanocytic lesion as it grows, okay? And I don't think there's much, maybe there is a little dermal component. Here's a little bit of intradermal melanocytes in the middle, and then the junctional stuff goes out to the side. We call that shouldering when you have several reedy of junctional stuff that go out to if you hold your arms out, you can do this at home in front of the mirror if you don't want to do it here. If the intradermal stuff's your chest, then the shoulders and upper arms are the shoulder, okay, of the lesion. So all those things I just described are the features that people say are go for what? Dysplastic nevus or Clark nevus or nevus with architectural disorder or whatever the heck you want to call these things, okay? The basic thing is some people get a bunch of atypical nevi clinically and they look like this microscopically, and those people seem to have a higher risk of melanoma. That's like the dysplastic nevus syndrome. What this means when you have occasional ones in regular people is hotly debated and probably not nearly as significant. And they're supposed to have some cytologic atypia, which different sources have defined as being various numbers of times the size of the basal or the mid-spinous keratinocytes. And you can read all that stuff in the literature and decide for yourself. The most important thing is making sure it's a dysplastic nevus, not a melanoma. And once you're sure it's not a melanoma and that it's a nevus, it's probably okay. And some people grade the atypia. I do because our derms like it. I'm not convinced that it is meaningful or that it's even reliable, but that's how I was trained and that's how most people around me practice. And I would rather be pragmatic in the name of patient care than be semantically pure. But a lot of you argue that these are not probably true dysplasia in the sense that they'll evolve into cancer. Most of them probably will not evolve into melanoma. I see melanomas grow out of regular nevi more often actually than dysplastic nevi. So in my experience, but I still do use the term dysplastic nevus and I do provide a grade, but you can, I think the advice I give to my fellows is when you go into practice, don't be all dogmatic and say, well, Dr. Gardner said, who cares? Just find out what your derm's like and what your group does. And unless it's totally abhorrent to you on a moral level, try to adapt to the language that's spoken by the people taking care of the patients. And if you can speak the language that they speak and get good patient care across, I think that's more important than being super meticulously accurate about what exact name you want for scientific purposes. That's just my approach. And you can take it or leave it. I don't mind. I don't want you to be dogmatic. But anyway, so this is a dysplastic nevus. And I think this is a really, to me, this is a real classic good example of dysplastic nevus. In my chapter, I start with psi ... in the dysplastic nevus section. Seriously, we'll see if the publisher will let me get away with it, but it just sums up all the ways I feel. All the feels. Okay, well, oh, that's it. There's your 2X diagnosis on the boards. You're like, done, and you move on. In real life, take a little more time, but what's that? Oh, it's so cellular blue nevus. Exactly. It's like it's the dumbbell, right? The bulging nodule of dense cellular nevus cells pushing down into the deep dermis or subcutis. Pigment sometimes is abundant, but actually I feel more often I see ones that are hypopigmented when I see cellular blues, okay? The thing is some books will show a picture like this and they'll call it deep penetrating nevus. And it's exactly what I would call a cellular blue. And they'll like call things cellular blue that I would call deep penetrating. And I used to say, oh, it's so easy to tell them apart. And then we did a study, which just recently got published. And I realized, and we did them back to back, it actually is a little more hard to tell apart than I thought. So arrogance is quickly cured with experience and one way or the other. But to me, I think this bulging dumbbell shape is really good for cellular blue nevus. And one of the things I find most helpful is, look, before we look at the cellular stuff, go up to the top and out to the sides in the dermis. And almost always cellular blue nevus will have stuff like this. And if I showed you a picture of that, that's slam dunk regular old blue nevus. almost always you can find a conventional blue nevus component at the upper periphery of the lesion as it interfaces with the dermis, spindle cells, bland, sclerotic background, pigmented melanophages in the background, and a little bit of dusty pigment of variable amounts in the spindled melanocytes, okay? So find blue nevus, and then in the middle, it gets cellular and dives down deep and makes a nodule. Awesome, cellular blue. This is one of those nevi that breaks the rules of maturation. Nevi are supposed to be more cellular at the top and get less cellular and smaller cells as you go down. This does precisely the opposite of that, okay? But don't worry about it, okay? And as you get down here, they're oval or even round cells, but they tend to be real uniform in size. You might get occasional mitoses, even down deep. That's okay. You don't want to see atypical mites. You don't want to see severe pleomorphism. If you start seeing real big nucleoli, you got to think about clear cell sarcoma of soft tissue and weird melanomas. There are melanomas that mimic blue nevi. So there are some other things. The buttock of a kid is the best place to see these, but I see them also in the extremities and other sites too. And our clinicians tend to usually like to excise them because a lot of times they'll broadly transect it and they go back and excise it. And I don't think I've ever seen a case that on excision was actually something more nefarious. But the most important thing is whatever name you use, deep penetrating cellular blue, they probably are different molecularly actually. These actually have GNAQ mutations, GNAQ, which goes along with blue nevi. And deep penetrating nevus, some of them at least have HRAS mutations, which is what you see in Spitz. They're probably related to Spitz nevi. So at least that's my general understanding. But the most important thing is weird benign nevus and not melanoma. That's the important take home. Don't call it melanoma, okay? Whatever name you use doesn't matter. Just don't call it melanoma because it looks so weird. And if you're not familiar with it, you're gonna see that and see some mites and you're gonna freak out, right? Don't freak out. Keep calm, put the case on your desk and come back tomorrow. And if you're still worried, send it for a consult, okay? Just not to me. If it's something real easy to diagnose, you can send it to me. Otherwise, send it to Raj, okay? Cellular blue nevus. And they strongly stain with HMB45. So that's the other thing. Have you guys heard of that? HMB45 is supposed to highlight maturation in nevi. I feel like it works really great in perfect classic nevi where I don't need it at all. And the more atypical and weird and diagnostically challenging it gets, the less easy it is to interpret, of course, right? Thank you, body, for making it hard for us. But the big epithelioid cells at the top of a nevus are strong HMB45 positive in the junction component. And as you go deeper in the dermis, you lose expression of HMB45. Blue nevi break that rule though. They tend to be diffuse strong HMB45 all the way down. And what is the HMB45 is human melanoma black. That's what it stands for. Try that out at a cocktail party. See what happens. I don't know where the 45 comes from. Probably some molecular weight or something stupid. But what's the antigen that it targets? Because it's always good to know both names, the antibody name and the antigen name, because you never know which one the boards will ask. And you can know everything in the world, but not knowing the alternate name, you miss the question, which is not cool, right? I don't write the questions. What antigen is being stained by HMB45? It's GP100. It's a molecule in the melanosome complex. So again, these things are nevi that make a bunch of pigment. They got a bunch of melanosomes. They stain strongly with HMB45. That's like panorama mode. Look at that. It's like a picture of Yosemite Valley that I took. That's pretty cool. All right. Here we got to think, let me stop. Look at this from low power. Even before you see anything else, this is a melanocytic lesion. I'll just tell you that's a little pale, but there are nests of melanocytes here. Do you think it's benign or malignant? Okay. Does anyone think it's malignant? I think it's malignant because I looked at it last night on high power. But also, what about it? It's broad. Yeah, that's one good clue. See, it's cheating. But I do all the time. If my derm that is not like somebody who's a first-year resident, they might go down to the fat with their shave and it might just be a nothing, right? But if an experienced derm gives me a broad shave, I'll look again if I don't think I'm like, why are they so worried about this, And so, yeah, when I see a big excision or a wide shave, I'm usually know that they're freaked out about it. It's asymmetric. This area looks very different than this. And that is not always proof of melanoma, but it is, and you got to really worry if you see asymmetry side to side. That saved me several times where at first glance, I didn't think about it. And then I was like, ooh, it looks really different over here than there. And I cut deeper and it's because there's a melanoma growing out of a nevus or something. So do some deepers if you can't tell. Here, thankfully, we don't have to do that. We just got a high power and see the marked atypia, the top of the lesion and the bottom of the lesion. You can't tell which side's up or down. There's no maturation there. The melanocytes in the epidermis are nested here, but with pagetoid cells, okay? And over here, look too, more pagetoid. Now, how do I know? Let's see if I can pull this off. Probably not. Every time I try, there's only one of the artifacts that I need in any given section. That's a fair thing. And the reason that you're thinking that is because there's a lot of cytoplasm in the cells. They're kind of big and epithelioid, and they're making big nests with clefts around them, okay? But I don't like all that pagetoid. You can have some pagetoid in the middle of a spitz, but a spitz should be nice and circumscribed. I guess you could argue it's circumscribed there. To me, this is too asymmetric. We got a ton of host response. There's some almost regression-like change, lots of inflammation. Again, it's patchy and spread out. Spitz should be usually real symmetric, very sharply circumscribed. But I think that's actually a good take-home. I often will look at a melanoma and think, am I sure it's not a spitz? Because it's one of those things, if you don't think about a spitz, you will go straight to melanoma. That's what Sophie Spitz did, right? Back in the 40s. She looked at these things in kids and said, these are melanomas of childhood, because until you know Spitz-Needus is a thing, nothing about that lesion looks benign. This cells look wild. And then only later he found, well, these kids do well, and actually most of them seem to be fine. And that's where I think it's an important point of history to remember that it looked atypical enough that it was published by a good pathologist as melanoma of childhood or something like that, and later proven to be benign with follow-up. So I think it's always good to think, is there any way that I can get out of a malignant diagnosis here? Is there any benign thing? Because that way you don't overdiagnose people with cancer. And I definitely think that spitzoid things can look a lot like melanoma. So that's actually a really good take home. And there's plenty of times I think about it and then I'm like, oh, they're 80 and they're sun damage. It's probably not a spitz, okay? But it's good to think about it, because if you don't think, you'll just blow right past that idea and you'll go straight to melanoma, okay? Same with Reed nevi, which people think are probably a variant of spitz. You'll go right to like moderate or severe dysplastic, and you'll get worried because they're big cells and there's bridging. And then once you're like, oh, it's a young woman and it's a dark spot and it's real circumscribed, and you're like, oh, I guess it's a Reed nevus, isn't it? So we don't have a Reed nevus today, but you can go look them up later. All right, so anyway, the one thing I was gonna tell you before I got off on that tangent is vacuolated cells in the epidermis. It can be hard to tell apart keratinocytes from melanocytes, right? And I think the one nice trick that I like, it's a little hard because this is faded, but the cytoplasm of melanocytes sticks to the nucleus. When the cells shrink during tissue processing, the cytoplasm all bulges up to the nucleus. Maybe a couple little strands of it will touch the neighboring cells, but because there's no desmosomes to hold it onto its neighbor, okay? Keratinocytes, their cytoplasm is full of what kind of filament? What do they stain for? No, keratin. Big, huge rope-like filaments of intermediate filaments of keratin. It's like reinforced concrete, rebar, right? It's like all of these huge strands of keratin going back and forth. It's not just there to make it easier for us to do immunostains. That'd be convenient. It's actually there for a functional purpose. And that purpose is it goes across the cytoplasm and it hooks onto desmosomes. And the desmosome hooks onto the neighbor cell desmosome, and that has keratin filaments that go across to the next cell, and that crisscross that times 10,000, and that's why your epidermis doesn't fall apart when you rub it. Okay? It's not just because it's got a basement membrane and hemidesmosomes holding it down. The whole network has to be strong. And the reason that's important is that when the cell shrinks, that cytoplasm, it ain't going anywhere. It's stuck to all of its neighbors. And what you get is a naked, sad little nucleus sitting here in a little hole by itself. It's a little halo of nothingness around the nucleus, and all the cytoplasm stuck to the outside. It's a little hard on this because it's faded, but I have a basic skin histology video, and right around like 7 minutes or 9 minutes into the video, I talk about this. But I think either John Reed or Victor Prieto, one of my, this is not my idea. I stole this blatantly from someone else. I just can't remember which someone else it was who taught me, but it's so useful. And so at first, I think a lot of trainees are like, how do you tell it's a melanocyte? If you see a blob of cytoplasm stuck to a nucleus, it's a melanocyte usually. Naked nucleus is keratinocyte, okay? Now, superficial spreading melanoma. The classic example that you think of as melanoma, superficial spreading. And in reality, I still use the subtypes because our clinicians like it, but it's pretty historical and doesn't really pretend much for patient care most of the time, with some exceptions like desmoplastic melanoma and other things. And so here we got an excision. What's wrong with that? Can anyone tell me the diagnosis from here? I'll give you a hint. It's an 80-year-old on the scalp. Here's one diagnosis. Maybe in real life there's other things, but I love you for thinking of that because I'm really interested in angiosarc, but no. Okay, maybe there's a couple possible diagnoses, but until the first and second and third thing you have to rule out when you see this pattern is pink stuff. And look up here. This is solar elastosis. This is this guy's normal dermis at 80, okay? In Arkansas, half the people have this. They're old white folks that have been working out on the farm or fishing their whole life, and they're really sun damaged, and their whole dermis is blazed with layer after layer of elastosis, like the polar ice caps 100 years ago when they were really thick, right? And then when you see the elastosis, look, it's going along. It's all blue, 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 blue. Whoa, gone. Now it's pink. No, that's a good thought too, but you're right to notice the lymphocytes. When there's pink collagen replacing elastosis, something has put new collagen down since the person got old, since they got sun damage. It doesn't work in young people or non-sun damaged people, but in blazed sun damaged skin, when you see pink fibrosis replacing dermis, it's either scar, or it's regression around the melanoma, or it's a biopsy site, or it's they picked it and it's healed. Something did that, and you got to figure out what. And in this case, yes, this is desmoplastic melanoma. Pink, going all the way down through the dermis, replacing elastosis, replacing much of the collagen, the fat in the subcutis, and all the way down to the freaking periosteum, the Galea aponeurotica. This is classic. This is what almost every desmo I see on the scalp goes all the way down to the skull, just like this. And they almost always have lymphocytic aggregates. So when you see scar-like stuff on an old sun-damaged scalp and lymphocyte aggregates, that's desmoplastic melanoma until you prove it's not. Do a SOX or an S100, they will stain almost always, and MART and HMB will never stain in pure desmoplastic melanoma. Some desmos have mixed areas of cellular spindle component or epithelioid regular melanoma component, but when they're purely desmoplastic, they will not stain with regular melanocytic markers. And what you'll see is you got the background is pink and fibrotic, and usually it's a little faded out here, but usually they have a little mixoid, bluish mucin and collagen in between the spindle cells. And the spindle cells don't really even stand out until you go to high power and see, look at that. The big hyperchromatic scattered guys, a little bit hard to appreciate the cytology here, but you start seeing large cells scattered about. But many of the cells will be bland and spindled and definitely can have areas that look just like scar, just like neurofibroma. Beware the scar on the old sun-damaged scalp. Beware a neurofibroma with inflammation on an old sun-damaged head and neck. Beware any spindle thing like that in an old sun-damaged person. Just do the S100 or the SOX so that you don't miss a desmo, okay? They can be real subtle. Only about half the cases have in situ over top of them. So that complicates matters further, okay? If you ask a soft tissue pathologist, because of referral bias, even fewer cases will have the in situ, okay? But if you find that, that's helpful. The lymphocytic aggregates are so incredibly helpful. Dr. Rapini said lymphocytes are like smart bombs. They can see like the antigens on the cells that we can't see, and they go into attack. So it's a useful thing. And see, look at the hyperchromasia. So scattered hyperchromatic cells are really helpful. If you start looking around, usually if you have a big enough sample, you'll find some mitoses. Okay, so scattered mites, scattered hyperchromasia. There's usually perineural invasion. If you get a big deep sample, but on a shave, you won't usually see that. But the lymphocytic aggregates are helpful. And telling apart, neurofibromas can have scattered atypia. Telling a neurofibroma with atypia apart from a desmo is one of the hardest differentials. There's different stains. None of them, in my opinion, are totally reliable. We've occasionally had to tell people to re-excise, and we're not sure if it's a neurofibroma or a desmo, but that's a huge differential. Totally benign, totally malignant. These are usually like 15 or 20 millimeters deep when you take them out, but when they're pure desmo, the behavior is much better on a depth per depth basis than other melanomas. Local recurrence is a huge problem. I've seen them grow through the skull, into the dura, outside the brain. Patient still alive, no meds. That's totally a weird, different thing than regular melanoma. It's like it's gone back to its neural crest origin, which is why it only expresses SOX and S100 neural markers and not melanocytic differentiated markers like MART and HMB. Beware desmos. They don't clinically look bad either. They look like scar clinically. So they don't get, the patient doesn't come in. I had one that we published a couple years ago that was a punch biopsy for alopecia protocol. They actually even bisected it horizontally, and it was scarring alopecia due to desmoplastic melanoma. Clinically, a dermatologist thought it looked like alopecia areata or something. That's scary, right? This isn't like somebody who doesn't know what they're doing. Someone who actually knows that this didn't even look like a tumor to them. So that's why it's problematic. So they'll think it's a scar or something. You'll think it's a scar, so it's a false clinicopath correlation. You feel like, oh, it all fits, but it all fits wrong, okay? Be very afraid of desmo. See, I wrote a lot about it because I'm real passionate about it. Klaus Bussam has published some really great papers from Memorial Sloan Kettering about desmoplastic melanoma, which to me are essential reading for DermPath. 2004 American Journal of Surg Path, I think, is the classic one. All right, here we've got a nub, a nodule, a polypoid nodule on the finger or toe, and it's acral skin, and it's dense collagen in the dermis, some dilated vessels, nothing else, very little cellularity. So what's this? Yeah, acquired digital fibrokeratoma, very good. And these to me look almost identical to angiofibromas, periungual fibromas, which are to me like angiofibromas that you see in tuberous sclerosis. So the biggest thing that helps there, I think, is I don't know how to reliably make that diagnosis. If you tell me a person's got multiple little nodules around their fingernail, that's probably periungual fibromas. The other thing is that the sequelae of tuberous sclerosis, the latest thing to develop is the periungual fibromas. Usually the patient already is known to have tuberous sclerosis by the time they start developing those. So, but I used to worry about that. Oh, what if I'm missing this? And then someone published a paper about that, and I thought that was helpful. Acquired digital fibrokeratoma. And if you start seeing more spindle cells and myxoid stuff, you can think of other weird acral spindle things like superficial or digital acral fibromyxoma, and just send it to a soft tissue pathologist at that point if you don't want to mess with it. We're almost done, I think. All right, what's this? I don't remember what this one is. Hopefully I will in a minute. Oh, now I do. Any thoughts? One piece. Beautiful. You don't go straight to high power. For DF on your test, look at 2x, okay? Or whatever they have, 4x at the boards. Probably don't have 2x. The epidermis has hyperplasia, acanthosis, and flattening, blunting of the rete, okay? It's like an invisible force field that the DF is throwing up. The epidermis is trying to grow down to it and then hitting that force field somehow. At the edge, you'll see collagen that gets entrapped. The stain, again, is a little faded on this one, but normally you can see that big collagen bundles entrapped at the edge. Okay, there's your dermal collagen, and see how the little bright pink bundles of collagen are getting wrapped by the cells. Okay, that's helpful. Go around also and look for areas of hemorrhage. If you see areas of blood or hemosiderin deposition, strong point in favor of dermatofibroma. The last thing you should look at is the cytologic features. Do not go to high power. You're going to freak out. You can get big, ugly, scattered cells in dermatofibromas, totally benign. You can have mitoses in dermatofibroma, totally benign. You can have some fat entrapment at the bottom even, totally okay. Oh, look, see, there's some fat involvement there. So I get these sent to me when they entrap the fat, but that's okay. You do have to think about DFSP, okay, dermatofibrosarcoma protuberans, but most of the time you can tell DF and DFSP apart on H&E, not with immunostains. I do occasionally do immunostains to tell it apart, particularly if I have a partial biopsy and I can't see the bottom or the sides. So I lose a lot of those clues that I have about the interface with the collagen and the fat, okay? But fat entrapment is sometimes seen in DFs, particularly big cellular ones like this. This is a cellular DF. Giant cells, foamy histiocytes, Teuton cells, hemosiderin, blood, all favor dermatofibroma over DFSP, okay? Epidermal hyperplasia occasionally can be seen in DFSP, usually not, but I've seen a few cases that had real good epidermal hyperplasia and yet we're still DFSP. The other thing is if you see atypia, it's almost certainly not DFSP. Very, very rare to have pleomorphism in DFSP because DFSP is a translocation associated sarcoma, and translocation sarcomas have monotonous uniform cells. They all have the same DNA problem. They don't have pleomorphism. Pleomorphism is not a feature usually of translocation sarcomas. These do have some tendency to grow back, not necessarily because they're aggressive, but because they're usually superficially biopsied. So you're just taking the top of the iceberg and the rest is left down there and it just keeps growing, okay? Very, very rare cases have been reported to metastasize. Do not put that in your report, okay? Do you tell your patients that get basal cell, oh, well, this could metastasize? No, you don't do that because it's 1 in like 500,000 cases or less, right? Same thing here. I don't think Dr. Weiss, my mentor in soft tissue, said don't go telling people they're going to freak out and do big excisions, and the vast majority of them are benign, totally benign. I do tell people that if a lot of it's left in there, it could recur and they could decide if they want to either follow it or take it out. I personally think it's fine to just follow these. All right, cellular dermatofibroma. Also, these are known as benign fibrous histiocytoma. Cellular fibrous histiocytoma is the same thing as dermatofibroma. And they can even have necrosis, it's okay. This is DFSP. It looks so different, okay? There's a little fat trapping. The last one, this all used to be pristine subcutis landscape real estate, and it's been just totally overrun by DFSP, entrapping, making that honeycomb pattern of fat entrapment here, okay? Classic islands of stranded adipocytes being squeezed in the middle of the process, the tumor. The tumor has some fine collagen in the background. Myxoid change is pretty common in these. It can be extensive sometimes, and those are diagnostically challenging. Usually it's pretty subtle. If you're having a bad day, this looks like a neurofibroma. They're bland spindle cells. They're long and thin. They can be a little wavy. They can have mucinous myxoidy background. Diffuse neurofibromas and trapped fat like this. If you're having a bad day, you can make a big mistake there. So what do? What stain would you do to tell apart diffuse neurofibroma from DFSP? Okay. Factor 13A, patchy, rare. I don't like factor 13A, honestly. I just don't feel like it helps that much. It does usually stain scattered dendritic cells in DFs, and those tend to be absent in DFSP. 34 is good because it's strong diffuse staining in the majority of DFSP unless you have a high-grade fibrosarcomatous version. But the problem is it's so do neurofibromas. 70% of neurofibromas are going to be CD34 positive. So you make a big mistake if you do 34 only. Do an S100 with your 34. That's going to always be negative in DFSP. See, this case actually did have a little hyperplasia of the epidermis with basal pigmentation. So that's a useful clue. And on a test, I would say you see that, call it dermatofibroma. But in real life, I've definitely had a few that I thought, well, it really has a lot of features of DF. But when I looked close, the cells were so bland and so thin and stretched out and spindly, almost neural looking. And that makes me really think, am I sure it's a dermatofibroma, not a DFSP? And in those times, you can do 34, you can do FISH for what's the translocation? 1722 in the genes. Yeah, collagen 1A1 and PDGF beta, platelet-derived growth factor beta. And that's a tyrosine kinase. And like other tyrosine kinase inhibitors sometimes have response and can be used to treat really large DFSPs or those rare cases that metastasize. Doesn't usually cure it, but it can hold it at bay. Okay, and then classically we describe it as having a storiform pattern. In real life, I feel it doesn't always help as much, but storiform is kind of this swirled pattern. This is probably not the best example of it. It's one of those things you have to see a bunch of times and then you're like, that's storiform. I can describe it 100 ways and it won't make sense until you've seen a few of them back to back. You're like, oh, that's storiform pattern. But it doesn't always have it, okay? And DFs can also be storiform. So I feel like it's not terribly helpful. The fat entrapment like that honeycomb pattern, really helpful. And the very bland, thin, stretched out spindle cells are helpful. DFSP. Don't often metastasize, but recurrence is a big problem, and these patients get huge surgeries. I work with a DFSP Facebook patient support group, and the scars these patients get are enormous. So it's not a great cancer to have, even though it doesn't kill people usually. Lots of morbidity, okay? I got a video about that on my YouTube channel too, about working with Facebook support groups. If you're curious about how I do that, you can go watch that. So here's a nodule on the sun-damaged scalp of an old guy or an old woman. Let's not be sexist here, okay? Women can get these too. But what this will be is a red scaly nodule clinically. They're going to think it's a squame. They're going to shave it and transect it across the bottom, and then you go look in high power. And it's going to be like atypia out of control. Big pleomorphic ugly cells, huge mitoses, tripolar mitoses, stick figure mitoses, all the atypia you could want, right? It's going to be real ugly. So what do you do with the real ugly spindled cell tumor filling the dermis in an old sun-damaged person? What's your differential? AFX, atypical fibroxanthoma, everyone's favorite. Okay, what else? Spindle cell squamous cell carcinoma. Yeah, poorly diff squame that's spindled. And what else? Melanoma that's spindled. And occasionally angiosarc can be solid and spindled. Not usually you'll see vascular channels, but I've seen a few that look a lot like an AFX. So I always actually now include a marker to rule out melanoma, SOX or S100. I include P63 or P40 to rule out spindled squam. I usually I'll do a keratin too, but you don't have to do that. And then I include ERG or CD31 for vascular. I don't like 34 as a vascular marker. It's negative in some angiosarcs, and it's also dirty and nonspecific. And then also, I usually will include Desmond because I've seen rare examples of rhabdomyosarcoma in the skin. Quite rare, but quite aggressive. So I'm paranoid. The more stuff I see, the more paranoid I get. So I'm going to be a real problem in 10 years. But I'm married to a psychiatrist, so that will help, I think. True story, I really am. And she's given me permission to use her as a joke in every talk, so there's no HIPAA violations here or anything. So anyway, you do all your stains and they're negative, okay? I don't like any of the other stains like CD10 and pro-collagen. I just feel like they're also non-specific. If you wanted to turn brown, do a Vimentin. Vimentin will turn everything brown. And if you want to know my views on Vimentin, I got a YouTube video about that too. And I'll tell you, spoiler alert, they're not positive views. I do not like Vimentin. I don't think it ever helps. I've never seen it change a diagnosis in any case ever. In all of fellowship and practice. So I don't ever use it in my practice. The first order of business in my lab was to have them cancel using Vimentin. So, but I know some people who do, and that's okay. If you do want something to turn brown, that's your antibody. Pick Vimentin, it'll turn it brown, okay? In any case, but I'm getting old. I've got to have some curmudgeonly pet peeve. So instead of yelling at kids on my yard, I yell about Vimentin on YouTube. So, we all got our thing. How do you tell apart AFX from an undifferentiated sarcoma, entity formerly known as MFH? We don't use that term anymore. It's ancient. We call them undifferentiated pleomorphic sarcoma. They look the same, they stain the same, they have no specific positive markers, but the difference is real important because behavior is different, okay? It's all about the size and depth. If it's a big lesion going down in the subcutis, it is not AFX, it is a sarcoma, okay? And the term that people have recently used, although it's confusing, is pleomorphic dermal sarcoma. The weird thing about that is you only call it that once it invades the subcutis. So I don't know, but I don't write these rules. I'm just telling you. So what I do in my report is I say pleomorphic spindle cell neoplasm, atypical fibroxanthoma versus pleomorphic dermal sarcoma, right in the line, which I'm sure they were like, versus, how can you do? But that makes them read the comments and say, what's this guy talking about? And I say, you got to re-excise this and see how deep it goes. If it's down in the fat on the head and neck of old people, about 30% of those metastasize, behave much more aggressively. AFX, even when they're ugly as sin, if they're confined to the dermis, it's very, very rare to get metastases or aggressive behavior. Either way, you need a wide excision or Mohs with negative margins. But when they go down in the fat, they should be regarded as a fully malignant sarcoma, okay? And some people think that some AFX are actually spindled squames that have dedifferentiated and lost all markers. We have no real good way to prove that. But I think of them as like pleomorphic sarcomas that are just arising in the skin. And when they get big and grow down in the dermis, we call them sarcomas. But I think this is a big problem I see practicing pathologists and dermpaths even make, is they'll say AFX and it's widely transected. And I think it's important to let the dermatologists and the treating physicians know, hey, this could be a little bit more of a problem than your regular old AFX, which a lot of like old school people think, oh, it's a benign, atypical but benign, you know? So it's important for them to know that they got to have the whole thing out. And they're almost always transected just like this. No. It's spamming us in the middle of our recording. Worrisome sign, okay? I think we're down the last couple of cases. If you guys have to leave, you can. I won't be offended. Don't worry. That's something fill in the dermis, huh? Yeah, malignancy. I like that. Malignancy identified. They say rule out melanoma. I say no melanoma identified. Sign out. Boy, my day would go a lot faster. But you're right. And on low power, then malignant cell proof. I'm just teasing you. And I think you're right. To be able to look on low power and say that is bad until I prove it's not is an absolutely essential skill for dermpath. You got to be able to look at low power and think, I need to be worried here. This is a worrisome thing. Know when to worry. And then go spend more time at high power on those cases. You don't have to spend long on this case because look at that. Whoa, you got it. Yeah, it's Merkel. It's got that powdery, fine, salt and pepper, whatever that is, chromatin. See, I don't like any of the old names because they just don't work. Maybe my eyes are wrong, but yeah, kind of fine, powdery, chromatin and the nuclei are all smashed together. There's no cytoplasm, and the growth pattern is really classic here. It's filling up the spaces between the collagen. Kind of the nests are all squished and leaving some of the collagen. You know what other tumor in the skin will do that? Blue atypical cells from low power with reticular dermal collagen kind of left intact and filling in the space. And a few other things could do it, but there's one other thing I always think of. Leukemia cutis grows just like that. From low power, my first guess on that would be actually leukemia cutis. Merkel's are bad news. They occur on the sun damaged head and neck of old folks. If you don't find lymphovascular invasion in a Merkel biopsy, go back and look again because it's almost always there. You may not have it on the biopsy, but on the excision, it'll be there. I had one just the other day that was an excision of an ear, and I was a bunch of lymphovascular. So I went and checked the margin again, which at first glance I thought was negative. And in the background, it looked like little hair buds, but it wasn't. It was little lymphovascular invasion foci all over the margin. I mean, before I signed it out, I saw that, but it's terrifying. Learn from the fear and the mistakes of your attendings. And then when you're in attending, share those mistakes so that your trainees can learn too. And if that saves someone one day from making a mistake, everyone wins there. Ego should never get in the way of patient care. CK20 dot-like positivity, real helpful. Neurofilament also stain these, and I find that to be kind of helpful too. It works pretty well. Neurofilament and CK20 dot-like staining. Other keratins will stain with dot-like pattern too, like pan-keratin, okay? And you can do neuroendocrine markers and all that stuff, but I feel like if I think it's Merkel like this and 20 is positive, done. I sign it out as Merkel cell. Could I be wrong? Maybe 1 in like 10,000 times, maybe. There are other 20 positive neuroendocrine carcinomas, but the idea of one of those showing up as a skin met or a small cell lung showing up as a skin met and 20 positive, it's exceptionally rare. We've seen only 3 cases, I think, of metastatic small cell to the skin. One patient had a known stage 4 small cell, and the other 2 actually were primary diagnoses, which was kind of shocking because it's pretty rare, but we've seen that twice. But they didn't stain with 20. And so that's why once the 20 is negative, then you expand your panel. Include melanoma markers for small cell melanoma, include CK7, TTF1 for lung cancer. You can do neuroendocrine markers. I don't usually use neuroendocrine as first line because some basals and other things will stain with synapto. And then what do? 20 is negative, but synapto is positive, and it's kind of blue. And then you're gonna have to put in your report, well, it might be a basal, but I can't exclude Merkel. And just don't open that box. You'll regret it. You'll ignore me and you'll do it a couple years into practice, and then you'll be like, oh, I shouldn't open that box. Stain yourself into a hole. That's what happens. All right. Because a nodule in the dermis, it happens. You'll see. Just trust me. Nodule in the dermis, reactive. Someone's been scratching it. They got LSC change over top, lichen simplex chronicus. Dermis is filled with what? What is it? Boom, nailed it. Yeah. These huge, massive cells, big nuclei, big nucleoli, a bunch of pink cytoplasm, variable amounts of inflammation. One of the most helpful features that I like is, well, you can there's some area on here that had it really good. Let me look on this one. The color here is a little different. They have 2-toned cytoplasm most of the time, where you'll get like a central zone of kind of a dark purple cytoplasm near the nucleus. And then as you go up to the side, it gets more light pink. Okay, that 2-toned cytoplasm there, you can see purple versus kind of the other cells that are a little pink. That's really helpful, I think, for reticulohistiocytoma. If they have multiple lesions, it's called reticulohistiocytosis, and sometimes associated with gammopathies and debilitating arthritis. And then also, I think that even though these are probably etiologically different, they awfully look a lot like juvenile xanthogranuloma histologically. to me, they are histologically on a spectrum. And what I use is if it's a lot more EOs and a lot of foamy Teuton cells, then I tend to call it juvenile xanthogranuloma. If it doesn't have those things and it looks with that two-tone cytoplasm, then I favor reticulocytoma. If it's a solitary lesion, either way, it's benign, and so that's okay. Okay, a nodule in the dermis, kind of ill-defined, right? It's pink, and it kind of just merges into the surrounding dermis. Again, a little epidermal hyperplasia over top. What kind of cells are these? Yes and yes, both true. True and true. They are spindle cells, and because they are spindle cells that have abundant pink filaments in their cytoplasm, they're probably smooth muscle cells. Smooth muscle and fibroblasts both can run in fascicles, and they're both pink, and so that confuses a lot of people. But if you see the pink is actually stringy filament in the actual cell itself, that's smooth muscle. Fibroblasts lay down collagen in between. And if you kind of move your finger under the scope or flip your condenser, you can see the wavy collagen fibers in between cells. If that's what you're seeing, you're probably dealing with a fibroblastic or myofibroblastic process. Or nerve sheath tumors also lay down collagen. Whereas smooth muscle, you can see a tiny bit of background dermal collagen, but the pink is all in the cell, okay? And if you stain them, what's the best stain for a smooth muscle tumor? What? So I bless you. Yes, Desmond, you're right. Not smooth muscle actin. It stains a bunch of stuff. It'll stain dermatofibromas, myofibroblastic things, but it sounds like it should be the right answer because it says smooth muscle. No, I've seen lots of people misdiagnose things because they're like, well, is actin positive? So it's got to be a leiomyoma. And I was like, no, it does not. I didn't really say that. In my head, I said it, maybe in a little bit more aggressive terms even, but my fellows will never tell. So in any case, you look around, and overall, the cells have pretty uniform nuclei, and you can see the nice fascicles, and some of them are cut long ways, and some of them are coming straight out at us. This 90-degree orientation of fascicles is classic for smooth muscle. And look, it infiltrates the dermis. It's because these are erector pili muscle differentiation. Most of the leiomyomas in the dermis are pilar type leiomyomas, and just like erector pili, they just kind of trickle out at the edges into the skin. If you see marked atypia or mitotic activity, it could be a leiomyosarcoma. Chris Fletcher has made papers saying that if it's in the dermis, even like a really high-grade looking leiomyosarcoma almost never metastasizes or does anything bad. So he suggests we call them atypical intradermal smooth muscle neoplasm. Probably not going to catch on as much because it's not quite catchy enough, but I think his point's well taken. I still call them leiomyosarcoma when they're atypical, but I put a comment that because it's totally confined to the dermis, the chance of aggressive behavior is close to zero. And I cite that publication and say some people think we shouldn't even call them sarcoma, because if the patient goes home and Googles leiomyosarcoma, so any of you derms in the room, make sure you tell your patients, it is not the leiomyosarcoma they will find on the internet, which is all about uterine leiomyosarcoma, which is a totally different story. And deep soft tissue leiomyosarcomas in the subcutis or deeper can metastasize and behave aggressively. Dermal ones do not. But anyway, so if you see, a lot of times people are like, well, but there's a little atypical. Don't worry, because even if it's a leiomyosarc, it's still going to be okay as long as it's in the dermis. So there's not good criteria published though for like how many mitoses are okay. I see things all the time that are leiomyoma that have a couple mitoses. I don't know, and people text me, like my co-residents are like, hey, how many can you have? I was like, I don't know, no one knows. Like, don't worry about it. But they're like, but there's got to be a rule. And I was like, I know, but I don't know what it is. And I've published on this topic, so maybe I should just make up a rule and publish it, right? And then, just kidding. All right. Leiomyoma, pilar type. And in the dermis, in the subcutis, what kind of leiomyoma do you get? They look quite different in the subcutis. They're angio. And basically every other place in the body when you get a smooth muscle tumor, unless it's in a visceral organ that's smooth muscle, or in the dermis, it has to come from vessels, right? Because you got vessels everywhere and they're made of smooth muscle. And so vessels arise out of, the vessel is what gives rise to the leiomyoma. And they're usually in the subcutis on the lower legs, more common in women, painful. And they'll eat like a little donut, in the middle, or a little vessel on the side, and then a big smooth nodule, like a marble, okay? Of smooth muscle, leiomyoma. What's that one? Beautiful. It's a little cup shaped. It pushes down. It's got acantholysis, dyskeratosis, warty D, part of a nutritious, I don't know, something. There's some joke there. Warty D. All right, warty dyskeratoma. And if you have solitary lesions that are not cup-shaped other place in the body, sometimes people call those acantholytic acanthomas or acantholytic dyskeratotic acanthomas. You can see those in the genital region. Just had one of those a couple weeks ago, actually. So it's good to learn all the things that can cause acantholysis and dyskeratosis. Darier's, Grover's disease, warty dyskeratoma, acantholytic acanthoma. You guys can do this. I know it. It's a blue nodule. You could think of spiroadenoma, blue ball in the dermis, right? But someone already is on it, right? Look at all the blood vessels. When you go to high power, there are round blue little cells. They're very uniform, and they form little layers and rows that are wrapping around the vessel. See, that vessel's wrapped. This vessel is wrapped. So this is a glomus tumor. Glomus tumors can mimic adnexal tumors, though. So do keep that in mind as a differential. A lot of people don't think of that. Spiroadenoma, or even occasionally like hydradenomas. I've seen glomus that had pink oncocytic change or clear cell change that looked a lot like a sweat gland tumor. And it's easily solved because they're going to be keratin negative, P63 negative, and positive for what? What are these staying with? What kinds of cells are glomus cells? They're basically modified perivascular smooth muscle, what we call pericytes. So they are true pericytic tumors. That old school tumor called hemangiopericytoma is not pericytic, which is why we've renamed it. And also because we like to rename stuff in soft tissue pathology. It's job security and we have to get published. So anyway, but I think the point's well taken. Hemangiopericytomas are not pericytic. Glomus tumors actually are, and they stain with smooth muscle actin. But they're negative for desmin, and they're negative for all the endothelial markers like CD34 and CD31, and of course negative for keratins. And if you've got a solid nodule with not that many vessels, you call glomus tumor. If there's lots of vascular spaces that are dilated and it looks more like dilated spaces with just a little glomus, you can call it a glomangioma, also known as a glomerulovenous malformation. And some people get multiple examples of those as a familial thing. They inherit it and they get multiple glomangiomas. One useful clue about glomus on H&E, I think you can see it on this one, is if you look at the periphery of the tumor and find a vessel that's leading away from the tumor, you'll see the glomus cells follow along the vessel, follow along the vessel. See, they're still out here. They follow and track along vessels away from the tumor. Really, really useful clue, okay? And there's a spindled kind of variant of glomus that people call myopericytoma. At least that's what my concept of myopericytoma is, like a spindly form of glomus. Okay, so if you hear myopericytoma, that's what that is. Oh, okay. I think I got to give another lecture this afternoon too. Right. We're gonna need some pizza before then. All right. We got a nodule on that, like acral skin, but it's probably down in the deeper. Like you can see, it's like they've taken off the top of the skin and then popped out this nodule. And on acral skin, if you see a nodule like this, if you see a nodule of tumor taken off, not taken off by a surgeon from like the abdomen or something, but taken off by a derm, a nodule of tumor with nothing around it, it's almost always centered in the subcutis. Because if it's in the dermis, they're going to take epidermis and it'll be attached. If it's in the muscle, they're not going to go down underneath the fascia and pop a little thing out and not bring muscle with it. You'll see muscle attached. In the subcutis, sometimes fat's attached, sometimes the fat strips away, but that's a useful clue on tests. Nodule of something that you can see, it looks like the whole thing's shelled out and there's nothing attached to it. Almost always that's a subcutaneous nodule. And if you see little ratty strands of pink dense collagen around it, that's almost always a subcutaneous nodule from the hand or the foot, because the hand surgeons go in there and they just try to pluck that out without damaging anything else. And so things that are on the tendon sheath can push up into the subcutis on acral surfaces and they'll just go pluck it out, okay? So here we've got a nodule, we've got dense collagen in the background, real dense pink. And we've got osteoclastic giant cells, very good. And we have another area here that has the cell I want to show. Let me see if I can find it. These cells, you kind of can appreciate, you can see it better on my screen, but I don't know why I can't see it up here. The actual cells of the tumor are these. They're histiocytoid cells, and they usually have abundant pink cytoplasm and an eccentric nucleus. Oh, wait, there. This guy. See that? It almost looks like a plasmacytoid or even rhabdoid cell where it's got a pink blob of cytoplasm pushing the nucleus out to the side. This is really characteristic of giant cell tumor of tendon sheath. Don't go hunting for the giant cells right away. That's fine and it is a good way to learn them, but there are examples that don't have any giant cells or have very few. And if you don't learn to diagnose these with all of the other features, you'll be in real big trouble when you have a frozen section and there's no giant cells. And they tell you, well, the patient has a history of cancer and they've got a nodule that's hot on PET and you see mitoses and rhabdoid cells and you say probably metastatic carcinoma. You'll go down the tubes because they're often mitotically active and they're hot on PET. So they show up sometimes occasionally in weird sites, like I've seen one in the shoulder or other places in a patient with breast cancer that they were doing PET scans on because they're hot. They show up and then they biopsy it. So it's important to be careful about that, okay? So anyway, because they do look kind of epithelioid and they do often have quite a few mitoses, totally benign still. The giant cells are great when you find them, but learn that the rhabdoid or plasmacytoid histiocytes, the very dense sclerotic collagen in the background, usually hemosiderin is present, and sometimes it'll make like a little ring or a halo. I couldn't find it in this example, but a little ring or a halo around the outside of those histiocytoid cells. And you'll also get little areas that make like little pools that the cells fall apart and the little histiocytes go for a little swim in these little cystic spaces. And if you're real lucky, you'll find foamy xanthomatous histiocytes around the periphery. And that's a really good clue when you find those. So spend some time the next time you see a giant cell tumor tendon sheath, and there's the foamy cell. And look around and learn all those other features, because that will really, you see another one. Look at that rhabdoid, eccentric plasmacytoid nucleus there. Really useful clues. These are common, and when they don't have giant cells, you can be in big trouble if you don't recognize all those other features. Most of the time, you do not get any skin with these. This surgeon was nice and included that top of the skin, because they're rarely ever in the dermis, almost always below subcutis or tendon sheath, okay? I mean, they do always attach the tendon sheath, but that can present as a subcutaneous nodule. So giant cell tumor tendon sheath, the other name for this is tenosynovial giant cell tumor, localized type. And there's a diffuse form of this, which is large and usually in the knee and sometimes villous, and that's called pigmented villonodular synovitis, which derms you don't need to worry about. Paths you definitely do. At a high power, it looks identical to giant cell tumor tendon sheath. They are just two ends of the same spectrum. But those are more problematic because they invade the knee and cause contractures and scarring, and even though they're not malignant, they're problematic. Okay. Look where we are. We got skeletal muscle. We've got squamous mucosa. So we're on the tongue. Good. In the middle, it looks like skin because it's got reactive change, and you've got little nests of atypical looking squamous stuff growing down. So when you're having a bad day, you'll call that invasive carcinoma and get a hemiglossectomy specimen. And then you'll see that there's granular cells filling the dermis or the whatever, submucosa. And that's a bad day when that happens. So you want to avoid that. And always, if you end up doing any oral path, if you think it's a squam on the tongue, check in the whatever the equivalent of the dermal papillae are. I don't know. But those little spaces in between the redi, and make sure that there's not granular cells there, because granular cell tumor can induce a really brisk overlying reactive epidermal hyperplasia, a pseudoepitheliomatous hyperplasia can mimic carcinoma. I feel like more often I see them not do that in real life, but when they do, it's a problem. And so just know that. And the cells have abundant granular cytoplasm, round nuclei, and they tend to kind of make a syncytia. They merge with their neighbor. It's hard to see where one cell ends and the other begins. And another really helpful thing is this. The way they grow out into and they kind of ooze into the spaces between the dermal collagen. See, the collagen bundles are left. It kind of just like that leukemia cutis pattern, although they're not anywhere near as atypical, but they just kind of merge in between the spaces, and they can infiltrate way down even into muscle. They can recur sometimes, but in general, most of them are benign. There are very rare malignant examples. You don't probably need to know that for board's purposes. They're really, really rare. And guess what? Perineural, I won't say invasion, but involvement. I don't know if we can see it here. Yeah, there's the cells, and here's your nerve. Like 90% of cases have it. Do not be afraid. You see it in congenital nevi because they're related to the neuroectodermal stuff. We see that in schwannomas and palisaded encapsulated neuromas, and granular cell tumors are nerve sheath tumors. They just have a very funny appearance. So don't be worried when you see perineural involvement by granular cell tumors. It's a very common and totally benign finding. Marked atypia, mitotic activity, big, huge nucleoli, then you start to get worried, okay? And scattered random atypia, just like for a schwannoma, totally benign and okay, don't worry. And what will he stain with? S100, SOX10, neural markers. They also will stain, what is the granularity of the cytoplasm? Why are they granular? Yeah, lysosomes. And what's the marker for lysosomes? You know it, you just don't realize that you know it. Because then people don't teach it this way, but they should. CD68, people teach it as a histiocyte marker, but it's not. It's a lysosome marker. Histiocytes have lysosomes and they stain, but it stains a bunch of other stuff. It's not a specific histiocyte marker. If it's negative for 68, it's probably not a histiocyte. But if it's positive, it doesn't mean anything. It could be a lot of things. And these are loaded with lysosomes, so they're blazing with 68. I mean, usually you don't need much. You can do just S100 is enough to confirm it. I have one time seen an angiosarcoma that looked essentially identical, although it had a lot of mitoses. We're from a colleague in Brazil that I think Geronimo may know. We haven't written it up yet, but we're going to. We presented at a meeting, but the resident's still thinking about the paper. Granular cell tumor. Always a beauty. All right, these are great. They're great when you can make the diagnosis. See, here's a problem. You get a biopsy like this, and you're like, what is it, psoriasis? Is it a weird SEB? Is it an AK? Well, not really any atypia. Is it a wart? I don't know. It's funny squamous something. Sometimes there'll be fibrosis and inflammation here, and you'll scratch your head and they want a single lesion. And I'll think, I know it's a thing, but I don't know what kind of a thing it is. So it's some weird keratinocytic thing, but it doesn't fit in any of the categories. And then you go to the side and then you find that. What is it? Yeah, corny lamellae, a stack of parakeratosis with some little vacuoles underneath and a little divot in the epidermis. So once you find that, then your diagnosis is done. But in real life, what happens all the time is if you don't see the corny lamella on the section, you'll really scratch your head thinking, like, there's got to be a name for this, but it doesn't quite add up to anything. And then if you find a corny lamella, and if you get a good biopsy, you'll see a corny lamella at this side, and you'll see another one over here, which this case is behaving beautifully. There's a corny lamella. It's like if an old-timey train, like from Back to the Future 3, was going this way and the smoke was billowing out behind it. That's what the corny lamella looks like to me. So if you're into that sort of thing, you can do that. And what my fellow Nathan Lee said, and I'll make him famous for this, is he said, what happens between the corny lamella stays between the corny lamella. And I think he's so right that you get all this wild, weird, crazy changes, inflammation, acanthosis, atrophy, and it's all between the lamella. So it will explain a multitude of things once you find that corny lamella. So porokeratosis, right? And there are some weird forms of it you can read about in your spare time. Boy, it seems like more than 50 cases. Did you add some more? Like, he's in the background, like plugging more cases in. I can tell it. I'm just joking. All right. I think I kept saying we're almost done, but that was like 30 slides. All right, we've got a nodule pushing up here. It's it bulges down, but it's relatively flat across the bottom, doesn't infiltrate. And then we got these. Squamous eddies, these beautiful swirls and whorls of bright pink keratin, and they're not invading down into the dermis. And so I think there's two different considerations when you see this pattern. It could just be, well, what would you think? Could be a squame, but in a squame, usually what I want to see is that stuff invading out into the dermis. In real life, I do struggle on a regular basis. Is it squame or is it one of these other things? Yeah. Irritated seborrheic keratosis will make squamous eddies, absolutely. And one other thing in the follicular family will do it too, which some people think is related to this IFK. So if you see it bulging down into a hair follicle and has squamous eddies, you can call it inverted follicular keratosis. If you think it looks more like just a seb, you can call it irritated seb. I think there's really a lot of overlap there. In real life, I do see on a regular basis some that have glassy kind of atypical stuff, and especially if it's transected, I will sometimes include a comment like, well, there's atypia that I think is reactive, but I can't see the base of the lesion. And if it grows back or you're worried, you can do another biopsy. And that way I'm not obligating the derm to do anything, but I am letting them know, there's some stuff there I can't see. When I see the whole lesion like this and I can see its nice smooth bottom, I would just sign this out as either an IFK or an irritated seb, whichever direction you would want to go with it. And I feel there's a close relationship probably between those two. But the swirling squamous eddies are the sign of irritation in a seb, and they're a common feature also in IFK, inverted follicular keratosis. All right, here we got a thing. It's so beautiful. Oh, I know, isn't it pretty? Epidermodysplasia verruciformis, that's why we call it EDV, because who can say that? And you get big nuclei with cleared out kind of funny chromatin. It's a weird HPV change. So this is basically a form of flat wart. And there's like a growing list of many, many different viral types that can be seen in EDV. And what you tend to get is some para on top sometimes. You get hypergranulosis, a common feature of verruca, of warts. And you get this gray, blue, abundant cytoplasm. It's really vivid when you get on a freshly stained section, but it's this real expanded cytoplasm in the keratinocytes. It's this distinct gray-blue color. If you go Google like EDV or go search on Twitter, I've tweeted about it many times because I like it so much. I have to restrain myself from taking more pictures because I have like 100 pictures of it. I don't need more, but it's really cool. So anyway, it's a form of flat wart. We see it incidentally all the time. If it's the only thing they biopsy, I call it EDV. And if it's in the background of like a nevus or a squame, it's nothing. But some people do have a germline mutation that predisposes them to get this, and they get many, many flat warts all over that all look like this. And those patients have a higher risk of squamous cell carcinoma, particularly if there's sun damage. And we've seen a few syndromic familial patients where both the mom and the daughter had it, and already in their 20s were getting squames and stuff. So it's, and I think anytime you have a flat wart, it's harder to tell. They have more atypia. They have bigger nuclei because of the HPV. So especially if they're real sun damage, to me, it becomes real hard to tell, is this just a funny flat wart or is this a squame in situ? I feel it's a lot harder to judge atypia once you have viral change. And I see squames in the sun damaged skin away from the genital sites that have a viral change like all the time in my practice. Some other people tell me they never see that, but I feel like I see it on a weekly basis. So, but this is classic when you got that gray stuff, epidermodysplasia verruciformis, EDV. And here we've got a crater-shaped lesion, right? It cups down into the dermis. It's got a volcano of keratin in the middle, okay? It invades just a little bit at the edges. So what do you like to call these things? Yeah, this can be considered a keratoacanthoma, particularly if it arose quickly and you can see the whole thing. I was trained to call these squamous cell carcinoma keratoacanthoma type. Other people vehemently disagree with that and are sure these are benign because many times they regress. The big problem I have is A, if I can't see the bottom, and B, if I don't know the whole history, which is almost always the case. So I feel in all of my derms that I work with, treat these like squames. But I have heard, I think Elston and some other people have talked about examples where it was like on the finger and they decided to wait and it regressed on its own instead of, you know, amputating part of the finger, doing something real aggressive. So I do keep that in mind and bring up keratoacanthoma as a type when it's in a sensitive site or something where they may handle it differently. But most of the time, my dermatologists will treat them like squames, okay? They have glassy atypia and they're crater shaped and they're full of keratin. They don't usually have a camptolytic pattern and they don't really infiltrate much at the bottom. If you see it really infiltrating out, I don't like to call that. Or real marked atypia, I don't like to call those a keratoacanthoma. Other things people find useful is the presence of little clusters. Oh, I thought I saw some clusters of neutrophils that get entrapped. And also sometimes elastic fibers from the dermis will get trapped up into the peripheral edges of these lesions. So whether you call it a keratoacanthoma or squamous cell, keratoacanthoma type or whatever, that's what it is. But the classic examples go away on their own. But I'm not totally sure that I can always predict which ones will. All right. Here we got an infiltrative thing. It's little basaloid islands, tadpoles in the dermis, right? So what would you do with this? Good. See, even on this one, which is actually pretty darn morphiiform, but there's still some islands that begin to look more like regular basal. You tend to get more of that myxoid change in the stroma. I feel like these usually are pretty easy to diagnose most of the time. So this is a real good example of morphiiform or sclerosing or just call them all infiltrative pattern basal cell to encompass all of the infiltrative patterns. But morphiiform is another term that's used by many people. Real thin little cords of basal cell invading the dermis. When you see these look for perineural invasion, it's often, I find it on a regular basis, a couple times a month. I feel like it's not on people's radar. They probably don't need like radiation or anything, but they do have to usually get wider margins on it when it takes them longer to clear if they do Mohs. So I usually like to at least comment on it if I find it. All right. That's a big ulcerated nodule, lots of inflammation. Atypical spindle cells, really atypical. They're kind of making fascicles. What do you think? Nodular melanoma is a great thought. Spindle cell melanomas that are nodular often make fascicles. So do leiomyosarcomas. That's another thought. And I definitely have had times where I thought something looked like muscle and it'd be a melanoma because it'll make fascicles and they're kind of plump cells. Spindle squame, AFX, all that stuff, right? So this one would stain with keratin and P40 or P63. So this is a spindle squame. They can be essentially impossible to distinguish unless you have some area that's more differentiated. I can't, as a sarcoma pathologist, I did a whole sarcoma fellowship. I cannot tell you what kind of sarcoma that is by that field. I can't tell you if it's a spindle squame or a melanoma or an AFX or undifferentiated pleomorphic sarcoma or leioma. I can't reliably tell you. You just have to use stains on things like this. And it really does make a difference in behavior. If that's a spindle squame, well, it's not great, but they're going to get around it and they'll be probably fine. If that's a spindle melanoma, that patient's going to have a problem. So it's a big difference. If you're not sure, be sure. Do a stain. A lot rides on that. What's that? You guys nailed it. How'd you know? Hypercellular Antony A, hypocellular Antony B, well circumscribed, got a thin capsule or a lot of times thick capsule around the outside, which is expanded perineurium. And then you get these beautiful palisades, which we call Verricae bodies. All the cells are lining up. People say they look like a picket fence or something like that. But my co-fellow, Toby Foster, who is from rural North Georgia, and he had all these really cute little Southern wisdom sayings. And he's like, well, it looks like if you had a pile of leaves and you took a broom and swept them into two piles, and I was like, Toby, that is the best example of what a Verricae body is. He is like one of the smartest dudes I have ever known. He sounds like he's from the rural South because he is. But the best example of not judging a book by its cover. That guy is wicked smart. So, and he also came up with all these really cool clues. So I learned a lot from having a fellow who was way smarter than me as my co-fellow. And he had also been in practice 5 years in the military. So, but I wasn't nervous at all. I was. But he's like the nicest guy ever. So I still tell that story about Toby because I love the pile of leaves, and I've never heard anyone else say that. And when you look at the Antoni B areas, they can look an awful lot like neurofibroma, real loose Schwann cells that are kind of mixed around. And a scattered pleomorphism and atypia, totally fine in nerve sheath tumors. Neurofibromas can have it, schwannomas can have it, that's okay. Mitoses are usually infrequent. If you start seeing a lot of mitoses, still could be a schwannoma, but you might want to think a little more about it or get a consult just to be sure. I've definitely seen plenty that have had that, but it makes me still a little nervous if I'm not sure. Oh, and the vascular change, there it is. The vessels tend to get this really dense collagen, hyalinization, and fibrin around the edges. You often get abundant hemorrhage. You often get hemosiderin. I've seen people mistake these for weird vascular tumors because they were so bloody and had dilated vessels and they hadn't done an S100. If you've done, there's the hemosiderin right there. If you've done 5 stains or more on a spindle cell tumor and you haven't done an S100 or a SOC stain, you better go back and do an S100, okay? In heme path, you don't have to, but in spindle cell land, S100 should be like on your first tier. You're going to miss melanoma or something bad one day. Okay. A nodule, dermal, hypocellular, bland spindle cells, haphazard, yeah. Neurofibroma, mast cells will be present too. Usually you can find little nerve twigs. Neurofibroma. What do you do with this? Can they solve it? Okay, well, what type? Good. This is the worst possible thing that we've done in the derm path literature. After dysplastic nevus, this is the worst. Is we name something that's totally unrelated, just like something else, okay? This is, I like to call these nerve sheath myxoma. Okay, that's the newer name, and I think it is less confusing. They're a myxoid proliferation of the nerve sheath, and they make multiple nodules that are hypocellular and myxoid, and have bland spindled or stellate cells that are kind of swirling around in that myxoid background. And they usually have collagen in between. The nodules are separated from each other. Sometimes they go down in the subcutis, multinodular. Hand is a good site for them. And if you do S100 in SOCs, they will always be positive, okay? They're true nerve sheath tumors. They probably are like weird plexiform myxoid variants of schwannoma. I've seen a few that have nice palisading like Verrucay bodies, okay? So this is called a dermal nerve sheath myxoma. In the olden days, this was called conventional or myxoid neurothekioma, okay? I know it's confusing. But then later people found things that looked kind of like this but had nodules that were cellular histiocytoid cells. And so they said, well, these are cellular neurothekiomas. But once we got immunoassays, we found out that all those cellular ones are dead negative for S100 in SOCs. They are not neural. We don't really know what they are, but they're something totally different. I do have a video on YouTube that explains this in detail. So you can check that out if you really want that, because all the time I have to explain this and I got tired of typing on Facebook. So I just made a YouTube video and now I keep that link saved on my phone and I just share it when everyone's like, what about the, and I'm like, link, watch the video. There you go. So anyway, to save you from the boredom, it will explain in detail. If it's S100 positive, it's a nerve sheath myxoma or what used to be called conventional neurothekioma. S100 negative is cellular neurothekioma, which despite the name is not at all neural. I don't blame you for being angry about this. It is a deep, deep hurt that we've caused to the world in the future by naming all these things so similarly. Okay, so that's a nerve sheath myxoma. Benign. Oh, I remember now. I was like, what is this? It's a nodule, lymphocytic aggregates with germinal centers. What are these? They're vessels. They're vessels in which the endothelial cells are so big and plump that they've squished the lumen. You can barely even see that there's a lumen in there anymore. If you do stains, you can see. So there's a little tiny lumen, but the vessels have such epithelioid, plump endothelial cells that they've packed the lumens of these little vessels. And in the background, there's a bajillion EOs, and there's brisk lymphocytic infiltrate with some germinal centers even. So what's this? Angiolymphoid hyperplasia with eosinophilia, also known as epithelioid hemangioma, because sometimes they don't have much inflammation and they have those real epithelioid vessels. The classic site is the temple, often arises off of a damaged vessel, like the temporal artery if you like bang your head, and then sometimes you'll see like a damaged vessel wall in the middle and it's growing out of it. So there's been debate over whether it's a neoplasm or a reactive thing. I'm not sure if that's fully satisfied yet, but in any case, it's good to know about because it's got really plump endothelial cells. A couple things that I think that no one told me in training, but in practice, I think this and LYP and bug bite are actually on the differential together. Robust bug bites sometimes have prominent vessels and EOs and can have CD30 positive cells. LYP can have all of those things, and so can ALHE. So I never thought of those things as being on a differential, but in real life, I actually consider those three entities, robust bug bite, ALHE, and lymphomatoid papulosis together and try to parse that out with clinical info. It can be challenging, and CD30 positive cells have been described in bug bite, and I think also in ALHE, reactive immunoblasts that were 30 positive. So that's a nice example of ALHE. Another malignant thing filling the dermis probably. So the question again is, what kind of malignant is it? I mean, you could go a lot of directions with this, huh? Epithelioid cells, round nuclei. I mean, is it a carcinoma? Is it a melanoma? What about now? What is it? Angiosarcoma, very good. This is an epithelioid angiosarc, actually, I think. And they can be quite cellular and very much mimic carcinomas and melanomas, okay? This is a great example, though. These are collagen bundles, and the individual collagen is being completely wrapped and invaded. Every space being lined by malignant endothelial cells. And what happens is you get these floating little collagen bundles that are totally wrapped by endothelial cells. And this is like the form of infiltrating. The channels are so anastomotic that it's just made one huge space. Sometimes the epidermis can lift away. You can have the rest of the dermis move away from sweat ducts and sweat glands because it's such abundant infiltration. So this is what you want to look for. This and infiltrating vascular channels. It can be very challenging in some cases to see. Usually when you look to the periphery of an angiosarc, you can find those areas, and that'll help you make the diagnosis. This is part of why, though, I always include a vascular marker in poorly differentiated spindle or epithelioid things in the skin, particularly in old sun damaged people. These are aggressive. A lot of these patients die. They need rapid treatment, and they need to be handled differently than regular sarcomas. If you get an angiosarcoma patient, send them either to Dr. Ravi at MD Anderson or Dr. Van Tine at WashU. Those are two medical oncologists that have extensive experience with angiosarc, and it's so different from other sarcomas. I actually put that in my report now. People can argue or complain if they want, but I care more about the patient getting the right care right away and getting some chance at doing okay. And no one's complained yet. So I'm in a Facebook group for angiosarc patients too. That's been a very life-changing experience, very sobering experience. It's a bad tumor. But I've met some people who have done well and lived a long time and been essentially cured. So there's hope, right? Angiosarc. What's the gene in radiation-induced angiosarcs? Not on the head and neck. Oh, you guys are savvy. Good job. That's been out long enough that I think it's hot enough to end up on the boards at some point. c-MYC amplification in either chronic lymphedema or radiation-induced angiosarcs, not usually in the the UV exposed old people angiosarc, which is actually the most common ones that I see are on the old people on the head and neck. How about that? What? Yeah, metastatic renal cell. Nests of clear cells in the dermis, vessels in between, real pale cytoplasm, big nucleoli. Always keep renal cell in your differential for clear cell tumors in the skin. One other thing that can kind of make nests of clear cells and be in the dermis. What if I told you keratin's negative and HMB and actin and Desmond are positive? Balloon cell nevus, balloon cell melanoma, you can think of those. Yeah, yes, very rare in the skin, but yes. Highlighted clear cell carcinomas. And also PCOMAs could look potentially like this. And PCOMAs stain with CD10. I don't personally love CD10 very much as a marker because it stains a lot of things. Because it's very non-specific, and it stains PCOMAs too. So for renal cell, the markers I like is like pankeratin, keratin 7, stains most of the renal cells. PAX8 is a great stain for renal cells. That's the one I really go to. And the most important thing, also, if you're thinking about primary clear cell tumors of adnexal origin, doing a P63 or P40 will help you because it's essentially always negative in renal and almost always positive in clear cell adnexal things. I've seen a clear cell hydradenoma that was called metastatic renal cell. It was the clearest clear cell hydradenoma I've ever seen, but then they scanned the patient and their kidneys were negative. So then they sent it for consult, and I was like, oh yeah, it's actually hydradenoma, P63 was positive, and had focal duct differentiation. So it all worked out well in the end, but that probably was not a great experience for anyone involved at the time. So clear cell, this is renal cell that's met to the skin. All right, dermal infiltrate is something. How did you get to that so quickly? Very well done. How did you know? Fried eggs, boy, you got good eyes. There are two types of dermal infiltrate that tend to fill the papillary dermis. Mastocytosis and what? Yeah, Langerhans histocytosis. And what's the easy way, even without cytology? I know fried eggs, grooves, coffee beans, but what on low power can tell you the difference between those two? Usually. Yes, kind of, yes. But there's a reason for that. These cells are totally in the dermis. They are completely respecting, and Langerhans normally live in the epidermis. It's their home. They're just like, hey guys, what's up? And they can go right through that basement membrane somehow and get up into the epidermis because that's where they live. Like in Happy Gilmore, like the ball goes to its home. Okay, this is really dating this video. Now everyone's gonna be like, what movie is he talking about? Because clearly none of you guys have ever seen it. So, wow. Yeah, you guys are like 3 probably. But anyway, the papillary dermis is filled with cells and no violation of the basement membrane. These are mast cells. You can see that they're fried eggs, and at higher power, they'd have little granules. And what stains will stain mast cells? CD117 or c-KIT, leader stain, Giemsa stain. Good, all those things. Tall blue, which is more or less like a variation of on some of those stains, okay? And you can do all this. And mast cell tryptase also will stain these, okay? So what if I did a KIT and all this stuff's positive, but I see scattered KIT positive cells right along the basal layer? So does that mean it's, infiltrating the epidermis? What would that mean? What would positive KIT cells be in? Melanocytes. See, you guys are too. Yeah, melanocytes normally stain with KIT. A lot of people don't know that. And guess what? Metastatic melanoma will stay with KIT, including metastatic melanoma to the GI tract. So don't use KIT by itself for GIST, okay? If you're a general surgery pathologist, use S100 plus KIT, or use DOG1, which is much more specific. But someone much better than me told me they once called something a malignant GIST that was metastatic melanoma. And so use that S100, okay? Important to know those pitfalls. This is mastocytosis. And then clinically, I let them sort out whether it's TMAP, urticaria pigmentosa. When they're real cellular like this, it usually means they're a younger patient. It's probably urticaria pigmentosa or a solitary mastocytoma. But the clinical, I just say mastocytosis and let the clinical sort out. Okay, and if you have cells involved in the epidermis, think of Langerhans. At high power, Langerhans looks quite different from mastocytosis. But we did it! Thank you all for attending, and hopefully that was helpful. Raj, big round for Raj, put this whole thing together. Awesome. You did a great job. Thank you. What says it, like 5 o'clock? Oh, 12:20. It feels like 5 o'clock.
I don't know whether it recorded or not.
We have to go. We have to go on the home screen.
Yeah, that's what I'm. Close this.
My kids won't.
That was awesome.
Thank you.
Awesome.
Thank you so much.
Didn't record.
Oh, awesome.
Stop.
Cyanide?
Yeah.